We cannot hear his voice.
Madam, please unmute yourself.
Aparna, you unmute yourself.
Aditya Dipen, we cannot hear. Can you please see? Dipenji. Dr. Aparna, madam, we can't hear, sir.
Good morning, ladies and gentlemen. I welcome you to the virtual 5th annual conference of the Association of Cytologists from Maharashtra, organized by the Indian Association of Practising Pathology in Pune. The talks by eminent speakers arranged over the next 2 days cover a wide range of interesting topics, and I am sure will be of immense help to one and all. COVID restrictions have eased, and we would have loved to arrange an offline conference where we get to meet friends and colleagues from all over. We get to visit cities which we may not go otherwise for holiday. We get to interact with experts in their fields. But offline conferences are a little easier to organize, more budget friendly, especially for practicing pathologists who can also take care of the practice at the same time. Enjoy the academic feast over the next 2 days. Thank you.
With this address of Dr. Mirashi, we will now like to start the lamp lighting, which is a small little activity. And then simultaneously, once the lamp lighting is done, we will like to felicitate Dr. Usha Saraiya, who is a well-known diva in the field of cytology in our country.
महाकाय सूर्य कोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा.
Now we want to felicitate Dr. Usha Saraiya. Usha Saraiya, madam, kindly accept our felicitations from the Association of Cytologists of Maharashtra and Indian Association of Practicing Pathologists. Dr. Usha Saraiya is a stalwart in the field of cervical cancer and cytology, and I will like to briefly introduce her. Her work has been awarded by the President, Dr. Usha Saraiya is MD, DGO, FIAC, FICOG, FRCOG from UK. Dr. Usha Saraiya is a gynecologist based at Breach Candy, Saifu Hospital, Elizabeth Hospital, Mumbai. She started cytology in her clinic at Kama Hospital in 1970, and over these so many years has developed into an internationally recognized center. Conferred upon with the honorary fellowship by RCOG in 2012, Madam has received awards of a living legend by IFCPC in July 21. Her leadership has awarded her with a leadership award for preventive oncology by SAFOG 2022. She has been awarded with Outstanding Woman Obstetrician and Gynecologist by FIGO in 2003. She has received National Awards of Lifetime Achievement by AOGIN India in September 2017 and has a Lifetime Achievement Award by COXI in January 2020. Dr. Usha Saraiya is a very loving individual, and I got a chance to interact with her very closely over this invitation, and she was very approachable, and I could very easily relate to her and talk to her as if she was my close friend. Dr. Usha Saraiya has a couple of stories to tell, which I really would like to share with all of us. Dr. Saraiya was telling me that she had arranged through the government of Maharashtra, for the government of Maharashtra and for the state of Maharashtra, an event which was a project involving one gynecologist, one pathologist, and one technician from each district of Maharashtra. Each district of Maharashtra was represented by a unit of these 3 people. And these people were called over to her Kama setup, and they were all trained and were enthusiastic by her with working for LBC. And then after all these people were trained, they went back to their original places, and they started a key of skill development and giving back to society. This is one activity, and the other activity is a very interesting one. She had called over all the technicians from the entire state represented in the government, and this activity was to give dignity to the technicians who actually do the work. And Madam trained them. They were very excited. They got respect and dignity for the first time, and a platform to express their own opinions and their thoughts and their intelligence. Not only that, with the loving personality that she is, Madam had arranged for a cruise for them at the Bombay Harbor, and that excited them so much they had tears in their eyes, and that bond remains with her forever, and all of them try and get in connect with her whenever possible. Dr. Usha Saraiya has very affectionately sent her blessings to us in a short video, which I will like to play now. And then we will declare the conference open for the scientific proceedings. Dr. Usha Saraiya, please.
Good morning, everybody. Dignitaries in attendance, residents and members of the Association of Cytologists of Maharashtra and the Indian Association of Practising Pathologists of Pune. I was very happy to see your brochure and to see so many familiar names in the brochure. Dr. Vagodikar, Dr. Neelam Kolte, and of course, my dear friend, Dr. Meru Kamal of Nagpur. They are all wonderfully experienced and energetic people, and I'm so happy that they are here to guide the younger generation. So thank you all for this double honor of felicitating me and also asking me to inaugurate this major conference on the subject. As you know, my journey started in 1965 and I set up my unit of cytology colposcopy in 1970 in Kama Hospital. So I've also completed 50 years like the academy. The scenario of cervical cancer was very grim those days, and incidence was very, very high, and all cases were seen very late, and mortality was unfortunately high. There were very few centers offering anything like a detection test, and there was no chemotherapy on the subject, and very few cancer hospitals were there where radiation could be done. But then ICMR had a very charismatic Director General in Dr. P.N. Vahi, and he had done tremendous work in basic cytology in Agra, and he got all the cytologists together and formed the Indian Academy of Cytologists. And after that, there has been no looking back. IC has steadily improved their performance, given wonderful accreditation for laboratories, conducted regular conferences, started a newsletter and then a journal. And simultaneously in clinical gynecology, urology also, there was a lot of development, and Foxy had a colposcopy centers, detection centers, which were recognized for teaching, and we started training a lot of people. And we also took camps in the rural areas to get a better coverage of our patients. So today we are in a happy position. Our ASR has come down, and there are a lot of tests available, lot of centers available, and a lot of people interested in this subject. But this is not only the screening and vaccination, because that has just started and that has just covered a very small part of our population. The improvement in the incidence of cervical cancer has come because of our social changes, because of improvement in the general health of women, and in having small families and going for hospital deliveries and getting treated for anemia. And luckily, girls are getting educated and they're not married till after the age of 18. So all these things, plus better housing and water supply, has made a difference. But today we have changed a lot in our concept of cervical cancer, and the radical approach came in the 21st century, when it was known that it is a viral disease. And since it is a viral disease, the virologists, immunologists, everyone got informed, the vaccines were available, and because of COVID, everyone is familiar with the role of vaccines, and we are on the verge of having completed the control of cervical cancer program. We are going to launch, we have launched the elimination of cervical cancer, and we hope to achieve it and have no cervical cancer, just like no polio and no smallpox. But to achieve that, we all have a tough task ahead. We have to cover every single woman with screening and every single girl with vaccination, which is not going to be such an easy task for us, but we are organized and we are ready for it. So I feel I would like to congratulate all those who have worked on this subject for so many years, and I hope they continue to do so. And we want to see the reaching of our goal, if not by 2030, very soon after that. And I hope to achieve that goal all over India. It is easy to achieve in urban areas, but it is not so easy to achieve in the rural areas. And before I end, I want to quote a few golden words from Hippocrates, the father of modern medicine, which are worth remembering even today, and more so in the story of cervical cancer. One such sentence is, diagnosis must precede treatment. Treat the whole patient and not her report. And if you have nothing else to offer a patient by way of treatment, you can still offer hope and loving care. So thank you once again, and I have great pleasure in inaugurating this great meeting with learned people, with experienced people, and very brilliant lectures. Let's learn from our speakers. Let's get some new ideas, and let us be inspired by their work to continue with our work. And as always, I would like to say my best wishes are with all of you always, and I'll be happy to receive any of you in my Kama Hospital department if you happen to be in Mumbai. Thank you very much, especially Dr. Joshi, who's taken a lot of trouble to communicate with us. And I'm happy and grateful to all of you. Thank you.
Dr. Bhagyashree, we can start now with the scientific proceedings. I will now request Dr. Bhagyashree to introduce the two chairpersons, and then we will have Dr. Prerna Guleria from Command Hospital speaking on EUS cytology. Dr. Bhagyashree, I hand over the podium to you.
Thank Aparna, and good morning all. We have two distinguished pathologists and cytologists as chairpersons for today's first session. First, I will introduce Dr. Vikas Kavishwar sir. He is professor in pathology, TNMC Nair Hospital, Mumbai. He's consultant surgical pathologist and cytologist at Metropolis, Mumbai, and he is on an executive committee of Association of Cytologists of Maharashtra. After completing his post-graduation, he has mainly worked in nephropathology, cytopathology, and dermatopathology, which are his special interest in pathology. And he has numerous publications to his credit, as well as he is faculty at many conferences, CMEs, and workshops. I welcome Dr. Kavishwar, sir. The second chairperson for today's session is Dr. Anand Bhosle, sir. He is professor and head of Department of Pathology at Symbiosis Medical College for Women, Symbiosis International University, Pune. He has experience in pathology for 25 years. He is a dedicated teacher whose lectures in general pathology, surgical pathology, and hematopathology are cherished by his students. He has been actively pursuing various lines of research and regularly publishing them. He has published several articles in both national and international journals and given talks in various conferences. I welcome Dr. Anand Bhosle, sir. And now we will introduce today's speaker, Lieutenant Colonel Dr. Prerna Guleria. Aparna, can you project her introduction, please? I request chairpersons to please conduct the question and answer session at the end of this lecture. Lieutenant Colonel Prerna Guleria, ma'am, has been working with Army since long. She has served as a medical officer in forward military medical setup in Jammu Kashmir as well as in Rajasthan. She has practiced as pathologist in military hospitals as Tejpur and Yol Cantonment, practiced as an oncopathologist at Army Hospital, New Delhi. Presently, she is serving as classified specialist pathology and oncopathologist at Malignant Diseases Treatment Center at Command Hospital, Pune. She has various awards and decorations to her credit, namely distinction in ENT and JOC INSEE commendation in 2015. She has published many articles in pathology in various journals. I welcome Dr. Colonel Prerna Guleria and request her to please begin her talk.
Okay.
Good morning, everyone. Myself, Dr. Prerna Guleria, bring you greetings from Command Hospital, Southern Command, Pune. At the outset, I would like to thank the organizers for giving me this opportunity to speak on endoscopic ultrasound guided spine aspiration cytology, which is a cardinal topic for any cytopathology field. This endoscopic ultrasound was introduced in 1991 by Peter Billman. And it's a technique which allows the study of human cells obtained through aspiration using ultrasound probes which are attached to endoscopes. They are usually performed after the lesion is detected by other methods, radiological methods. And it has got a diagnostic role in which were difficult nuts to crack. First case is of a 56-year-old male who was operated in a peripheral hospital for acute abdomen. Intraoperatively, the surgeons found a spontaneously healed perforation in the V2 region. Excision of the small bowel was performed and end-to-end anastomosis was done. However, when the patient came to us, he did not possess his histopathology report. A contrast-enhanced CT scan of the abdomen, in addition to the post-op status, showed a 1.5 centimeter SOL in the head of pancreas. His tumor markers CA99 and CA were raised. Upper GI endoscopy revealed a deformed D2, and a PET CT scan showed the SOL pancreas as well as a bowel wall to be FDG average. There were no other sites of metastasis. The second case is of a 37-year-old male. He presented with pain in the right hypochondrium of 1 month duration. His performance score was 1. His CCT of the abdomen showed multiple hepatic SOLs, which were subcentimetric and some were cystic. A 3 centimeter gastrohepatic ligament SOL was also found. The PET scan showed mildly FDG avid lesions of the liver as well as the gastrohepatic ligament. The tumor markers were normal, and his upper GI endoscopy showed a small ulcer in the pylorus with a deformed T2. So we attempted FNAC of the liver lesion. Despite 2 attempts, they were non-representative. A EUS guided FNAC of the lesion from the gastrohepatic ligament was also attempted, which did not reveal any material. The third case is of a 32-year-old lady. She presented with chronic cough, weight loss, and severe bony pains of 2 months duration. Her chest CT scan revealed multiple nodules in bilateral margins, and the largest was around 2 centimeters. The PET scan showed all these nodules to be FDG avid, along with extensive scapulae nets, intestinal, hilar, as well as retroperitoneal. The bronchoscopy and the TBNA were also performed. There was no endobronchial lesion. However, the TBNA revealed poorly differentiated malignancy. What next? So as we proceed with the presentation, we will take up these case scenarios one by one. Let us see the importance of endoscopic ultrasound in pancreatic lesions. So the pancreatic tumors, when they are staged, EUS forms an integral part of diagnosis as well as staging of the pancreatic tumors, because we are able to obtain cytological material under direct visualization, and it is also seen that lesions which are less than 3 centimeters in size have better detection rate. Also, it has been shown that the overall accuracy, sensitivity, specificity, positive predictive value as well as negative predictive value is better for EUS as compared to other radiological modalities of detection such as CT scan or MRI. But it also has false negativity. It has got low negative predictive value. That means the negative result does not completely rule out a malignancy. And routine use is sometimes debatable, especially in those cases where you have a potentially resectable pancreatic mass. Here comes the role of rapid on-site evaluation, which we will discuss later. Few factors which affect the adequacy are the technique which we're using, which depends on the size of the aspiration needle, the technique of FNA being performed, how much pressure we are applying, and also whether we use a stylet or not. It also depends on the technician who is performing the endoscopy, the way the cytological material is prepared, the experience of the endoscopist, and the FNA puncture route that we use. The transdural lesions are more difficult as compared to the transgastric lesion, based on the puncture angle and the relative analytical complexity of the pancreas. So the diagnostic consideration depends on how we prepare the slides and what stains do we use. whether we prepare a cell block or not, or do we take material from liquid-based cytology. The contaminants which can come in EUS guided FNACs of the pancreatic lesions include the gastrointestinal mucosa, the columnar cells which also contain mucin, and the goblet cell, which gives us the static sky appearance as we can see in this photomicrograph. In addition, pancreatic cystic lesions themselves form a difficult nut to crack. Interpretation of paucicellular smears is always tricky, and the interpretation has to be given in the clinical context. For example, if the patient has got liver as well as peritoneal deposits, we should suggest malignancy by lowering threshold. Of course, there is a clinical suspicion of autoimmune disease, and a definite malignancy also cannot be ruled out. We can just call it that atypical cells are seen, which are of uncertain malignant potential. And if there is a high clinical suspicion of malignancy with very scanty cellularity, then we should give it out as a possibility of non-representative sample with recommendation for deaspiration. The commonest pancreatic lesion is a ductal adenocarcinoma. Presence of atypical cells as well as a necrotic background help us in making this diagnosis. The grading of these adenocarcinomas is subjective, and they can vary from well differentiated to moderately differentiated to poorly differentiated adenocytes. So let us come to a first case, which was that of a 56-year-old male who had a pancreatic SOL and who was previously operated for a perforation in the small bowel. So we went ahead with endoscopic ultrasound guided FNAC of the pancreatic mass. The FNAC smears revealed cellular smears which were composed of atypical cells present in sheath as well as in glands at some places. The cells had increased NC ratio with moderate nuclear pleomorphism and prominent nucleoli. Based on these cytomorphological findings, we gave a diagnosis of moderately differentiated adenocarcinoma. Later on, when the histopathology and the blocks of the small bowel resected specimen came to us, we found that the bowel wall was infiltrated by the similar atypical cells which were positive for CK7 and CK19, thereby indicating that they were metastatic deposits of this pancreatic tumor. The pancreatic cystic lesions form 2 to 13% of all pancreatic lesions. They can be serous or mucinous. The presence of a mural nodule or a papilla, it helps in diagnosis. Cystic lesions which are purely cystic are generally paucicellular, and they can be pseudocysts, they can be cystadenomas, or they can be the IBMs. We need a clinical and a radiological correlation to interpret these cystic lesions. The most common ones are the mucinous neoplasms, which form 10% of the cystic lesions. They are generally located in the body or the tail, and they are commonly seen in middle-aged females. They are defined as cyst-forming lesions which are mucin-producing, and they lack a communication with the pancreatic duct system, and they have presence of ovarian-type stroma. They can be with or without dysplasia, and they may progress to carcinoma. In a Leishman-Jeamsa stain, the mucin gives a magenta color appearance, and this is how it appears on Pap stain. The intraductal papillary mucinous neoplasms are generally located in the head of pancreas. They are common in elderly males. On endoscopy, we often find a patulous ampulla which secretes mucin. The mucin can be viscous or thin, and it depends on the connection, whether it is with the main duct or with the branch duct. The cytology is generally cellular, with abundant background mucin, and you have sheets and papillary aggregates of cuboidal to columnar cells, which are filled with mucin. The pancreatic serous neoplasms are only 1 to 2% of all pancreatic tumors. They are commonly seen in elderly females, and the ultrasound shows multiple cystic lesions. The FNA is generally controversial because it has low cellularity and there are high chances of false negative. These are the few images of a pancreatic cystic neoplasm, wherein we can also see hemocellulated macrophages. So to summarize, a mucinous cystic neoplasm, an IPMN, or a serous cystic neoplasm can be differentiated by the location of the lesion, gross features also, and if we can find out whether it's connected with the pancreatic duct. The cellular features I described earlier, and if possible, the use of immunohistochemistry. The other pancreatic lesions which we come across include the neuroendocrine neoplasms, solid pseudopapillary neoplasm, autoimmune diseases, or metastatic tumors. The interpretation has to be done in an appropriate clinical background, especially in case of metastatic tumors. Let us now see the role of EUS in gastrointestinal submucosal lesions. So the EUS is used to characterize the lesion. The lesion can be characterized by examination of the layers, the internal echogenicity, the size, and the relationship of the lesion to the extramural structures. These are some of the few important subepithelial lesions of the gastrointestinal tract. And this is a list which indicates malignancy or endoscopy. So if you have an echogenic foci of more than 3 millimeter and more than 4 millimeter cystic space with irregular border, along with any enlarged lymph node, then they are highly suggestive of malignancy. The micrograph on the right shows a gastrointestinal stromal tumor where the smears reveal tight aggregates of tumor cells with a green background and the nuclei streaming in one direction. The slide on the left, high-grade sarcoma. The cell block reveals spindle cell neoplasm with hyperchromatic pleomorphic nuclei and frequent mitosis. The other gastric submucosal lesions include leiomyoma, where the smears show tumor cells with ill-defined cytoplasmic borders, uniform long spindle nuclei with its own nuclear membranes, highly distributed chromatin, and inconspicuous nuclei. Smears from a pancreatic heterotropia show cytology smears with tightly cohesive clusters of uniform bland-appearing epithelial cells with glandular cytoplasm and oval nuclei. So let us come to our second case, which was a 37-year-old male with multiple hepatic SOLs and a 2 into 3 centimeter lesion in the gastrohepatic liver. Since his previous FNACs were non-contributory, but we weren't reaching anywhere, and the treatment of the patient was not being able to start. So we decided to repeat the EOS along with ROSE this time. EOS smears were highly cellular and they revealed monomorphic cells lying in sheets as well as singly dispersed. These cells were monotonous with round to oval nuclei with salt and pepper chromatin. We stained one of the smears and applied immunocytochemistry. The synoptophysin was positive in all of these cells. So we made a diagnosis of well-differentiated neuroendocrine tumor. However, the grading of the tumor could not be performed due to lack of Ki67 IHC antibodies. The subsequent histopathology of the gastrohepatic ligament SOL revealed a well-differentiated neuroendocrine tumor WHO grade 9. Endobronchial ultrasound has its utility to diagnose lesions of the lung and the mediastinum. The EBUS cDNA helps in the diagnosis and staging of lung cancer, and it helps us in visualization of various lymph node stations. It helps in the diagnosis of hilar or mediastinal adenopathies of unknown etiology, which may be detected on CT or PET examinations. The FNA has a high sensitivity and specificity, and it is useful in many cases, including metastasis, lymphomas, and as well as non-malignant cases like tuberculosis and sarcoidosis. We can also diagnose mediastinal tumors with EBUS cDNA, which have direct contact with the tracheal or the bronchial wall. So EBUS alone may not be able to reach the lower lymph nodes of the tracheobronchial tree. So if we combine EBUS with US and mediastinoscopy, almost all the thoracic lymph node stations can be achieved. EBUS definitely has advantage over conventional tDNA and mediastinoscopy. When we compare it to conventional tDNA, it has the advantage of direct visualization of lymph nodes and access to more lymph nodal stations. And when we compare it with mediastinoscopy, it is less invasive and it has access to hilar lymph nodes. Plus, it can be done only in daycare setting. An adequacy criteria has been laid out for the EBUS guided FNACs of the lymph nodes, the lung parenchymal lesions, as well as the molecular samples separately. So if we are doing the FNAC of the lymph nodes, there has to be abundant lymphocytes or lymphohistiocytic aggregates. And these are the different criteria which have been given to determine adequacy. Coming to the lung parenchymal lesions, again, we have to do a clinico-radiological correlation, and we should be careful in interpreting a sparsely cellular smear as negative. We can which includes broad topics like
David sir, if you can mute yourself.
Sure.
as well as lymph nodes. Using EBUS FNACs can be reached, varying non-small cell lung carcinomas or non-small cell lung carcinomas which are squamous cell morphology. Then they can be small cell carcinomas and non-neoplastic lung etiologies include granulomatous lesions, and we may at times even find fungal hyphae. So we come to a third case, which was that of a young lady with multiple lung nodules and multiple mediastinal, hilar, and retroperitoneal lymph nodes, as well as extensive skeletal nodes. The EBUS cDNA of the hilar lymph node had revealed poorly differentiated malignancy. So these were the smears which we had received, where we can see that the cells are present in sheets and they are singly lying. At places they appear plasmacytoid as well as spindle. They have high NC ratio with prominent neutralized. So our further plan was to attempt immunocytochemistry on these spheres as the biopsy was not achievable during EVIS CBN. So as you can see, the pan-CK immunocytochemistry was positive for these cells as well as the nuclear positivity for TTF1. Therefore, this was a case of non-small cell carcinoma lung favoring adenocarcinoma. Pros or rapid on-site evaluation. This rapid on-site assessment is done to ensure sample adequacy. It has a rapid turnaround time. It reduces repeat endoscopic procedures. It improves quality of smears. And on-the-spot diagnosis is possible at many times, which helps the clinician in making quick management decisions. So, is ROSE a luxury or a necessity? So, this meta-analysis says that the presence of cytopathologists increases the diagnostic accuracy of endoscopic ultrasound guided fine needle aspiration cytology for pancreatic adenocarcinoma. And they had concluded that EUS FNAC is an effective modality for diagnosing the pancreatic ductal adenocarcinomas and solid pancreatic lesions with an increased diagnostic accuracy when using on-site cytopathology evaluation. Similarly, the second meta-analysis also concluded that ROSE was associated with up to 3.5% improvement in adequacy rates for EUS FNA of solid pancreatic lesions. This is our experience with ROSE at our center, wherein we have done ROSE for various lesions of the lung, of the mediastinal lymph nodes, of the pancreas, gallbladder, few abdominal lymph nodes, and GI submucosal lesions also. And we have a decent psychological correlation. Histopathological correlation was not available in all the cases. ROSE has its own share of obstacles. In centers doing EUS, there may be limited cytopathology staffing. It definitely adds to the cost of the procedure, and it also comes with interpretative challenges. In this era of artificial intelligence, EUS is not far behind. Various studies have used artificial intelligence on EUS, and they have compared pancreatic cancers with chronic pancreatitis. Artificial intelligence has been based on deep learning to build algorithms to analyze pancreatic cystic fluids. And also, they have used this to do ROSE during EUS FNACs. In ROSE, a ranking of 1 to 5 has been given, and this ranking has been used in various portions of the slide to achieve a conclusive diagnosis of whether the cytology slide was adequate or not. Artificial intelligence has also been used in conjunction with EVIS, and algorithms have been prepared which will help in distinguishing between granulomas and cancers versus reactive lymphadenopathy. In this era of digital pathology, telecytopathology is also fast gaining momentum, and it has been employed along with EUS FNACs also. In this study by Khurana et al., in an initial study, he had compared telecytopathology with conventional microscopy and had achieved a concordance of around 87%. In a subsequent study, he had used only telecytopathology to carry out on-site diagnosis and reduced the non-diagnostic rate to 2.7% with the use of telecytopathology. So what lies in future as far as endoscopic microscopy is concerned? With the advent of confocal laser microscopy, intravital microscopy of the human gastrointestinal mucosa is done during the ongoing endoscopy, and the fluorescent light detects the area of concern from which the biopsy can be achieved. Steve Jobs has correctly said that great jobs are done by a team of people.
Therefore, before concluding, I would like to thank my team, my colleagues and staff in the Oncology Center, departments of gastroenterology, respiratory medicine, and laboratory sciences at Command Hospital, Pune, who have contributed enormously in this journey of EUS FNACs. Thank you.
For the lucid presentation. Now the forum is open for question answer session. I hope Dr. Prerna ma'am has joined.
Yes, I'm here.
Yes, welcome ma'am here. If anybody has a question to ask, please type it in a Q&A box and the chairpersons will read it to Dr. Prerna ma'am.
I think there is no question answer chat box, any question. I think it was very good. Definitely, this US guided FNA is good invasive technique for diagnosis of GI pathology, hepatobiliary, and mediastinal lesions. Madam, I would like to know the various challenges faced while starting this US guided FNAC during your in your institute. What challenges you face in the beginning?
Actually, sir, EUS FNACs were being done at our center since 2018 itself. I'm talking of only Command Hospital, Pune. And I have joined this institute in 20. When I came, I thought maybe we could start and doing the procedure of rows also over here. So the challenges which we face at times are, the endoscopists, they did not know how to aspirate the sample and how much suction should they apply. So, with our experience of doing FNACs in the lab, I just guided them through it, the amount of negative pressure which you should take. Second challenge we face is because of that long needle. If there is a time lapse in putting the material on the slide and smearing, then most of it gets entrapped in clot. So at those times, we are unable to interpret. So like I got them to get this thing done fast. Me being present in the lab, they also learned how to do it, fast. Thirdly, whatever material was there in the clot or maybe in the needle, we used to then take it in a small, container like the microcentrifuge container, and then process it as a cell block, or maybe even send it for molecular if at all needed. So these were the few challenges. Mainly, it was because of the procedural challenges which we faced in the lab.
Another leading question means as per your experience, whether we shall prefer US guided FNAC or frozen section for early diagnosis?
So frozen sections we could do only if we get a biopsy, sir. And FNAC.
I am asking for early diagnosis. Which one is better? This sensitivity is more than this frozen section. So instead of going frozen section, we can tell oncologist or oncosurgeon to do EUS.
Sir, I would prefer EUS because we are seeing the cytology, sir. In a frozen section, there are a lot of, artifacts because of the freezing artifact which are there, which you may not be able to. And EUS FNACs are like, short procedures. So you can go for it first. That's what I prefer, sir.
Thank you, madam. Thank you.
Thank you, sir.
There are no more questions. Can we have concluding remarks by Dr. Kavishwar, sir? I think he is not there. Aparna, can we begin with the next session then?
Sure, Bhageshri. I would now have the introduction to Dr. Grover given by Dr. Milind Mirashi, the President of IAPP, Indian Association of Practicing Pathologists. And we will have the Grover oration after the introduction of Dr. Grover. She has been a teacher to many of us, a very senior and accomplished cytopathologist from Nagpur.
Ladies and gentlemen, it is indeed an honor and privilege to introduce a luminary, Dr. Grover Mann. Dr. Shobha Grover Mann is a revered teacher for all of us. She was born in Rasalpur, which is now in Pakistan. She did her MBBS from Lady Harden Medical College, Delhi, and her MD in Pathology and Bacteriology from GMC and Nagpur University. She had a luminous undergraduate and postgraduate career. Madam was instrumental in starting and establishing cytology in GMC Nagpur, which was the first institute in Maharashtra after Delhi. She was the professor and head of pathology department and also worked as the dean of GMC. Madam has been the past president of the IC. She was a crucial member in the Committee of Human Resource Development Program for starting new courses for cytotechnologists and cytotechnicians. She has been a member of Scientific Advisory Committee at the Institute of Cytology and Preventive Oncology and a member of Postdoctoral Board of Studies. She was a member and advisor in various committees of the ICMR, the most important being the Steering Committee for Research on Carcinoma Cervix. She had 10 research projects funded by ICMR in the field of infectious disease and cancers. Cytology of lymphomas, thyroid, bone, and cervix were a forte. You name any organ, and she has worked extensively in both cytology and histopathology. She was a research fellow at Vienna Cancer Institute and visiting fellow of International Agency for Research in Cancer, Lyon. As a nominee of the Austrian government, she visited the Sloan Kettering Institute of Cancer, New York, National Institute of Cancer, Bethesda, and the Texas MD Anderson Hospital, Houston. She was a WHO Fellow for Cancer Research in Leukemia and Lymphoma and visited cancer institutes in UK, Europe, and USSR. She was also a UICC Fellow. She won many awards like the ICMR Oration Award, the Best Teacher Award in the state, Cipla Oration, Briganza Advani Oration, and many more. She has 148 publications to her credit in peer-reviewed national and international journals and has been on the editorial board of IJPM and IOC. Madam has taught us the organizing of conferences, workshops, and CMEs because she herself was an organizer of national conferences of ISC and IPM, MACyCON, and of course, director of workshops on immunology and gynec cytology. She also worked hard for screening of cervical cancer in rural population. My introduction is probably the tip of the iceberg. Here is a short presentation on Dr. Grover Mann.
This is a PowerPoint we made on Dr. Grover. It's a bunch of photos that we have and very important events that Dr. Grover has participated in. She has been awarded with the Best Teacher Award and with the ICMR Oration Award in 1990, Cipla Oration Award, Briganza Advani Oration Award, several awards, and a very pioneering cytopathologist and a visionary, an academician. These are her fellowships that she, oh no, this is not good. No, it's not. Yeah. So these are research fellowships. Madam has been, as Dr. Mirashi has just said, she's been to been for training to Sloan Kettering and to Vienna Cancer Research Fellowship and another fellowship in Austria. And this is a nice photo with all our teachers here. Dr. Dravid is here. Has sir joined online? Dr. Vavolikar sir is here. and good old times shows. And that's her teaching experience. This is her staff from the department. And it's like endless. Actually, I had lots and lots of information coming from Dr. Kamal and a few other people on Dr. Grover. And I am, because there is short of time, I just had to compile this into a PPT. So that's Dr. Grover. Now we will have the Dr. Grover oration by Dr. Min N from Singapore.
Thank you, Aparna, for such a nice introduction of Dr. Grover. And I would like to call now the chairpersons of today's main session, Dr. Grover Oration. They are two very hardworking pathologists in Indian Association of Pathologists, Pune, in Private Practitioners, Pune branch. Dr. Aparna Joshi, and Dr. Swapnil Karnik, I welcome you as chairpersons for this session. Dr. Aparna Joshi, after completing her UG and PG from BJ Medical College, received training in neuropathology at University of Toronto, Canada, and then training in cytogenetics in Genzyme Genetics in California and USA. She has huge work experience in surgical pathology and as a neuropathologist over the last 25 years. And she's presently attached to KEM Hospital as consultant histopathologist at Pune. And she is a co-founder of OptraScan, a software company into digital scanners, digital pathology, and healthcare IT solutions. And we are seeing her skills right now. Special interest in development of digital pathology, imaging, and telepathology solutions. Welcome, Aparna. Dr. Swapnil Karnik has also done his PG from BJ Medical College and worked as post-MD at Christian Medical College, Wello for nearly 6 years. His special interest includes renal pathology, oncopathology, immunohistochemistry, and molecular pathology. He is practicing exclusively histopathology in the city of Pune for last 17 years. He is chief histopathologist at Ruby Hall Clinic and visiting fellow at the histopathology department, Cornell Medical Center, New York, USA. He has established MegaVision Labs Private Limited, which offers nearly 100 IHC tests, immunofluorescence panel for renal and skin biopsies, frozen section cytology. MegaVision Labs is NABH accredited also, and he has many publications to his credit. MegaVision has collaborated to establish Pune Institute of Nephropathology, a state-of-the-art center of excellence for diagnosis of medical renal biopsies. So I welcome Dr. Swapnil for today's session. Now, can we have introduction of Dr. Min N from Singapore? She is a very distinguished cytopathologist from Singapore. She is a senior consultant from Department of Pathology, National University Hospital, Associate Professor, Department of Pathology, National University of Singapore. She has various qualifications. She did her MBBS from National University of Singapore and did her FRC PAT from Royal College of Pathologists, United Kingdom. She completed her FRC PA from Royal College of Pathologists of Australia, and she did her fellowship in International Academy of Cytology from there. She has research interest in cytopathology, especially head and neck cytology and lung tumors, the study of molecular markers of diagnostic and prognostic relevance. She has received research award from Singapore Society of Pathology, Becton Dickinson Research Award in 2012. She has been elected fellowship in National University of Singapore, and she has many, many teaching awards to her credit. I now welcome Dr. Min N from University of Singapore to give Dr. Grover oration.
Good morning, everyone.
Thank you so much for the kind introduction. I would like to sincerely thank Professor Leena Naik, President of the Association of Cytologists of Maharashtra, as well as the organizing committee for this honor of being able to deliver the Dr. Grover Oration. And today I'm very excited to be able to share with you a little bit about the art of detection in cytology, and what you're about to see are little glimpses of the casebook of a cell detective. So before we start, here's a little nostalgia for you. I was looking through my Google photo spread and looked up the last time I was in India. And in fact, this was in February 2018. Of read and looked for you. I was looking through my Google photo spread and looked up the last time I was in India. And in fact, this was in February 2018. If you notice, my Google photo spread has a vast majority of food photographs, which attest to my love of Indian cuisine. But the reason I was in India, and in fact I was in Mumbai, was because I was participating in the first conference and workshop of the Association of Cytologists of Maharashtra. And this was at Tata Memorial Hospital, and I'm fortunate enough to be back again. So let's look at the word detect. The Merriam-Webster Online Dictionary defines this as to discover the true character of. And when I looked up the synonyms, they include to dig up, discover, dredge, ferret out, hunt down, root out, and track down. So if you think about all these terms and what sort of character traits they will require, I think two words come to mind: curiosity as well as tenacity, to see the case right through to the end. So I think these are two traits that are very important in cytopathologists. So I firmly believe, after having practiced cytopathology for many years now, that cytopathologists are indeed the detectives of the microscopic world. So what makes a good cytodetective? As my favorite Belgian detective, Hercule Poirot, would say, the little grey cells, mon ami. And to me, this is the ability to apply the knowledge that we know for each individual case as an individual, and to have a little bit of imagination, to have a good eye for detail, and of course also to have a strong sense of curiosity in terms of never letting a challenging case go unfollow-up. I also have no qualms asking clinicians silly questions, because I find a lot of the time what they do with their needle, how the needle goes in, is very, very important in cytology. More important than in histopathology, because the route of the needle is pretty variable in cytopathology. Also, Google is your friend, and sometimes I actually do compete with my trainee doctors when we try to find the best reference for a particular strange and interesting sighting down the microscope. If you have been very observant, you may actually have spied that I have signed this with my little signature here. And indeed, drawing is one of my hobbies, and I've drawn my favorite Belgian detective here. So let's look into my casebook. And the first case is entitled The Mystery of the Hidden Primary. This is a 72-year-old man with a left level 2 cervical lymph node. And you can see that it is a pretty cellular smear with these large tissue fragments that are extremely cohesive. Not much going on in the background. If we look on higher magnification, we can see that there is a little bit of clear space between the nuclei. And this tells me that the cells do have at least a moderate amount of rather pale cytoplasm. Again, we can appreciate this pale space between the nuclei. There is a hint of some microarchitecture, which I'm not going to describe here, but just have a look at this, especially in this area in the alcohol fixed smear. And the nuclei are actually relatively uniform and round, and we see a hint of small but prominent nucleoli in some of the cells. So we have cellular smears, we have cohesive sheets of epithelial cells, which are relatively uniform with brown nuclei and pale cytoplasm. What is the next step? I think the most obvious thing now that we are dealing with, if indeed this is from a lymph node, is we know that this is a metastatic carcinoma. So of course, in this day and age, this is not enough. And the next question is, let's try to figure out the primary. So what do we do? And this is something that I'm sure many of us do on a daily basis. The first thing I would like to actually do usually is to check for known history, because this saves time, it saves money, because I don't have to do so many ancillary tests, and more importantly, it saves tissue, because the clinicians may actually want to save tissue for molecular tests, etc. So this patient has no known history of malignancy. He is a non-smoker. We also look at morphological clues, which I will expand more about later. And fortunately, in this instance, we had a cell block. So cell blocks can be extremely useful in this clinical scenario of where's the primary. We want to look at morphology of the H&E, and of course also do our ancillary markers. So here is the cell block, and I believe the architectural patterns that we can see are very apparent here. We can see these repetitive acinar patterns. And here is the cell block in a more close-up picture. We can see that the nuclei are still relatively uniform, small nucleoli and moderately abundant pale cytoplasm. So remember that this is an elderly male. There is an acinar architecture, and hence these morphological features are very helpful to narrow down the IHC. So which IHC are you going to do? And normally I would think about the top 3 stains so that I limit myself, and also because my lab tends to charge in 3s. So that's the reason for this. And so we have 3 diagnostic immunohistochemical markers here. Just going to give you 2 or 3 seconds to think about it before I reveal the answers. So we have PSA, of course, NKX 3.1, and CK7, which is ironically quite helpful in this instance because this is one of the few carcinomas that is negative for CK7. And of course, the answer is metastatic prostatic carcinoma. So this was pretty much a surprise to the clinical team. And at this point, there was actually no investigations done yet. And 2 weeks later, the PSA was done, and it was staggering 973 micrograms per liter. And also, of course, imaging bore out the likelihood of metastatic prostatic carcinoma. Subsequently, a core biopsy was performed of the prostate gland, and it was a Gleason score 8, 4+4 adenocarcinoma. So some quick shots of other mystery primaries. And again, this is always the approach. I'm going to focus more on morphology now. So I'm going to show you a few quick snapshots and see if you can figure out where is the primary. Here again, we have this acinar or rosette formation, rounded nuclei with small nucleoli. And yes, again, we are dealing with metastatic prostatic carcinoma. This is yet another very classical appearing metastatic carcinoma. We see these elongated cigar-shaped nuclei with nuclear palisading, dirty background necrosis. And of course, this tumor is positive for CK20, negative for CK7, positive for vilin, CDX2, and SETB2. This is metastatic colorectal carcinoma. There is, of course, an enteric variant of lung adeno-CA, but this tends to be more frequently CK7 positive and can also be positive for TTF1, which is a helpful clue. And again, the clinical and radiologic features are of utmost importance here. This is another classical picture. We have branching tissue fragments. The cells are polygonal with voluminous cytoplasm, which is quite pale, delicate, kind of bubbly or finely vacuolated. This translates to the appearance of clear cytoplasm on histology. We can also see a delicate branching vascular backbone here, And this is extremely classical for renal cell carcinoma. So here are some of the immunohistochemical stains that can be done on cell block. And here is another one with a startlingly dispersed cell population where the nuclei are quite eccentric in this plasmacytoid appearance. If you're lucky, you may be able to see very prominent nucleoli and sometimes intracytoplasmic fine melanin pigment, but this is often not present. And here is another example of a dispersed malignant tumor. And looking at this, you may actually be fooled into thinking that it could be a hematolymphoid malignancy. However, this is another melanoma, and this is the melanoma that occurs with very small malignant cells. Very often, a clue is that the nuclei are eccentric and there is a little small bulge of cytoplasm. Also, if you look at the nuclei, you can see prominent but small nucleoli. And yet another dyscohesive metastatic malignancy. You can see that these cells have intracytoplasmic lumina, and some of them actually also closely resemble signet ring cells. It's a little droplet inside the cytoplasm. And of course, this is metastatic lobular breast carcinoma. This was quite a spectacular case. And the sample that we're looking at here is actually from the knee joint. So the metastatic lobular carcinoma went to the knee. And in contrast, this is an example of a classical signet ring cell carcinoma, metastatic to the peritoneal fluid, and this primarily was, of course, in the stomach. So a few words on signet ring cells. There are often a lot of these pseudo or fake signet ring cells that we see sometimes in effusions. This is a cell block from a pleural effusion. And in this particular case, the epithelial marker was negative. The mesothelial marker did show a couple of cells with somewhat eccentric compressed nuclei, but the majority of the cells were actually CD163 positive macrophages. So beware, if you see these pseudo or fake signet ring cells, always go back to basics. Look at the nuclear features. You really want to see cytologically malignant nuclei before you call this a signet ring cell malignancy. Here is one of the pictures that I have stolen from this book that I have published recently. And I have a whole series of fake and real signet ring cells. So you can see here that the macrophage, the nuclear chromatin is very fine, the nuclear membrane very smooth. Whereas in lobular carcinoma, the nucleus is more hyperchromatic. There's a prominent nucleolus. There's a little droplet as well in the cytoplasm. And when you compare this with gastric adeno-CA, we can see clearly malignant looking nuclei in these signet ring cells. So always go back to the basics, which is look at the nucleus. And here is yet another tumor which kind of declares its origin, not so much from the cells, which are clearly malignant, but if you look at the background, this very interesting pattern. This is what is termed a tigroid background. And of course, this is a germinoma. Do be careful because this background is not readily appreciated on the PET stain. So I would always advise to do two, both an air dried as well as an alcohol fixed smears if you are dealing with, say, fresh tissue from a mediastinal tumor. And just a little point where, the books always call this tigroid, but personally, I actually feel it looks a little bit more leopardy. So here is a table taken from my book where I have actually tried to note down the specific morphologic features of some recognizable mets. And it's very important for us to know this because sometimes history is not necessarily forthcoming, or perhaps the patient has not even had a diagnosis of a primary yet. Now let's move on to case 2, and this is the case of the mistaken identity. We have a 25-year-old lady with a 2-centimeter right submental lump just below the chin for about 5 months. This is a very hypocellular sample, and we can see that there's this mucoid material, or is it matrix material? Again here, all this material here, but not a lot of cells. At high magnification, there are a few cells here that resemble macrophages. And again, over here, a few cells, a little bit more cohesive. And this is one of the most cellular areas I could find, epithelioid-looking cells, some of them with vacuolated cytoplasm. And in the alcohol fixed smear, not sure if this is trying to be columnar, but some of these cells have eccentric nuclei. And a little cluster of more epithelioid cells here with slight variation in nuclear size and a little bit more dense cytoplasm. So we have hypocellular smears, a few loose groups of epithelioid cells, and abundant background mucin in the submental location. So what are the differential diagnoses? Could this be something completely benign, like a mucocele? Could this be a salivary gland tumor, like a pleomorphic adenoma with mucoid stroma? Could this be suspicious for mucoepidermoid carcinoma? Or maybe this is a strange metastatic carcinoma in a young patient, or the famous other. So let's look at our clinical clues. And upon digging, we discovered that the clinician's impression simply says submental lump. Now, I'm not sure whether this is a phenomenon that you have also come across, but more and more, I see that the clinical diagnosis is quite non-committal. It is essentially just describing the lump. So it's not very helpful here for me. And then I check out the imaging. And again, I'm disappointed because there's no imaging yet. So in the end, I call this a mucin-rich lesion, salivary gland neoplasm. For example, low-grade mucoepidermoid carcinoma is not excluded, mainly because I saw a few clusters of epithelioid cells with just mild variation in nuclear size. So again, this is a little algorithm taken from my book. And here, looking at cystic aspirates in the salivary gland, the first step you really want to do is decide whether we are mucin-rich or non-mucinous. So we go down this route, and because of the possibility of low-grade mucoepidermoid carcinoma, it's always a little bit more concerning when the cystic lesion is rich in mucin. So back to our case, this is actually a server in a restaurant. She's young. She's a non-smoker, and her ENT examination is completely normal. So the clinicians were also quite puzzled, and after 4 weeks, they excised the lump, and this is what it turned out to be. We have quite a bit of dense collagenous fibrosis, adipose tissue, and then we have this bluish material tracking into the collagen. And on higher magnification, we start to see that there are multinucleated giant cells. And in fact, this is not a tumor, it's not an epithelial lesion at all. What it is a reaction to filler, which is hyaluronic acid. And this patient now gave the clinicians a history of hyaluronic acid filler injection some months ago. Hence, my diagnosis was completely wrong. And of course, in hindsight, it's so obvious, right? You can see the multinucleated giant cells even trying to eat up this fake mucin, this hyaluronic acid material. So this approach was actually completely wrong in this instance. Hyaluronic acid can induce a foreign body reaction, and this can sometimes mimic neoplastic parotid cytology or salivary gland cytology, depending on the location. It is relatively non-immunogenic. It's biocompatible with our own hyaluronic acid, hence its use as a filler. However, it is still produced by bacterial fermentation, so there is still potential contamination, and this can still incite a host immune response. This can then present as a lump with or without pain at the site of injection. So on cytology, there are rare epithelioid cells, there are multinucleated giant cells. You can see more and more here, which are so obvious now. The PEP may show this wispy to dense material, and in air-dried smears especially, we may be tricked by this metachromatic material, which can resemble either mucin or extracellular matrix. So these authors published a case, and they actually showed the MRI showing this rather intense masses where the injections were. And I also went to dig up this patient's MRI, and we could see this, which is quite similar to what they have shown.
It's a hyper-intense area in the submental region. So that was mystery solved and lesson learned. And especially in the head and neck location, one has to be very careful. Now let's look at some other funny looking things. Here is an ileal conduit urine. And first of all, I would like to point out that this purplish material is lubricant. It's not mucin. It's a little bit too well defined. And then there is this. So here is actually a little bit of a combination of cases where you can see the same thing over and over again. And I've seen this in a few cases now. They do look a lot like vegetable cells to me. So should I have alarm bells ringing? When we see vegetable-like material, we always worry about the possibility of rectal vesicle fistula with fecal urea. However, usually we would also see other recognizable vegetable material and perhaps some degenerate skeletal muscle, which we didn't see here. Could these be parasitic ova, or could they be some other strange unknown entity? So I did a little bit of searching and Googling, and actually it was my colleague who found out what this was. It was a vegetable cell contaminant from the urostomy bag. There is this adhesive or skin barrier, and sometimes this material actually melts down into the contents of the bag. This contains guar gum, which is of this vegetable origin. These are the pods of the guar plant. And hence they actually come out as these vegetable-looking cells. So if you do see this in an ileal conduit urine, go and check out if there is a similar looking urostomy bag, and this may answer your question. This is also another entity that we quite often see in peritoneal fluids, this kind of fake mucin. If you have seen this before, you will probably recognize this. Instead of being real mucin, more wispy, like you see in this picture, for fake mucin, there are laminations. It is more well defined. And this is also DPAS negative, and that's very helpful. This is also related to the collection bag. Speaking of strange things, here is a non-cytology picture, which I've given you to rack your brains over. I'm going to give you 3 or 4 seconds to think about this, whether you can figure out what this is. And here is a clue. And if it's still not coming to mind, here comes the answer. This is a typical morning breakfast drink in Singapore, known as teh tarik, which is pulled tea. And the reason I'm showing you this is because when we look at cytology alone, we are looking at a tiny snapshot. And this is often high magnification. It can sometimes give us the wrong idea. In fact, if I look at this, to me, it looks a little bit like leather or crocodile skin. But in actual fact, it's completely different. So we really need the benefit of the clinical picture to balance out what we see. Now let's move on to case 3. And this is the case of the sheep in wolf's clothing. Here we have a 32-year-old lady with a 0.7 centimeter liver nodule, which underwent ultrasound-guided FNA. Actually, this is a very, very impressive FNA because of the tiny size of the nodule. And we can see that there is a complex tissue fragment. Perhaps there are some vessels. There are a lot of cells, but at this magnification, we can already see some extremely pleomorphic, large, eye-catching cells. And then the clinician actually volunteers this information, which is very rare. And they mentioned that the patient actually has a history of high nuclear grade DCIS with microinvasive carcinoma. So here is a higher magnification picture showing these very eye-catching, large, polygonal, huge pleomorphic cells. Some of the nuclei appear a little bit more elongated. And over here, again, these large cells, some appear to be binucleated or multinucleated. And we also have some intranuclear inclusions. The cells look equally scary in the alcohol-fixed smears with prominent nucleoli, binucleation, and intranuclear inclusions. So we have branching complex tissue fragments and dispersed cells, which are highly pleomorphic, which exhibit multinucleation and nuclear inclusions, and also some spindle cells. So what on earth is this? Is this a neoplasm? I would probably say yes, it's safe to say that it is. Is it malignant? Well, certainly I'm pretty worried about malignancy because of the degree of pleomorphism. Is it a primary tumor or is it a secondary tumor? Bearing in mind the patient's history of DCIS and microinvasive carcinoma. So the plan for the cell block is let's do some very logical stains. Let's do some breast markers. We'll do a liver marker. We'll do just a very broad cytokeratin and perhaps some sarcoma markers. Sounds good? And here comes the cell block. So unfortunately, because of the cell block, in fact, there was actually only one little tiny fragment of tissue that probably was testable. Kind of had to scrap my big plans, and then there's nothing to do but to take another look. So looking at this again, and this is a video, and we can see here, there are quite a lot of vessels actually running through these tissue fragments. And we have these remarkably pleomorphic cells, also some spindly cells associated with them. And again, we can see the blood vessels, we can see some spindly cells and epithelioid cells, intranuclear inclusions. And so this light bulb moment hit me. It probably has hit some of you, and maybe you knew the answer the minute you saw it right at the start. So here are my 3 mystery stains, and I'll give you a couple of seconds to see if you can figure out what they are. And we have SMA, which is positive. We have HMB45, which is positive. We have HEPA, which is negative. So this was actually an angiomyolipoma. It was an unexpected diagnosis, but thankfully it is not metastatic breast carcinoma. I also did do a cytokeratin, and that was negative. Angiomyolipoma of the liver usually occurs more frequently in women. A small percentage may be associated with tuberous sclerosis. Our patient did not have a history. It is the picoma thought to arise from perivascular epithelioid cells. And the danger is that on imaging, it can mimic a lot of things, benign or malignant hepatocellular tumors, or even METs. On histology, there are 3 components: blood vessels, smooth muscle cells, and fat cells. And we also know that there may be this bizarre pleomorphic epithelioid huge cells on histology. Mitosis can sometimes be seen, as well as extramedullary hematopoiesis. On cytology, similarly, we also see complex tissue fragments with traversing vessels, which we definitely had in this case. I did hunt for adipose tissue, but I did not really find convincing adipose tissue. Perhaps it's because it's such a tiny lesion. The cells can be spindle and or epithelioid with some bizarre, very large epithelioid cells and small lymphocytes and plasma cells in the background. Also, I did hunt for extramedullary hematopoiesis, but could not find it in this case. So differential diagnoses include malignancy such as HCC, which you can see this more trabecular architecture, broad trabeculae with this endothelial cell wrapping, sarcomas, carcinomas, melanomas, and also some benign tumors like lipomas and leiomyoma. So immunohistochemistry is very helpful. Let's move on to case 4, and this is cryptically called the case of the backward clues. This is a 73-year-old lady with a cystic pancreatic body mass. And we can actually see that the needle course did bite a lot of tissue, and these appear to be stromal in nature, yet there are some little bits of epithelial-looking cells attached right at the edges of the stroma. We can see this flat sheet of cells here, and also over here, just coming off the edge of the stroma. On PET, the nuclei are somewhat oval and quite uniform, and they're also round in other areas. We can see that the cells are polygonal, they have quite pale cytoplasm and very bland nuclei. So there's a hypocellular fibrous stroma, we have cuboidal shaped cells, There is mild variation in nuclear size. This is a cystic pancreatic lesion. And a very good clue is to always look for mucin for pancreatic lesions, pretty similar to salivary gland lesions as well, because the neoplastic mucinous cysts confer a significant risk of malignancy. So this is a non-mucinous lesion, and this is borne out by the fluid CEA being very low, only 2 nanograms per mil, which is really quite a helpful clue to the diagnosis. Here is the accompanying core biopsy. Again, we can see this kind of alternation of hypocellular stroma and then these cuboidal cells. Now they are arranged in almost microcystic spaces. You can see a very beautiful microcystic space here. The cells with polygonal shapes and clear cytoplasm. And these cells are actually D-pairs negative. We can see the nice internal positive control here of gastric mucin, whereas they are pairs positive. So they contain glycogen, again, a very useful clue. And this immunohistochemical test actually clinches the diagnosis alpha inhibin positive. This is a serous cystadenoma or serous microcystic cystadenoma of the pancreas. So this is an example where we may actually be more familiar with the histology of such a case. However, the first diagnosis still can be via cytology. So we can reverse engineer what we see or what we know of histology and then try to figure out what the cytology looks like. So in this instance, we have hypocellular stroma and cuboidal cells, which is exactly what we saw on cytology. And the cuboidal cells look very bland as they do on histology. So I think it's very helpful to actually create your own morphological correlates on cytology based on our knowledge of histology for those of us who practice histology, because it strengthens our appreciation of cytomorphology of the less commonly sampled conditions or lesions. So quick shots on a few more reverse histocytologic correlation. This is a pancreatic tail mass. This is the air-dried smear where we see large cells, polygonal cells, and mixed with smaller cells with very coarsely granular cytoplasm. Here is another example of the PET of these large orangophilic cells. And what are these cells? They are actually gastric specialized epithelial cells, parietal cells, and chief cells. So once we recognize this, we will be able to appreciate the morphologic spectrum of EUS FNA better, especially if you're dealing with lesions in which the needle passes through the gastric body. And here is another reverse histocytocorrelation case of a pancreatic head mass. And sometimes we see these bulbous structures in our smears, and this is actually lamina propria from the villi of the small bowel. This is higher magnification. The cells are quite nondescript. In fact, they look exactly the same as they do on histology. And in this particular case, we can even see the little blood vessels within the lamina propria. So this is just something that is useful to take note of so that we don't mistake it for papillary lesions, for example. And here is another reverse histocytocorrelation of bile duct brushing. This is not a spindle cell lesion in the bile duct. In fact, this is cautery artifact. And the clinicians assure me that they actually do use diathermy during the ERCP procedure. Now let's move on to our final case, and this is the case of the double twist. Here is a 54-year-old man with a left cervical lymph node. The ENT exam showed a base of tongue mass. So the clinical working diagnosis was SCC, squamous cell carcinoma of the tongue with lymph node mets. However, the cytology had a different idea. So we have these large cells on a background of small cells. Some of these cells are multinucleated, some are binucleated. We can see quite obviously the larger cells, and your beautiful binucleated cell here. And we even had a little cell block. So the differential diagnosis in this instance, where we see large cells on the background of small cells, of course, one would think of Hodgkin lymphoma, and in fact, we can even see a couple of eosinophils here. But remember, this person also has a base of tongue mass. So could this be a very strange carcinoma? Well, I did do a cytokeratin, which was negative, but these three markers were positive. and they are CD30, CD15, and PAX5. And this is the expected staining spectrum for Hodgkin lymphoma. So I did end up calling this suspicious for Hodgkin lymphoma. And in fact, I noted that the clinicians were going to do a tongue biopsy. So I quickly called them up and said, can you please also excise the lymph node because it looks like lymphoma. And so they did that. And here is what the lymph node looks like. These very large Hodgkin-Reed-Sternberg-like cells. However, if you look in the background, the small lymphocytes were actually somewhat atypical as well, with irregular nuclear membranes and somewhat coarse chromatin. So I'm not a lymphoma expert, but of course this histology case was reported by a colleague who is a lymphoma expert. And these atypical cells in the background were all T cells. You can see that they're actually negative in the large Reed-Sternberg-like cells. They were CD20 negative as well. And these abnormal cells were CD4 positive. They were also positive for CD2, CD5, CD7, and in fact, the Ki67 labeling index was very high, 80%. So this was signed off as a peripheral T-cell lymphoma with Hodgkin-Reed-Sternberg-like cells. It was not a Hodgkin lymphoma, which is a good lesson for me to remember that in these instances, excision biopsy is still helpful because there's actually a whole host of entities that can have Reed-Sternberg-like cells. I'll give you some examples here: anaplastic large cell lymphoma, mediastinal large B-cell lymphoma, T-cell rich large B-cell lymphoma, angioimmunoblastic T-cell lymphoma. This is by no means an exhaustive list. There are other entities, and I'm sure more and more will be discovered. So it is important to keep an open mind. And in these instances, excision biopsy may be helpful following the initial FNAC. So despite the very suggestive history of carcinoma of the tongue with mets to the lymph node, first it was thought to be a Hodgkin lymphoma, and then the double twist was that it was not even a Hodgkin lymphoma, it was a T-cell lymphoma. What an unusual case. So some parting shots. I would like to encourage you all in your practice of cytology to use all the clues that you observe, not to let any go to waste. Always look for microarchitecture in the tissue fragments that you see. You can see this hint of acinar architecture here. The background can also be equally eloquent. For example, lymphoglandular bodies. By the way, we can also see lymphoglandular bodies in alcohol-fixed smears if you look very hard for them. And of course, leopards and tigers in the background. Compare and contrast. If you're lucky enough to find benign and lesional tissue in the same vicinity, always compare them. This is an EUS FNA of the pancreas, normal pancreatic acinar cells. This is a neuroendocrine tumor. You can see how much larger the lesional cells are compared to the benign pancreatic cells. And be relentlessly curious to actively follow up your cases. I tend to enlist my colleagues' help, and I find that they are very, very helpful indeed. They do actively tell me what are the outcomes of my cytology calls. Some cases are a gift. Use them to expand your mental picture archive. This was a beautiful case that I had in an immunocompromised patient of a lymph node in the mediastinum, and you can see these beautiful negative images of bacillary structures. Of course, this is Mycobacterium avium complex mycobacteria. The negative image is due to these hydrophobic interactions so that the stain does not pick up the lipid in the bacterial cell wall. And I firmly believe in keeping an actual picture archive because my brain lacks the space to store all these virtual images. So I put them in my computer instead. If you're not as fortunate as me to have a wonderful camera system attached to your microscope, you can use your mobile phone. In fact, these two pictures are taken with my mobile phone. And this is a very beautiful metastatic cystic papillary thyroid carcinoma with these finely bubbly vacuoles in the cytoplasm of the malignant cells. And this was an epithelioid cyst. And I was just curious when I was preparing for this lecture as to how many photographs I had amassed. And to my amazement, I actually have about 31,000 pictures currently in my archive. It's not because I have a lot of cases, it's because I take way too many pictures per case. So I would like to end off with a quote from Acute Poirot. I do not need to be told I have eyes and they see, I have a brain and it thinks. And essentially, what do you know? Our dear Belgian detective friend is also a cytopathologist. Just to end off, I would like to share with you some interesting e-resources that we have. There's a YouTube channel called PathLab Teacher, and Cytopathology in Practice is one of the playlists that you may want to look at. There's lots of good stuff there. We also have a CytoWeb Instagram channel where we upload cases regularly, and we have a CytoWeb website where we upload mystery cases regularly, especially in the Case of the Month section. And finally, for those of you who may be involved in undergraduate teaching, I would like to share this resource with you. This is PathWeb. This is an online resource that we have developed for undergraduate teaching of pathology. It has a virtual pathology museum, which contains more than 600 scanned virtual pathology specimens. So do feel free to explore and play around with this. This is a completely free resource, and it was created with the idea of sharing it. Thank you.
What an excellent presentation it is. Dr. Aparna?
Yeah, thank you, Dr. Min N. We are running about 12 minutes, little above that late. We are running 15 minutes late. I think we should go directly to introducing the chairpersons. Bhageshri, what do you say?
Yes, I think we can take up the question and answer in the chat box if anybody has, but we should move on to the next session because we are behind the schedule. And I would like to invite the next chairpersons for the next session, Dr. Nimbargi sir from Bharati Vidyapit and Dr. Rasika Gadkari madam. Dr. Nimbargi sir is a head and professor at Department of Pathology at Bharati Vidyapit University Medical College, Pune. And he is a postgraduate teacher for last 15 years, and he has a keen interest in research. He has many national and international papers to his credit, and he has a major role in accomplishing NABL accreditation for the central laboratory. He has also started a fellowship course in diagnostic hematology at his college. I welcome Dr. Rasika Gadkari ma'am also. She is very well known in cytology circles. She has done a MBBS and MD pathology. After that, she has done a diploma in cancer prevention and control and diploma in molecular prevention of cancer from Bethesda, USA. She has done postgraduate diploma in biomedical informatics and business professional program O-level training in MET clinical hepatopathology, and she is a co-opted fellow member of India CLIN, that is Indian Clinical Epidemiology Network. She is presently working as associate professor at AIIMS Nagpur, and she has many publications to her credit. She is also principal investigator in many funded projects and research projects. She was organizing secretary of CytoCon 2016, organizing chairman for MACyCON 2020. She was president of Vidarbha Association of Pathologists and Microbiologists from 2016 and 17, and president of Association of Cytologists of Maharashtra from 2019 and 21. I welcome Dr. Rasika Gadkari ma'am as a chairperson. Can we have now slide, please, for the speaker?
Bhageshri, we have Dr. Jayant Abhyakar Memorial Oration now by Dr. Shubhada Kane. Bhageshri?
Yes, I'm there. Can you project?
We have.
Thank you so much.
Yeah, okay.
So we have a Dr. Jayant Abhyakar Memorial Oration. Dr. Jayant Abhyakar was one of the brightest sparks of the Pune pathology fraternity. He was one of the original members of IAPP Pune and also served as its secretary for a few years. A a very good academician. He was always an active participant in all histology seminars as well as the journal reading sessions. He was pioneer of IHC in Pune and having established a technique at Inlax Budrani Cancer Hospital. He was well known as one of the driving forces of Golwilkar Labs, now AG Diagnostics, and he was instrumental in the modernization and enable accreditation of this lab. He was the organizing secretary of MACyCON by IAPP at Panchgani in 1966 and also an avid photographer and nature lover. He passed away in 2004. Every one of us will remember him as a very good human being and a pathologist. So Aparna, can I have a next slide?
We have Dr. Shubhata Karne speaking live, and we would like to welcome her. We would like to introduce Dr. Karne. We have made a flyer for her, and her biodata is so long it's not fitting into any PowerPoint presentation. Madam, salute to you.
Everybody knows Madam. Actually, there is no need for a formal introduction of Dr. Shubhata Karne, ma'am. She's so well known.
Yeah, true.
Yeah. I welcome Dr. Shubhata Karne, ma'am, to give this oration. And she has worked as an oncopathologist for 35 years at Tata Memorial Hospital and retired as head of Department of Pathology and Cytology in 2018. She has published over 250 scientific articles in reputed international and national journals and various chapters in 15 books on gynecologic cancer cytology and head and neck cancer. She's actively involved in more than 50 IRB-approved clinically oriented projects, and she's a chairperson of National External Quality Assurance Program in Histopathology and Cytopathology from 2018. She has received her training from Stanford Hospital, USA, Massachusetts General Hospital, Boston, St. Mary's Hospital and Sheffield's Hospital, UK, Toronto General Hospital, Toronto, Canada, and University of Pittsburgh Medical Center, Presbyterian Hospital at USA. She has worked in subspecialties in oncopathology like head and neck cancer, gynecological cancer, neuro-oncology, and pancytology. Her key activities are: she has established EBUS and TBNA rapid on-site adequacy testing for image-guided biopsies. She is a founder member of group of gynecological pathologists established in Mumbai in 1998 and was convener of the monthly meetings. She's initiated colposcopic joint meetings, designed synoptic reporting in oncopathology of head and neck cancer and exfoliative cytology, and assisted in establishing pathology and telepathology laboratory at Barshi, Maharashtra. I welcome you, ma'am, for today's oration.
Thank you for that kind introduction. Can you hear me? Am I audible?
Yes, ma'am, very well.
Yes, now let me share the screen. See, the thing comes that you cannot start screen share while the other participant is sharing.
Madam, it is closed from our side.
Oh, okay. But I cannot. Yeah, now it is closed. Okay, it wasn't till then. So now, yes, is PPT visible? Yeah. Hello, Aparna?
Yes, ma'am, it is.
Well, everything is nice, blue background, and lots of pearls on it.
Yeah. So thanks for the introduction, and still good morning, everybody. Without much thanks for inviting me, and let me straight start with the talk. So as you know, the topic was parotid FNAC, pearls and perils. You know, I'm going to talk a little differently this time, not like one topic, but I want to essentially tell you how the cytomorphology misleads you because of the mimics and how you can bring yourself back on the track. That is my main focus, and let's see how. Now, this particular slide I have always shown for all salivary gland FNAC because it is really a most challenging site of all the different areas. Because of these reasons given here, they are rare and many pathologists may be unfamiliar with the cytologic spectrum because they are rare. Morphologic diversity is there. More importantly, there is anatomic ambiguity related to the site of aspirates, and it will become clear in the subsequent talk. Each type of salivary gland tumor is complex because of the presence of different patterns and varied cell types. Above that, there are many metaplastic changes and focal atypia in neoplasia as well as non-neoplastic lesions, which make the diagnosis difficult. There is a morphologic overlap not only amidst the cancer, but also amidst pseudo-neoplastic lesions. Moreover, stromal invasion cannot be identified. So it is very difficult when you are looking at the low-grade lesions. Now, this anatomy I am showing particularly because when we talk about parotid region or parotid masses, you must take into account that you may be dealing with masses arising from the skin, which is infiltrating parotid, or masses from the preparotid node, which are commonly involved and present as parotid lesion. Then comes true salivary gland tumors originating from parotid. Sometimes it also originates from accessory parotid gland. But remember that tumors below the parotid from muscular regions also present as parotid mass because that is the most prominent structure in that area, preauricular area. Rarely, of course, big mandibular tumors present as parotid mass. So when you are reporting on a parotid FNAC, it is important to first make it clear what is the actual site of origin. But it is important to know that not always you get all these details, but you have to really ask for them. Now, this table is really a diagnostic algorithm. I don't want to go through all, though it looks busy. The important step is, what I want to stress is you have to first separate salivary masses from non-salivary. That should be the first step when you are getting any parotid FNAC. Then, of course, when you know it is salivary, neoplastic or non-neoplastic, which may not be always easy, particularly on the low-grade spectrum. Then, when you know it is neoplastic, benign or malignant, and this is how you go further. All malignancies are not carcinoma. They can also be lymphoma and few sarcomas. But commonly, of course, you will get carcinoma, which then you will try to grade on FNAC, low, intermediate, or high grade. On non-salivary slide, you will mainly get nodal as well as soft tissue masses. So I'm going to show you 4 cases to give you example that how you get misled by the parotid FNAC. So here it was 40-year-old male presented with painless swelling in the left parotid region. There was no other significant history or clinical finding. Other glands were normal. No other nodes were there. And USG showed a circumscribed solid lesion in 2 centimeter in diameter involving superficial lobe of parotid. So naturally, clinical diagnosis was parotid tumor and FNAC of parotid gland was done. Luckily, it was ultrasound guided FNAC. It was very cellular. But remember, cellular FNAC is the first hurdle pass, but that doesn't always result in a pinpoint diagnosis. So 3 different images. Here, it looks like more like a non-keratinizing squamous carcinoma. Here, it looks like adenoid cystic carcinoma because of cribriforming and basaloid cells. Well, here, because of this streaking artifact and hardly any cytoplasm, it also looks like a small cell carcinoma. So there were 3 differential diagnoses here. Considering a parotid gland and an adenoid cystic carcinoma was primary on the list. And of course, because it is parotid, basal cell adenocarcinoma also should be kept in mind. So basically the cells were basaloid, they were arranged in nest. There was a focal cribriforming as you can see here. Some areas background was pretty clear. Some areas there were the cells all around, and I'll come to it little later. But note that there was no squamous differentiation. So what do we label? Some more features, similar appearance with background cells. Here you can say I'm pointing out one cell which has the squamoid look, but rest of the places there was hardly any squamous differentiation, no keratinization was seen. So what is the diagnosis? Are we dealing with parotid lesion or it is a non-parotid lesion? The point I want to make is, first you see, when the FNAC comes as parotid, you know, you are tempted to give diagnosis of salivary gland tumors, but you have to be open-minded. And I like the means two important criteria, that curiosity, you should never be complacent that this is a salivary gland tumor. Now look at this photograph. There are a lot of background cells, you know. Though adenoid cystic carcinoma can have a bare nuclei and can also have apoptosis, background is never so busy. Here you do not see the stromal stroma, what you see in adenoid cystic carcinoma, that is those cylinders, okay? And more importantly, you see these particular cells, abnormal cells with polyploidal nuclei, which you never see in adenoid cystic carcinoma. You are seeing here apoptosis, no necrosis, but these nuclei and the busy background makes you think that, is it really adenoid cystic carcinoma? Okay, so these are little things that make you. Then we said, yes, we have to look more and find out some other clues. And this was one additional clue. You know, you can't make out nucleus, but it is like a ghost squamous cell. So that is pointing towards the squamous carcinoma. But the question is, why it is not looking like a typical squamous carcinoma? Yes, because it is comprising basaloid cells with cribriform pattern. With careful search, we saw occasional squamous cell, but not really a true keratinized squamous cell. And the background showed many dissociated cell, necrosis, and apoptosis. So naturally, it led to the diagnosis of metastatic basaloid squamous cell carcinoma within the pre-parotid node. Now remember, basaloid squamous carcinoma has always a DD with high-grade adenoid cystic carcinoma, not grade 1 and 2, where the adenoid cystic carcinoma really becomes more solid and less cribriformness. So because it was basaloid squamous, we suggested primary in the upper aerodigestive tract. When actually they send the FNAC, they have not seen there's oral cavities examined, but scopy is not done. So they are also not aware all the time where the primary is hidden. So we thought it is better to confirm with immunocytochemistry, and we did that with P63. You can also use P40, which showed strong diffuse nuclear positivity, and of course P16 we did because there was no known primary to know whether it was oropharyngeal cancer or HPV associated cancer, and that also came positive. So it was a metastasis of basaloid squamous cell carcinoma. Suggested primary site was upper aerodigestive tract. Maxillary sinus was involved here, and which was actually thought there is a maxillary sinusitis. They never thought in terms of malignancy. And this is how the treatment algorithm changed dramatically from primary parotid carcinoma to metastatic carcinoma from maxillary region. And this is the maxillary biopsy, where again, primary diagnosis was given as adenoid cystic carcinoma grade 3 because FNAC was being investigated. The final diagnosis was not out with immunocytochemistry. And look the similarities, the nest, the focal cribriforming, hyaline. This actually is the hyaline stroma, what you see within the nest. But what you also see is the very high grade, and there is a palisading. Palisading is known to occur in basaloid, but not in adenoid cystic carcinoma. And on maxillectomy, we also saw the abrupt keratinization, which is a hallmark of diagnosis of basaloid variant of squamous carcinoma. The close differential diagnosis on FNAC, of course, or basal cell adenocarcinoma, which are very low grade, and adenoid cystic carcinoma, which is high grade, which only comes in the differential diagnosis. But there are quite a few differences between the two. And this is how you have to always keep in mind when you see solid or nest. Pores also can be seen, trabeculae can be seen with peripheral palisading. These two tumors can show peripheral palisading, but not adenoid cystic carcinoma. These classic cylinders can be seen in adenoid cystic carcinoma, but they will be occasional because you are looking at grade 3. So this is how you can distinguish even basal cell adenocarcinoma from solid SCC, because these will not show necrosis, apoptosis, and sometimes they can show squamous modules, where adenal cystic will not show squamous metaplasia, and basaloid will show abrupt keratinization or keratinized squamous cells. So this is how you should always keep in mind that whenever you say tumor of superficial lobe of parotid, you must always keep in mind metastasis in the pre-parotid node, which the history will not give you the lead. Now we go to the second case, who was a 47-year-old male who presented with right parotid mass. It was there since 2 years. History is also important. 2 years was an important lead. He had noted this mass at the same site 4 years ago, which was operated outside Mumbai at that time, and the final histopathologic diagnosis was not known. Patient had post-operative facial palsy, so we did not know the diagnosis. He could not get the slides. So this is the current imaging, which on CT scan, it shows homogeneous right parotid mass, which was involving deep and superficial lobe. There was poor plane of separation with surrounding structures, and the repeat MRI showed a large lobulated mass involving superficial and deep lobes of parotid, which also involved the masseter and the overlying skin focally. So overlying skin as well as subcutaneous tissue were involved. So again, the impression was carcinoma of parotid region. Now, previous one was a small superficial, whereas here it was superficial as well as deep lobe of this. Now, initial FNAC, they were very frustrating. We couldn't make out anything from this. Entire smear showed this kind of appearance. There were no clusters, there were no clear-cut epithelial cells, and we couldn't make out what it is really. On higher power, it looked like this. Some cells, isolated cells like this, which we could not identify as epithelial or mesenchymal, and this is the background. I suppose this is actually a broken stromal tissue. It is not a mucin, not really a necrotic material, but it is a stroma which is broken down. Of course, FNAC was repeated at the referral institution, which was hypocellular, and what we could see with the cells were like this. Here you can see the cells are spindeloid. They show bipolar nuclei. The chromatin is dispersed. It doesn't look very aggressive, no chromatin clumping. Here you can see some wispy cytoplasm, but there is a lot of a stroma, which appears to be fibrocollagenous. Now I can say fibrocollagenous. Initially, we thought it could also be a stroma produced by the myoepithelial cells. Clinico-radiologically, the mass appeared to be malignant tumor. Repeat FNAC at referral institute showed we were thinking in terms of salivary gland neoplasm composed of spindle cell with some stroma, which could be the fibrillary stroma of myoepithelial cells. So decision was taken of doing total paroidectomy with removal of the tumor. An extended paroidectomy was done, but clinicians sent the tissue for frozen section because it was a very extensive surgery. Of course, we did not get this mass at frozen. We got one tissue, but this is how the specimen looked when paroidectomy was done. Look at this. You hardly see any parotid. It is the skin and underlying muscles. Entire region was involved by this whitish, fleshy, and a glistening, having glistening surface. So this was the gross examination. On FS, we said it is a spindle cell neoplasm. Now we have a visor. We did not mention it is a parotid, but surgery was done later with extended parotidectomy. So we said await paraffin section. So till we got the HE, we really did not have any idea of what this tumor could be. So what is the differential diagnosis of bland looking spindle cell neoplasm in parotid region now? Spindle cell myoepithelioma, inflammatory myofibroblastic tumor, fibromatosis, schwannoma, and solitary fibrous tumor. Of course, besides spindle cell myoepithelioma, which will involve the parotid, schwannoma is the most common diagnosis. In this particular case, we ruled out schwannoma and solitary fibrous tumor because the mass was not circumscribed, not localized. But schwannoma will show similar stromal background, and that always comes in the differential diagnosis. But we were relieved when we saw the H&E section, and I have chosen this a typical H&E section, which is classical for a soft tissue lesion. And you must have identified now on higher magnification, there were fibroblasts, myofibroblasts, and there was abundant fibrocollagenous stroma. There was no myxoid or hyaline myxoid what you see in the salivary gland. So stroma was so striking that it misled us on FNAC, but that became clear on H&E section. So the diagnosis given was fibromatosis because of dense ropey collagen, amidst fibroblastic and myofibroblastic spindle cell proliferation, no atypia, tumor infiltrated the overlying skin, which is its classic feature that though the lesion is non-neoplastic, it is infiltrative. It involves salivary gland, which wasn't apparent also. So this was actually fibromatosis, which was, mistaken for a spindle cell salivary gland neoplasm, actually because it was infiltrative. So diagnosis was myoepithelial carcinoma in mine, not myoepithelioma. I'm sorry, though the cells appeared very blank. So of course, we proved it by immunohistochemistry. Carbonine and vimentin was positive, SN rate, CD34, even P63, DES mean CK and CD10 were negative. And later we did beta-catenin, which is important in fibromatosis. But in this particular case, the morphology itself was quite clear that it was a case of fibromatosis. So this is rare occurrence, but we do come across fibromatosis in head and neck lesion, and that is forgotten by pathologists at times. So these common sites involved in head and neck are supraclavicular, infratemporal, and lateral neck. Though it is benign proliferative lesion, it is always locally aggressive and recurrence rate is high. So that's why this was in fact a recurrent fibromatosis, which sometimes can be very aggressive and clinically strongly mistaken for carcinoma. So remember, not all tumors of parotid region are salivary gland origin, and not all infiltrative tumors are carcinoma. This was the biggest message that we got. And the third important message, of course, do not give pinpoint diagnosis on hypocellular lesion where you are not confident, you are not comfortable of giving diagnosis. It is not wrong to be ambiguous, or it is in fact better to discuss this with your clinician that you do not know what actual diagnosis is, and to lead them for doing further investigations. Now, because it was fibromatosis, the surgery was indicated. Luckily, they have not overdone the surgery. But of course, because there is fibromatosis, maybe post-operative treatment is not necessary. Now, I just wanted to highlight that this is a picture from spindle cell myoepithelial carcinoma that I had. So look at the difference, and this was our FNAC. The stroma was more, the cells were like not looking obviously malignant, and they were not so cellular in the cluster also, as you can see here. So when you have a very limited material, you have to take extra efforts, to come to diagnosis. And if you cannot reach, it is better to disclose that you have not reached the diagnosis on FNAC and biopsy is necessary. In this case, we had suggested to do biopsy, but the clinician was adamant in the sense for them, it was clearly a case of parotid carcinoma. So we go to case 3, which was also a little baffling case. But this case I have been showing in different conferences because I think it is important, and let's see what it is. 18-year-old male who was a college student presented with left parotid swelling with only history of fever. FNAC was done from left parotid region and it was reported as chronic sialadenitis outside. The swelling persisted, it started growing, then patient presented in May 2015 to a referral institution, and there it was detected as a soft tissue mass in left preauricular region, and PET showed avidity with SUV of 8, and there was no other site of increased FDG uptake. As you can see here, it was located in the parotid region. It measures 3.1 by 2.5. MRI was also taken, which shows left parotid enlargement. involving mainly superficial lobe, here also circumscribed nodule, T2 hyperintense. And again, clinical diagnosis was parotid tumor, but here they felt it was low aggressive nature, query pleomorphic adenoma, which is the most common diagnosis, and of course, to rule out low-grade carcinoma. When we saw FNAC, it was just opposite to the clinical diagnosis, because no one can make diagnosis of any salivary tumor or pleomorphic adenoma for that matter. What we saw were lymphoid cells of varying sizes and some loose clusters, as you can see. You know, this FNAC was quite baffling, as I mentioned. The cells were of different sizes, and these, what I marked them, are the larger cells with showing larger nuclei, and nucleoli were seen, but you cannot see that, you cannot say that they are very prominent nucleoli. So at this stage, we did not even know what was the nature of these cells, but of course they were atypical cells and we wanted to follow them. In some other areas, the cells appeared very spindly, you know, and curved, as if they are histiocytic. This one is showing even lymphocytes in the cytoplasm. So we wonder whether it is emperipolesis, and these are really histiocytes of Rosai-Dorfman disease. But other areas did not show this picture, so we did not think of this condition. So that means the FNAC did not give any clear picture. That when the picture is not clear, naturally the list of differential diagnosis is big, starting from chronic sialadenitis, which was given outside, also to rule out granulomatous lymphadenitis. In the referral institute, we mainly thought of lymphohistiocytic lesion. Some of us wonder whether it is follicular dendritic cell tumor, which is very common in head and neck region. But considering his age and the side, whether it is a Hodgkin lymphoma, and of course, Hodgkin's differential comes is anaplastic large cell lymphoma. That means we were basically thinking in terms of atypical lymphoid lesion. And we were aware that this could be originating in pre-parotid node after looking at cytomorphology. But we said this is not sufficient, so we have to go further. And therefore, we started again reviewing the smears, and we saw this sudden nucleomegaly. Now, this is not one observation which may lead to, because this is seen, not so much seen in lymphoma, but it is seen more often in carcinoma, but not really a diagnostic feature. When we saw around, we saw the cells with a good amount, or more than moderate amount of cytoplasm, and that led us to think that this is really an epithelial tumor and not a lymphoid tumor, coupled with this sudden nucleomegaly, which are actually degenerative nuclei, but there are too much of nucleomegaly. There is a clustering also, there is epithelial look. So we started wondering whether it is metastatic carcinoma and not a lymphoma, basically clustering of the cells and abundant cytoplasm. No lymphoma shows abundant cytoplasm. The closest one becomes anaplastic large cell lymphoma. That is why it is said to resemble carcinoma at times, particularly when it is localized to sinusoid. So this is how our diagnosis changed, metastatic poorly differentiated, but we also kept in mind lymphoma. So what is the next procedure? So what carcinoma? Can we consider squamous cell carcinoma? Could be, but less likely because of age. Then adenocarcinoma, again, it did not look like adenocarcinoma, but less likely. Only carcinoma's salivary origin you get in a younger person is mucoepidermoid carcinoma mainly, but it didn't look like. Sometimes acinic cell carcinoma. Could it be neuroendocrine? No. So again, we fumbled here. What could? Then we said we must apply some theory. So when there is a metastatic carcinoma in preparotid region, what could be likely primary site? So as I mentioned, I'm here, I want to show the diagnostic approach. Difficulties are many in salivary gland, but the approach is important. So when any person sees the metastatic involvement, first thing you have to think is, of course, squamous cell carcinoma, not necessarily in this case because he is 18, I'm telling you in general. And what could be the primary sites? Ear, eyelid, or oral cavity and maxilla in head and neck. Then, of course, nasopharyngeal carcinoma, which can present as unknown primary malignancy. You have to add or consider HPV-associated squamous cell carcinoma, which occur basically in oropharynx. and sebaceous carcinoma. Don't forget sebaceous carcinoma in head and neck lesion, where it may be sitting in the eyelid, but it is not identified as sebaceous carcinoma, as it can just present as chronic blepharoconjunctivitis. So these are the three tumors which you basically consider when you deal with metastatic carcinoma, which is less likely to be adenocarcinoma, because if it is adenocarcinoma, it is a different pathway. So now in this case, we ruled out melanoma because of the age and it was non-pigmented. Alveolar rhabdomyosarcoma, these also can present with preparotid node. I have made a list of whatever we have seen at Tata Hospital. We had seen alveolar rhabdomyosarcoma with metastasis to preparotid node, and later on primary was detected in nasal. So there are many possibilities, though rare. So here we narrowed down with these three: nasopharyngeal, HPV associated, and sebaceous carcinoma. And considering the age, we said it is going to be nasopharyngeal, but let's prove it by immunohistochemistry. So first we confirmed that it is carcinoma, EMA and CK. The cells were of two types, epithelial and little bit spindeloid. Whether they were stretched or they were little spindle, it was difficult to say. P63, so yes, that was positive. And then we did one more marker to clinch the diagnosis. Of course, it was EBV LMP. You can do ISH also to prove that it is EBV associated. So diagnosis could be reached as metastasis of nasopharyngeal carcinoma. What was unusual here as metastasis nasopharyngeal carcinoma, though presents as a unknown primary, usually it is a bilateral cervical node metastasis into neck. But here it was unilateral, and that's why even the clinician did not think of nasopharyngeal carcinoma. Otherwise, whenever cervical nodes are presentation in clinical diagnosis, metastatic and nasopharyngeal carcinoma is always included. So this is what the biopsy showed, typical appearance of nasopharyngeal. Notice that in this biopsy, the nuclei are very prominent, but in our case, the nuclei were not that prominent, which I mentioned also. So this is how sometimes FNAC can be really misleading, but you have to go on searching and really crack the case. So what is the diagnostic approach for this? Review the slides from different angles. Don't be complacent that this looks lymphoid and is a young, so it has to be lymphoma. Consider all the theoretical possibilities based on age, sex, and level of the node, as I showed you in the diagnostic approach. Then you narrow down the differential diagnosis and then confirm with specific IC markers. These are all the important steps. Always correlate with whatever investigations are done before and dig the history. In this case, we tried to get the history of whether he was operated before, but we did not get that history. So think about likely primary sites in case of unknown primary malignancy. And I already shown you the three important unknown primary malignancy is in head and neck area. So what I'm trying to say, you must have a systematic approach, and any pathological diagnosis for that matter is really involved is an analytic process and involves series of the steps, and then only you reach diagnosis. The diagnosis are never made on the slide and just one look at the slide. So pathologists have to be a little bit detective, and of course all of us know that and we enjoy doing that. So every parotid FNAC, possibility of nodal lesion should be kept in mind. There are different types of nodal masses I have seen in parotid area involving like tuberculous lymphadenitis. We have seen sinus histiocytosis, follicular dendritic cell tumor. In fact, I prefer to keep this case, so I didn't keep I have FNAC of FDCTO as well, and all of them can masquerade as parotid tumor. So this is an important step. Do not forget nodal lesions. Always think about nasopharyngeal carcinoma in a young patient, whether he gives history or not, and whether radiology is done or not, even if it presents at parotid lesion or unilateral node. Extracting detailed history is an important exercise, and we have to teach it to the residents. Also knowing the level of expected node metastasis. Though tumors are supposed to follow the rules, then they may not always. So pre-parotid node is little unusual presentation, and that's why it foxes clinician as well as pathologists. So with that, we go to case 4, 45 male, presented with carcinoma larynx, biopsy proven squamous cell carcinoma. presented with growth in right glottic region with enlarged right cervical nodes and cystic lesion in right parotid. So FNAC of nodes as well as parotid lesion was done. Biopsy was proven to be squamous carcinoma. Both of them were labeled as metastatic squamous carcinoma, FNAC of neck nodes and parotid lesion. Now we were complacent here and we were happy to call. Now I have just picked up the two areas. Here it looks like degenerated squamoid cells because of that eosinophilic cytoplasm. There was a cystic background and there were some clusters of cells which maybe in a hurry were interpreted as squamous cells. And we'll look at it little later. And the diagnosis was given as consistent with metastasis of squamous cell carcinoma. Cystic metastasis was added in a known primary in the larynx because laryngeal biopsy was reported as keratinizing squamous. Remember, all head and neck squamous carcinoma are not keratinizing, but larynx is the site where you get keratinizing squamous, and keratinizing squamous cell carcinoma has tendency to produce cystic metastasis. Okay. Now, what I want to bring out here is it is simple to write consistent with, but you really should think whether it is really consistent only because of this diagnosis. But our clinicians were not happy. They did not disclose, but they decided because they know that tumors do follow some rules at times. Okay, they may not always. So it was clinically little discordant to get metastasis in the preparotid node. And then therefore he asked for the review. And on review, we realized that the many clusters are in fact flat and not like this. And the cells are not really squamous. They are flat, though polygonal, central nuclei, the nuclei are round. There is no atypia in the nuclei. Look at here. It is not typically squamous. Okay. And you must have recognized here that they are oncocytes and not squamous cells. Now in this area, it was clear. Actually, we had to repeat FNAC. And then in repeat FNAC, these oncocytes were seen much better, clusters of oncocytes. And in oncocytes, you quite often see the binucleated cell. That is what I have marked. So try to distinguish squamous cells from oncocytes whenever in any site in the head and neck region. Somewhere the border is clear. Oncocytes are supposed to give you clear border. In this particular FNAC, the border was not so clear, but so do squamous cells. So there are many similarities. I'm not elaborating on that. Precisely to see that this is not a typical squamous cell clusters, but there were typical squamous cell, as you can see here, and there was a squamous metaplasia, but majority of the clusters were oncocytes showing binucleate cells, flat cells, and clear-cut cytology. So final diagnosis was Wadden's tumor with squamous metaplasia, which mimicked cystic metastasis of squamous cell carcinoma. So we just saw the cluster and the isolated cells, which were actually degenerating apocrine cells, oncocytes, and they were not isolated keratinizing squamous carcinoma cells. So wherever you get salivary gland tumor and oncocytic appearance, this is the differential diagnosis. But don't mistake it for squamous carcinoma, particularly cystic squamous carcinoma. So this one I have specially inserted to discuss about the cystic masses. It is good to see the cystic FNAC also, which is usually hypocellular, but you can carefully look for the background, whether it is mucin or no mucin. If it is a mucin, it is going to be epithelial proliferation. So without any epithelial cells, it becomes mucocills. With epithelial proliferation, you look around for the cells. If there are mucinous and epidermoid, you will get mucoepidermoid carcinoma. And if there are no epidermoid cells, the diagnosis is different. On this side, if the mucin is not seen, look around whether there are lymphocytes. Again, there are very many differential diagnoses. Wadden's tumor comes first. But remember, even actinic cell carcinoma can show cystic chain and can show lymphocytes in the background. But in all these cases, do not forget to diagnose cystic metastasis of squamous cell carcinoma. In our case, we overdiagnose it essentially because of history of keratinizing squamous carcinoma. So FNAC of cystic lesions are really a complex subject. And it is a well-known sources of false negative diagnosis. For that matter, any site cystic lesions are always issue for negative diagnosis, mainly because the cellularity is not adequate. But false positive diagnosis can also occur, and that is an inherent problem. And that is also a pitfall in cystic lesion, as happened in our case because of squamous metaplasia and a history of squamous carcinoma. Marked pleomorphism can be seen as a degenerative change in the cystic area, and also can be seen in case of oncocytic lesion, and which misleads to the diagnosis of squamous carcinoma. So this is the common appearance of the cystic lesion, but if mucin is in the background, your track is different, and if only lymphocytes without mucin is in the background, you go on the different track. Now, there are many mimics of salivary gland tumors. Some of them we have already seen, and I have not shown you only PPS tumors, which include paraganglioma, meningioma, choroidoma, but I have seen all these being mistaken as salivary gland, mainly on the FNAC, later on cleared on excision biopsy. Fibromatosis was the unique case what we saw. So how do you avoid these pitfalls? First stage, of course, is knowing the pitfalls, and then comes the measures to avoid. So see that your FNAC is adequate, that is prerequisite. Ask them to repeat FNAC if it is not adequate. Particularly if the lesion is cystic, see whether there is a residual mass and try to aspirate it again. Multiple sampling, when it is not cystic, multiple sampling is necessary because different parts will have a different appearance. Try to give PAP as well as Giemsa stain, because you have to appreciate the stroma. Hello. Yes, Aparna. 2 more slides. Hello. PAP and Giemsa.
Ma'am, go on. This is somebody, some participant who has not muted themselves.
Yeah, because how much time I have? This is the end of this.
Yeah, ma'am, you finish those 2 slides. That's okay.
Okay. So PAP and Giemsa, I thought that buzzer was that. So to appreciate stroma and mucin, which is very important in salivary gland tumors, not so much in other tumors. Now, in our metastatic carcinoma, you may not see these unless it is adenocarcinoma. And lastly, you cannot forget correlation with radiology and clinical presentation. You know, it is very important. I have added this listening to Min. I had some different words, but I thought curiosity and tenacity, lage raho. You know, if you are, my message, of course, is if there is this little discomfort, or if you are not confident to give diagnosis, don't give that diagnosis. That means there is some mistake, some pitfall, and you know, lage raho and try to sort it out. That is important. Don't just give that diagnosis or make it clear to the clinician that you have not cracked this diagnosis. 2 ways only. So what is the take-home message? Imaging guidance and multiple passes improves allele, but it is the sample adequacy which is basic, and then the experience improves the diagnostic accuracy, especially in the salivary gland FNAC, because it is very much riddled with the pitfalls. So our case 1 showed that high-grade carcinoma are identification easy, but difficult to subtype, difficult to differentiate from salivary and non-salivary tumors. But in this scenario, you should remember metastasis, and particularly in the head and neck area. Case 2, not all infiltrative lesions are carcinoma, like your clinicians were quite confident that this is carcinoma. You must have an open mind. Background material can be misleading, as happened in this case. It was a fibrocollagenous stroma, which we actually interpreted as the stroma of the myoepithelial cells. Spindle cell tumors are difficult basically to distinguish from soft tissue sarcoma. So again, do immunohistochemistry, do repeat FNAC, cell block, and immunohistochemistry will be the answer. Case 3, avoid pinpoint diagnosis if you cannot make, but an appropriate differential diagnosis or subgrouping, objective subgrouping of the lesion also provides clinically useful information. When specific diagnosis cannot be rendered, or when you are not confident to give diagnosis, which was the case initially in that case 3, which was metastatic nasopharyngeal carcinoma, which usually happens when the epithelial neoplasm is of low aggressiveness, if epithelial neoplasm is of salivary gland. Case 4, beware of all cystic lesions. You come to know when you see the FNAC whether it is cystic, and your ultrasound also tells you, and you have to be more cautious because here the differential diagnosis ranges from benign to metastatic, as we saw in the last cases. So FNA is indispensable diagnostic tool in the broad classification on salivary tumors. in distinguishing salivary from non-salivary tumors, sometimes in diagnosis lymphoid lesions and lymphoma, and it really helps clinical management and also surgical planning of salivary gland tumors and parotid lesions which are of non-salivary origin. So how do you overcome the perils of parotid? I showed you the perils and I also showed you the way. To recapitulate, systematic approach, knowledge of immunohistochemistry, thorough knowledge. So you do a cell block and employ relevant immunohistochemistry. Literature search also has to be done sometimes and applied to your case, but not to forget clinico-radiologic correlation, which is very important. And keep on trying hard till you are confident and till you are in comfort zone, because there are so many pitfalls and because you want to have a proper clinical management. With that, I end my talk and thank you very much for patiently listening, even though I cannot see the audience here. Thank you very much once again.
Well, thank you, Kani Madam. That was an excellent lecture. And you are such a erudite speaker. And you exemplified all problems in parotid cytology, especially caused due to morphological overlap from surrounding lesion. And in this respect, I have one question coming in here from Dr. Sachin Sangamnerkar, that when cytology picture is not clear, what legal precautions are to be taken before giving the report? So if you can take this question.
Sorry, repeat. When cytology is not clear?
What legal precautions? He wants to know what are the implications for pathologists if you mistake between benign and malignant, or maybe metastatic and primary. And
I thought I mentioned it, but yeah. So first of all, you should try to develop your FNAC section in your institute, but I know everything is not in your hands, so you'll end up doing. Then you must, first thing is you must mention it in the report. The first line should be whatever suboptimal smears. This should be the first line. When you are not confident, don't give pinpoint diagnosis, group them, epithelial, neoplasm, and like that, and discuss it with the clinician and write in the report case discuss with clinician. That is, in short, I can tell you for variety of the pitfalls, Don't give pinpoint. If you are very confident, even if it is suboptimal and hypocellular, maybe in a solid lesion, in a squamous carcinoma, you can give a diagnosis. Otherwise, you don't give pinpoint diagnosis when you are not happy, and when you are not happy because the cells are suboptimally fixed, smeared, or stained. Ask for repeat. Does that solve? I know asking repeat is not easy, but it is better than getting into legal complication, So yes, as I mentioned, there are other measures I have already given you in the last slide. Systematic approach and other things I have already given. But if you have to report, don't give pinpoint diagnosis. That's it.
Madam, and many in private practice especially have seen give a printed declaration at the bottom that if it does not correlate with clinical and radiological finding, a repeat should be done, or this is not a definitive procedure, cytology. All those things they do write in the cytology report as a format. So maybe this can be included.
Yeah, but instead of standard having that big footnote, I find in a case to case you can write. I always write a comment pertaining to that particular case. It is better than having that standard footnote that we report on whatever sample we get, whatever sample condition. I mean, it is personal choice, but make it as a comment and clearly mention that suboptimal this or hypocellular smear has is a obscuring morphology, is interfering with the proper interpretation. Some such mention has to be there in the comment. Any other question?
Only one question,
Looks like not. Ma'am, thank you very much. It was very encouraging for all of us, very informative, very crisply made presentation and lovely cases. Very good photography. Thank you very much. The conference is warming up because of such good speakers, and all my anxiety has settled now.
Aparna, thanks a lot. I just want to say these are all real cases, huh?
Yeah.
Real problems. So I am not very happy with the photographs, but they are real photographs. You can't show.
Yeah.
Anyway.
Yeah.
Thanks a lot.
Yes, thank you.
Thank you. Thanks.
Bhagyashree, we should proceed for our next speaker and then break for lunch. We may have to cut down on the time that we have given for lunch. Dr. Bardia's talk is to happen now. Will you please introduce Dr. Dravid and Dr. Kalpana Kulkarni?
Yes, thank you, Aparna.
And can you stop screen sharing?
I would like to introduce now the chairpersons for the next session. Two of my favorite professors, Dr. Kalpana Kulkarni and Dr. Dravid sir. Dr. Kalpana Kulkarni is working as Senior Associate Professor at Department of Pathology, PJMC, Pune, and also as an Honorary Registry Superintendent at Pune Cancer Registry, branch of Indian Cancer Registry. She has been invited as faculty at various conferences, national and international, especially Cancer by 2020 in Maharashtra, organized by ICS, and various MACyCONs, as well as she has been invited to Canada for international CME in oncopathology. She has numerous publications in national and international journals. She is a reviewer for different PubMed Index journals. She has received many prizes and awards. She is felicitated by Chief Minister of Maharashtra for participating in various health camps. She was specially felicitated by Dhule IMA, awarded by Dean BJMC for Best Patient Care Specialist. Her field of interest is hematology, breast pathology, and dermatopathology. She is more of a friend to all her PGs than a professor. Welcome, Dr. Kalpana Kulkarni, ma'am. Dr. Nandakumar Dravid sir is a favorite professor of all PG students as well as faculty. He has a huge teaching experience of over 35 years. He has worked as Dean at SBH Government Medical College, Dhule Government Medical College, Aurangabad, BJ Medical College and Sassoon Hospital, Pune. He's been awarded Best Dean's Award in 2008 by Government of Maharashtra. He has over 100 publications in national and international journals and published 3 books. He has guided more than 100 PG students for MD pathology as well as PhD. He is a member of National Knowledge Commission, Government of Maharashtra nominee for MHT CAT, and chairman of Maharashtra chapter of IIPM. I welcome Dr. Dravid sir. Aparna, can we have a slide for the speaker? Yeah, thank you so much. Today's speaker is Dr. Anand Bardia. He is a consultant at Department of Pathology, Tata Medical Center, Calcutta. He has completed his MBBS from Calcutta National Medical College and MD Pathology from PGI Chandigarh. He has worked as PDCC trainee in renal and transplantation pathology under Professor Ritamra Nada at Chandigarh. He is awarded prize in the CME held under aegis of Association of Gynecologists Oncologists of India. He has participated in various state and national conferences and presented posters and oral presentations. He has several publications to his credit, with being a reviewer in few of them. And his current interest includes gastrointestinal pathology, renal and urogenital pathology, soft tissue tumor pathology, neuropathology, and cytopathology. I welcome Dr. Anand Bardia to give his talk.
Good morning, good afternoon, everyone. Am I audible, ma'am?
Yes, you are.
Yes, Dr. Bardia, you are audible.
Yes, there's a little bit of echo, but it should settle.
Is my screen visible to everyone, ma'am?
Yes, yes, absolutely.
Yes, it is visible.
Good afternoon, everyone. And first, I would like to thank the organizers for giving me this opportunity to present a talk on this auspicious conference. And I really want to, I'm spellbound with the ma'am's presentation just before. I hope people will bear with me for a few minutes for this presentation. So the presentation I'll give is on approach to thyroid FNA. And basically in this, I would focus on more on the challenges or the problems which we face while reporting thyroid FNA. So without wasting much of time, it will be mostly, this is the itinerary of my session which I've planned, some brief introduction, and then we should know some the thyroid lesion, how a radiologist looks at a thyroid lesion and what we should know being a cytopathologist and reporting a thyroid FNA. Then I'll brief some discussion about Bethesda system, and then we can, which our main focus is the diagnostic challenges which we face and where to place the lesions. And then a few words about the ancillary tests which are there, which have been developed recently to aid in the diagnosis of a reporting a thyroid FNA. So we all know that thyroid FNA of thyroid is a gold standard for evaluation of thyroid lesions because it gives a final diagnosis in 70 to 80% cases. But there are still 20 to 30% cases remaining which are still categorized and indeterminate for malignancy, and where there is a scope for improvement so that we can give a definite diagnosis and management of the patient can be improved. So before that, we should understand that when a clinician orders a thyroid FNA, what does he expect from us? Basically, his primary objective is to select the patients who require surgery for a neoplastic lesion from those whom he can manage with just clinical follow-up or just some medical treatment, which can be an inflammatory lesion or a functional abnormality. So with this expectation, a clinician usually orders an FNA. So the primary indication is when he sees any nodule which can be palpable or it is detected on ultrasonography incidentally, he needs to know what is the status of the lesion. And sometimes it is usually done for establishing a tissue diagnosis of thyroiditis when the other markers, other clinical parameters and biochemical parameters are not equivocal. So nowadays we have seen that the thyroid lesions are usually, they have an ultrasonography done. So it's worthwhile for a cytopathologist to know what are the ultrasonographic features, because it helps a lot in diagnosing thyroid lesions. So when a radiologist looks at a thyroid lesion, we should look for the location, size. With number of lesions, it is important whether it is single or multiple. Was it a solid lesion or a cystic lesion or a solid cystic lesion? Then echogenicity, is it a isoechoic, hyperechoic or hypoechoic? And whether it is circumscribed or having irregular borders, along with presence of microcalcification, and about the vascularity of the tumor. Because there are some features which actually radiologically which favor a malignant lesion rather than a benign lesion. And radiologists, we all know, have developed a scoring system, that's Stirad scoring, which was initially proposed by Horvath, and then it is subsequently there has been updated and revised. I'm not going into details of that, but as a cytopathologist, at least we should know what are the ultrasonographic features which are suspicious for malignancy. Suppose if we have any hypoechogenic nodule, which is having irregular margins, and if there's presence of micro mixed calcification or there's increased vascularity, all these are features which are suspicious for malignancy from radiology point of view. So having known about the clinical and the radiological features of a thyroid lesion, we then come to reporting of a thyroid FNA. And we all know now, we usually follow the Bethesda system of reporting. And this Bethesda system was introduced, was actually it was the conclusion, it was the fruit of the discussion and the meetings of the experts meeting, which was hosted by NCI, the National Cancer Institute in Bethesda. And its first edition came in 2010. And we should know that this Bethesda system was developed for primarily three main reasons. One is for a uniform terminology. And this terminology will help to give relevant information to the clinician what they should do regarding the management of the patient. And also, it should also, this gives an implicit or explicit risk of malignancy, so that the management of the patient can be further taken care of. So this was the article in the first edition, which was published. Then there were developments, there were studies being done, and the second edition came in 2018, and which basically revised the guidelines for the management of patients. And there was introduction of molecular testing for the first time as an adjunct to cytopathological examination. Apart from this, there was also reclassification of the of the variant of a non-invasive encapsulated variant of FAP, that's follicular variant of PTC, to the popularly known as now NIFT-P, that is the non-invasive follicular thyroid neoplasm with papillary-like nuclear features. So not going to details of the various lesions, we all know that we have 6 categories. More important, which I want to focus, is the recent Bethesda system of classification, the risk of malignancy from the various categories which we give, because it's important that whenever we give a category to one thyroid FNA, what does it's being interpreted by the clinician and how it affects the patient management. So if you give a non-diagnostic category, it is basically repeated with ultrasound nowadays. This is the recommendation which is being given by the Bethesda. Then if it is a benign, it has a very low risk of malignancy. But the main focus is the two categories, is category 3 and category 4, which have an increased risk of malignancy compared to the previous edition of Bethesda. If you see that in category 3, it is 10 to 30%. And now it is said that if you give a category 3, either the clinician will go for a repeat FNA or for molecular testing if it is available. And sometimes if the clinical suspicion is strong and they think that it can be malignant, they can often go for lobectomy as well. For category 4, it's usually the surgery is the usual, the risk of malignancy around 25 to 40%, and this is usually followed by surgery. Category 5 and 6 are usually malignant, and they are usually followed by lobectomy, neototal thyroidectomy. So having looked about the Bethesda categories, now we are coming to our main focus, that is the features, the challenges which you often face while reporting these thyroid FNA. This is basically this is a pic of a tiger's nest from some cafe in Bhutan. So looking at the challenges we face, so basically these are the usually problematic areas which we face. First is foremost is the category 3, which forms the major chunk, and then we have the category 4 lesions. Then sometimes we can see Hürthle cell rich lesions. Then whether it is a lymphocytic thyroiditis or a PTC or a Hürthle cell adenoma carcinoma. Then there are some cystic lesions which can be false negative in cases of cystic papillary thyroid carcinoma. Sometimes lymphoid lesions can be confused with lymphocytic thyroiditis, or it's a non-Hodgkin lymphoma, and some unusual lesions. If time permits, we'll discuss those lesions as well. So starting with category 3, that's the atypia of undetermined significance or a follicular lesion of undetermined significance. It is a major challenge for us, and it is usually, and that's why it is being placed in benign and malignant. The reason is this category, we see features which there is presence of some architectural atypia or some nuclear atypia, but we cannot ascribe, but they are more than that of a benign lesion. But still, they're not sufficient to put them into a suspicious for malignancy or a malignant lesion. So it's a very heterogeneous category. And I'll illustrate some through examples if we see, then I will come back what is the implication of this category. So this is if we see, this is quite a cellular aspirate, and there's some focal microfollicular arrangement along with presence of thick colloid. So the problem is, shall we say it to be a category 2 lesion because it's because there's presence of colloid and there's only focal microfollicular arrangement, or shall we say put it in category 4 because there's presence of microfollicles and it's quite cellular? So there is a dilemma to which category we place it, and usually we keep it in category 3, such kind of lesions. Then sometimes we get a very sparsely cellular aspirate, and then sometimes this Hürthle cells crop up. So is this Hürthle cell is a part of some reparative change, or it's a part of some reactive change in lymphocytic thyroiditis, or is it a part of some neoplastic lesion? That is difficult to say in cases where there's very low cellularity and we see only clusters of Hürthle cells, and they finally end up in the category 3 lesion. Sometimes we can see this some atypical or some naked nuclei in an otherwise a benign lesion. So how to place them, how to interpret them and convey to the clinician that no, it's not benign, but it's not sufficient enough to malignancy. So again, it falls into the category 3 lesion. So these are the various, if we come across these scenarios, we usually place them in an auspicious category. That is, if there's a presence of microfollicles in an aspirate, but it is not sufficient to call it as a follicular neoplasm. If there are Hürthle cells in a very sparsely cellular aspirate, if it's a follicular atypia is seen, but further interpretation is hindered by either the technical quality or the cellularity. Sometimes we can get some nuclear features like some nuclear grooves or some inclusions here and there in an otherwise benign sample. Sometimes some follicular cells can show nuclear atypia. So, and sometimes we can get some lymphoid rich lesions, and we are in a dilemma where to place them. So these categories, all these things come into auspicious category. So now the problem is clinician is giving us giving us with an expectation to classify whether it's a neoplastic or not. And these lesions, we cannot actually offer a direct answer whether it is neoplastic or not. So many times I thought whether this is just a waste garbage or it's actually a diagnostic category, whether we have developed this category to safeguard us from legal issues. So a study was done, and I think this question has come to many of us in our minds. So a study was done to see whether this actually find out whether this category actually holds its test of being just a waste garbage or a diagnostic category. So this study was done, a meta-analysis was done of 26 studies, and it saw that out of around 81,000 cases it reviewed, there was only 10.9% were categorized as OS+ category, and it had a risk of malignancy of 34%. A similar study was done with taking around 16 studies, and it also saw that there was around 10.4% OS+ category and 21.5% risk of malignancy. So this 10% cutoff is usually taken that, okay, if out of all the thyroid FNAs which are reporting, and there will be 10% cases where we cannot give a definitive diagnosis, and that has to be placed in OS+ category, and this is justified. Now, over here, the adjunctive ancillary tests may come to our rescue, but still none of them have been so sure of giving us the confidence to give it as a neoplastic lesion. That I'll discuss in the subsequent slides when I discuss the ancillary tests. So the recommendations for reporting category 3 to make it more clinically relevant has been laid down in the recent edition, and they are saying that now we should either use either OS or plus and not together. Second thing they are said is we should try to subclassify these categories by using these qualifiers. Either we are like, okay, we are saying it's we are not able to say whether it's neoplastic or not, but we should give a hint. What makes us feel that it is not a benign, and what makes us feel that it may be malignant or may not be malignant. So these qualifiers have been made for a uniform interpretation, and these qualifiers are cytological atypia, architectural atypia, cytological and architectural atypia, Hertel cell aspirates, NOS we cannot fit into the 4 qualifiers, and an atypical lymphoid cells. So cytological atypia usually see when we see that there's a smear which is showing some nuclear atypia, some nuclear grooves, some inclusions, but not so sufficient to make it to say it to be a papillary carcinoma. We can categorize into category and further subclassify to be having a cytological atypia. Architectural atypia refers to those if there's some microfollicular arrangement or there's some vague papillary fragments which we see, but we are not sure about that. That comes under architectural atypia, but mostly it deals with the microfollicular arrangement of cells. If we see some Hertel cells in an otherwise benign sample, again, it can be termed under a Hertel cell aspirate, and sometimes we can get just random atypical nuclei or naked nuclei, and that comes under the NOS category. So this is just a description of what features should be there to classify, to give the qualifier as an architectural or a cytological atypia, and with this I've discussed. The reason why I'm saying this is because we should try to subclassify the OS category is because it has been seen by studies that cytological atypia qualifiers have a 2-fold more risk of malignancy compared to the architectural atypia qualifiers. And the Hertel cell qualifiers, they have the lowest risk of malignancy, that is around 5%. Further, I would like to add one more point is that the recent introduction of NIFT-P, which we usually categorize under category 3 or 4. Now with this introduction, it may be that the risk of malignancy OS+ category may be reduced further. That we'll see in subsequent slides when discussed in NIFT-P cases. So, so the conclusion is that regarding this category is, so we should not shy away from giving something as OS+ category, because there will be lesions where we will not be able to say whether it is benign or neoplastic, and if it cannot fit into those categories, we should give it as an OS+ category, but it should be used as an interpretation of last resort. Like Kane ma'am just recently said, lage raho until you are comfortable, then only you place it into the diagnostic categories. Otherwise, you keep it in OS+ category. But it should be used as a last resort interpretation and to be used judiciously, and should not be used as a waste garbage. So having discussed about category 3 lesion, we'll now discuss some other cases. Now this is a case which is this 38-year-old male with a hypoechoic lesion. We can see there's a hypoechoic lesion. and with some calcification and vascularity. And on subsequent slides, you see it's a fairly cellular aspirate, and most of the cells are arranged in microfollicles. Some here and there we can see some nuclear inclusions. So it's easy for us to give it as a category 4 neoplasm, that is follicular neoplasm. Now, whether it's an adenoma or a follicular carcinoma or it's a follicular variant of PTC, that we cannot categorize over here. So it's another case, a 42-year-old female with a lung nodule, and on PET it revealed a FDG avid lesion in the thyroid, which is about 1.2 centimeter, and ultrasound was performed, and it was a cellular aspirate with follicles arranged predominantly in a microfollicular pattern. So this was termed as a follicular adenoma, and since they were presence of metastatic lung nodules, so this was also said as to be consistent with follicular carcinoma. So in these cases, it's easy for us, but so this comes under category 4 lesion. But the problem arises when we see these lesions, like for when we say it's a follicular pattern lesion, when we see follicles we think of these lesions like adenoma, a carcinoma, which we cannot, follicular adenoma and carcinoma, I can say that we cannot classify it on cytology because it is based on capsular and vascular invasion. But the problematic area is whether sometimes we are confused whether it's just a follicular hyperplasia, and sometimes we're confused whether it's a follicular variant of a papillary thyroid carcinoma. So giving another example, this is a 2.5 centimeter well-defined nodule in left lobe of thyroid in a 26-year-old female, and we can see it's definitely a very cellular aspirate, which far exceeds the probability of a follicular hyperplasia, which we can see. And if we have a look at these arrangement of the follicular cells, they're mostly in microfollicular pattern. And there's nuclear atypia, there is presence of nuclear overlapping, some nuclear irregularity, some grooving can be seen over here. So is it sufficient for FEPTC? Then this is the pap smear, where we can see some occasional nuclear inclusions also, but these are very occasional. You can see it's not very diffusely seen. So what is the opinion? Can it be a hyperplasia, or it can be categorized into neoplasm, or it can be an FEPTC? So if we see it on histomorphology, now I think we are quite clear what it was. It's a FEPTC. So now the question arises, what are the features on cytology which will help us to diagnose that it can be an FEPTC? These are some features. If you see an aspirate with microfollicular arrangement, having some nuclear overlapping with grooving, presence of nuclear inclusion, and chromatin, powdery chromatin. This was also further laid by study that presence of powdery chromatin with nuclear grooves and intranuclear inclusions, they are very these clues are very consistent with the diagnosis of a follicular variant of PTC. So this was the follicular variant PTC, but now we know that before the introduction of MIFP, there were two categories: the encapsulated variant of follicular variant of PTC, which was invasive and non-invasive. And a study was done by Nikiforov and et al. And he concluded that the non-invasive category patients, they behaved quite well, and none of them had any adverse outcome. So there was this NIFP, and from this study, actually, this borne the seeds for this category, where a reclassification of the non-invasive variant was done, and it was said to be NIFP. So this is the histological criteria, but what about the cytomorphological criteria? So a study was done to look if we can detect NIFP on cytology as well. So this study was done by Meleta et al. And because NIFP has a very good outcome, so they need not be exposed to radical surgery and followed by radioiodine therapy. So, and this study, it took into account 3 parameters. Hello? Hello? Shall I continue, sir?
Yes, please.
So this study took into account 3 important parameters: nuclear membrane irregularities, the clear powdery chromatin or the clear nuclei, and the nuclear size. And it concluded that nuclear enlargement, nuclear membrane irregularities, and chromatin clearing can be seen in both NIFP and invasive FEPTC. So on cytology, it's not possible actually to distinguish NIFP from the invasive variant of follicular variant of PTC. But yes, whenever we get a follicular event of PTC, we should report it. And then I would like to say that as I said earlier, that the risk of malignancy in this category 3 and category 4, is expected to reduce by this introduction of NIFT-P, because it doesn't have that malignant behavior. And this was further illustrated by this study by Fackwin et al. And by this study, they saw that there was a significant reduction in the risk of malignancy if NIFT-P is seen. And this reduction was about 40 to 45%. Regarding follicular adenoma and carcinoma, as I already said, that it's not easy for us. It is not possible for us to distinguish between follicular adenoma and carcinoma. So if we get a lesion which is predominantly showing a presence of follicles, a cellular aspirate, and with some nuclear isonucleosis, and this very scant colloid, we can easily give it as a follicular neoplasm, and that patient will be subjected to lobectomy, and that will be actually the diagnostic thing. So having discussed about category 3 and 4 lesion, we are coming to the other lesion, that is cystic lesions. Sometimes cystic lesions can pose a problem for us. Not every cystic lesion should be categorized as a non-diagnostic lesion, because sometimes we can get some particles, just like this in this rice muri butter, where we can see some rice or muri in the butter teal. So a 32-year male presented with a swelling in lateral aspect of neck, and on aspiration, a 6 ml of brown fluid was aspirated. It was like a colloid-like material, and direct smears and sediment smears were examined. So this is a direct smear. We can see it's predominantly a cystic lesion, fluidic background with some inflammatory cells and some scattered follicles. So ideally, what we will do next? Shall we put it in non-diagnostic category and ask for a repeat FNA? Then sediment smears were examined, and these sediment smears showed this clusters of cells showing nuclear atypia. There's some nuclear grooving, inclusions, but the cellular aspirate was not so cellular. It was not so cellular. So again, the same question: where to keep it? Shall we give it as a PTC? Shall we give a descriptive report, or shall we keep it in the category 3 with nuclear atypia? So what will be our advice to the clinician? Ideally, it should be a repeat FNA, because the cellularity is not that great, and we can keep it in OS category and give it as a cytological atypia. And on repeat FNA wasn't in this patient under ultrasonography guidance, and this is what we saw. There was presence of this papilloid fragment, and with more definite features of PTC, nuclear inclusions with presence of nuclear inclusion, pseudo inclusion, and nuclear grooving and irregularity. And this is the cytomorph. This is the histological image. So as we can see, it's predominantly a cystic lesion with a part of showing papillary thyroid carcinoma. So this is a very common false negative. This is a very common cause. The cystic variant of PTC, it's a very common cause of false negative cases in thyroid FNA, and we should always try to, whenever we see a cystic lesion which is radiologically looking like malignant, we should always try to do more, either by preparing sediment smears or by going for a repeat FNA so that we do not miss this lesion. Now coming to the next category, having discussed about one of the important lesions, which actually I also personally face a lot of problem, the Hürthle cell-rich lesions. So many of us may have encountered seeing a benign aspirate and suddenly some clusters of Hürthle cells coming in. So whenever I see Hürthle cell lesions, usually these are the differential diagnoses which you can think of. A lymphocytic thyroiditis with Hürthle cell hyperplasia. Can it be a colloid goiter with Hürthle cell hyperplasia, or a PTC of Hürthle cell variant, or it is just a Hürthle cell neoplasm? So this is a straightforward case. We see a lot of markedly a fairly cellular aspirate, which showing predominantly comprising of Hürthle cells, and on histology also confirms that this is actually a case of Hürthle cell neoplasm. Another case, a 4 centimeter nodule in the right lobe. It was a solitary nodule, and now we can see that it's a fairly cellular aspirate showing abundance of prominent nuclei with abundant cytoplasm, looking like Hürthle cells. Then there are some disc cohesive cells as well, showing some sudden anisonucleosis-like features. So what it can be? Can it be a medullary carcinoma? Can it be a papillary thyroid carcinoma with Hürthle cells, or can it be just a Hürthle cell neoplasm? So and where to place this category basically. So in these cases also, I think our category 4, it will be a better term because we are seeing some Hurtle cell-like changes. Although a medullary carcinoma, we have to look for other features also to say whether it's a medullary carcinoma or not. And on histomorphology, this was the picture. So it's basically a case of Hurtle cell carcinoma. So having discussed about this, this one, whenever we see Hurtle cells, we should also look for presence of lymphocytes. This was this helps us a lot in differentiating the lymphocytic thyroiditis cases from the neoplastic cases. So if we see a Hurtle cell, sometimes of some clusters of Hurtle cells, then we should look at the background where the lymphocytes are more or not. And also we should diligently search for plasma cells, because usually in a hemodiluted smear, blood plasma cells are not so prominent in blood. So if you get plasma cells in the background along with the inflammatory cells, even if you don't get features of follicular destruction, it can be a case of a lymphocytic thyroiditis. So when we case in Hurtle cells and PTC, when if this is a difficult case, and actually what we see in smears is usually you can see a lot of Hurtle cells, but we should always look for some papillary features somewhere in the smear. And if you get that, either you can go with a repeat FNA, you can use adjunct.
You have 1 minute.
Yes, ma'am. Ancillary tests, and then we can do. The another thing is, if you get lots of sheets of colloid in Hurtle cells, if you get a lot of cyst macrophages along with some Hurtle cells, it can be Hurtle cells and colloid goiter. So coming to lymphoid lesions, I would go through rapidly because there's time constraint. This is 28-year-old female with a clinical history of lethargy, menstrual disturbance, and weight gain. And this is an easy take. We get sheets of lymphocytes with follicular destruction and along with presence of Hurtle cells. So this is a case of lymphocytic thyroiditis. Another case, a 45-year-old lady with a thyroid swelling of 1.5 year duration. And this was the smear. You can see that there are some Hurtle cells, there are some lymphoid cells. And from another site, it was done, and was seeing some sheets of lymphoid cells, which are not so enlarged, some small to intermediate in size. These are the lymphoid-rich aspirate with presence of Hurtle cells. So is it a lymphocytic thyroiditis or suspicious for NHL? So flow cytometry was done, and this showed that there's a mixed population of B cells and T cells. There was kappa chain restriction. So it was basically a case of a low-grade lymphoma occurring in a background of lymphocytic thyroiditis. So this is a histological picture image. We can see that's a primary thyroid lymphoma, marginal zone lymphoma. Another case, it's a straightforward case, 60-year-old lady with increased swelling. We can see there's some large cells and with presence of tingal body macrophages. It was a lymphoma and anaplastic carcinoma. That was the differential which was there. And fortunately, we had cell block and showed presence of CD20 positive cells, which was further confirmed flow cytometry to be a case of a DLBL. And DLBL is actually an aggressive course, and it's an aggressive disease, and it should be treated by chemotherapy rather than surgery. So primary thyroid lymphomas, these are uncommon variants, usually seen in middle to old age women. The problem is they have a very confusing clinical history with anaplastic carcinoma. They usually have a very short history and comprising of a rapidly enlarging neck mass. And usually when we suspect lymphoma, there are usually two lesions, either it is a low-grade mild lymphomas or it's a high-grade DLBL. The distinguishing feature for low-grade maltomas from lymphocytic thyroiditis is basically in smears, we'll see abundant and lymphoid tissue and a high proportion of syntocyte-like cells. If we see this is usually seen in cases of low-grade lymphoma, and that should raise the suspicion of presence of a lymphoma. And apart from this, I will come to one other case, this slide, that what are the causes for false positive cases? When we try to overinterpret nuclear features of PTC, sometimes they are highly cellular smears and some papilloid clusters, which can be seen in adenomatous nodule of multiloid goiter, which are misinterpreted as neoplastic lesions. Hurtle cell nodules in thyroiditis can be overinterpreted as presence of Hurtle cell adenoma. Sometimes in thyroiditis, we can see PTC-like changes. Writing false negative, it can be a sampling error, it can be a cystic lesion in case of cystic variant of papillary thyroid carcinoma. Last of all, we should also remember that sometimes the radiologist and clinician may fail to distinguish whether it's a thyroid lesion or parathyroid lesion. In that case, we should always remember that sometimes if we cannot fit, if the cells are having a very smooth outline and with very minimal pleomorphism, which we cannot put it into a thyroid follicle cell, we should always look for a parathyroid neoplasm. So a little bit, 2-3 slides, ma'am, I have for ancillary test. Shall I continue, ma'am?
Please.
Maybe, yes.
So regarding ancillary testing, they can help us to improve the diagnostic accuracy of thyroid FNA. And we have at one hand, we have the IHCs like galectin-3, HPME1, CK19, which help us to distinguish the malignant lesion from the benign lesion. And they have have a sensitivity of a fairly good sensitivity of 78%. But the molecular testing is, we have, apart from the IHC, we have molecular testing, followed by gene mutation rearrangement studies, gene expression qualifiers, and the microRNA analysis. So, this major studies have validated the use of this IHCs, but it was said that still it's not giving a more than 90% sensitivity or specificity. So molecular tests were advised in the latest edition of the Bethesda, which are fairly more specific and sensitive than the IHCs. And usually these 4 markers are important: the BRAF mutations, the RAS mutations, the red PTC gene rearrangement, PAX8 PPAR gamma rearrangement. And regarding the BRAF markers, they are positive in 40 to 45% cases of PTC. That's basically the RAS marker pathway is being followed. So what are the methods which we can use? We can use a conventional PCR, RT-PCR, or FISH study. This is by Nikki Farrow and et al. And the sample which we can take, it can be a direct collected sample, it can be cell block, and even the scraping from the smears are quite a good material for carrying out this molecular tests. So, and these molecular tests have been shown to have a very high positive predictive value, as we can see, that is around 80 to 90%. So they are being have been added as an adjunctive measure to in the latest Bethesda. Apart from this, the molecular tests not only help us in diagnosis, but they are also helping in prognosticating the patients. It has been found that presence of BRAF mutation with these co-mutations like TERT, PIK3CA, P53, and AKT1 mutation, they have a poor prognosis. They confer a poor prognosis to the patient. And there's gene expression qualifiers which have a high negative predictive value, that is the AFFIRMA test. There are some positive predictive value ones which are known as the rule-in test, like the ThyroSec test. Then finally come to the microRNA analysis. This has been shown that if microanalysis is being used in conjunction with the gene panel, it has a very good sensitivity and specificity. And maybe this can be the norm in the near future. So just I want to show one more case, just in awareness. This is an 8-year-old boy with a thyroid lesion of 2 to 3 months. And what we saw in the smears that there were some spindle cells, scattered spindle cells, along with some very scant colloid. And so the summary was it was a cellular smear with spindle cells, and there was some pink material, extracellular material. So is it a follicular, is it a medullary carcinoma? This is the histomorphology. So it was actually diagnosed as a spindle epithelial tumor with thymus-like differentiation. Just few slides that it typically occurs in older children and young adults having a low malignant potential. And we have to differentiate it from a spindle cell variant of medullary carcinoma, synovial sarcoma, solitary fibrous tumor, and a spindle cell anaplastic carcinoma. So these are the usual differentials. So whenever we get a spindle cell in a smear, we should not directly go for a medullary carcinoma, but we should also keep in account this entity settled along with differentiating from synovial sarcoma. IHC is important because settle is usually positive for vimentin, SMA, and CK, while it is negative for calcitonin and CD34, which will help us in differentiating this from the other differential diagnosis of medullary carcinoma, synovial sarcoma. And I think since time is not there, I'll skip these lesions for diagnosing of a tall cell variant and the diffuse sclerosing variant of papillary thyroid carcinoma. One thing I want to say, in diffuse sclerosing variant, we will not get nuclear features of PTC, but you will get large vacuoles, cytoplasmic vacuoles, along with squamous differentiation and many sarcoma bodies. So if we see these features, these are usually seen in the diffuse sclerosing variant of PTC. So to conclude that the recent edition of the Bethesda, it reinforces the usage of all categories of the previous Bethesda system. The risk for malignancy in category 3 is higher compared to the previous Bethesda system. And the use of NIFT-P is expected to reduce the lower risk of malignancy in these categories. Molecular testing is recommended for category 3 and 4 lesions, and management should take into account all the features, not only pathological, but clinical, radiological, morphological, and molecular test reports. So the take-home messages for coming to a proper diagnosis, a team approach is always required. We should involve the radiologist as well as the cytopathologist. We should ensure a good technician to obtain the adequate material. And the material fancy techniques should be taken if it is available. We can apply molecular testing to improve our diagnosis. And in cytopathology should be interpreted in the light of ultrasonographic findings. And anytime if we feel that we are not in the comfort zone, then we can always go for a multidisciplinary meeting. We can discuss with the clinician, radiologist, cytologist to come to a diagnosis. Thank you.
Thank you, Dr. Bardia. Dr. Kane wants to ask a question. Madam?
Yes, ma'am.
Just one question. In the
Yes, ma'am.
current scenario of NIFT-P, do you ever diagnose FVPTC on FNAC? And on what basis? Just short, in a short you say. Should we diagnose a circumscribed nodule aspirated as FVPTC on FNAC? What should be our approach?
Whenever we get the smears, ma'am, like I have diagnosed 1 or 2 cases where if we see a we have to keep into mind some features. That is, if we see a microfollicular arrangement with presence of nuclear features and pale chromatin if we are seeing, then, and if the clinical context, if it's a young lady, then we should give a hint actually that it can be a follicular variant of PTC. It can be categorized into category 3, but should be given with a qualifier of a cytological atypia, so that this can be followed up with either a repeat FNA, or it can be done with a lobectomy, and they can see the lesion, and then it can be further followed up with
my question was, will you give FVPTC as diagnosis or even suspect FVPTC, or you will keep it as follicular neoplasm 4, Bethesda 4, and a comment or rider that FVPTC cannot be ruled out? What should be the approach?
We usually give a rider. Basically, we give it as a follicular pattern lesion, and we say that a follicular and we give a differential basically that FVPTC cannot be ruled out.
Because with current scenario, it is very difficult to distinguish the two on cytology. All the features seen in FVPTC can be seen in NIFT-P. That is why, and we don't see invasion.
Okay? Yes, ma'am. We don't see invasion.
That's all. In interest of time.
Yes.
Aparna.
Thank you, ma'am. Thank you, Dr. Bardia.
Thank you, ma'am.
Nice talk, but Anand, very nice talk. I must, yes, I enjoyed it.
Thank you, ma'am. That means a lot.
We should break for lunch now.
Yeah, Aparna, just a moment. I would like to thank our chairpersons, Dr. KK Madam and Dr. Dravid sir, if they have any comment to make.
Our only comments will be that yes, Cat 3 and Cat 4 is where our antennae go up very fast. And NIFT, TP, when we think in terms of, as Kane Madam has already rightly pointed out, follicular neoplasms with papillary potentials, we will not be able to put it down under cytology. And that's exactly why we really like Anand's radiology, as well as the CAT, as well as the ROM, the risk of malignancy into consideration. Thank you very much, Dr. Bharti.
Thank you very much.
Thank you, ma'am. Aparna, over to you.
We are now breaking for lunch, and we should meet after 10 minutes. 1:35. It's very difficult for us as organizers, but it's much easier for people who are listening only. So we'll try to make this ambitious plan. 1:30, in 10 minutes, we should meet and start the proceedings.
Aparna, in the meantime, can we thank and play the videos of our sponsors in the lunchtime? I request everybody to please watch those videos. I would like to thank here our IT partner DigiShield, who because of whom we are seeing this flawless streaming of the conference, though it is online, and also the KM Hospital and the Navle Hospital for giving us the office space to relay this conference from both the centers. Thank you very much. We break for lunch and we'll meet at 1:35 sharp. Thank you.
Sana.
Speedy SurePath Direct to Slide is a high-quality liquid-based cytology test utilizing cell enrichment, but designed for the low-throughput laboratory. Speedy SurePath Direct to Slide is a very simple procedure.
पुढे लावलं ना. हॅलो.
Dr. Aparna, are you there?
Yes, I'm there. Let's begin. We have now Dr. Kavishwar is going to give a talk on urine cytology. Bhageshri, I will now request you to introduce Dr. Sharda Rane and Dr. Gore as the chairpersons for Dr. Kavishwar's talk.
Good afternoon, all. I would like to welcome Dr. Sharda Rane ma'am and Dr. Charushila Gore ma'am to chair this session. Dr. Sharda Rane ma'am is a professor and head of pathology and deputy dean at Government Medical College, Baramati, Maharashtra. She is in her field of interest is histopathology, infectious pathology, renal pathology, general surgical pathology, dermatopathology, and intraoperative consultation. She has numerous publications in national and international journals to her credit. She is currently vice president of IAPM. She has served as Secretary IAPM from 2017 to 2019, Joint Secretary IAPM from 2013 to 2016, Chairperson of Maharashtra Chapter of Pathologists from 2009 to 2012, Online IAPM Quiz Master from 2013 to 2017, and convener for PG Quiz Session in Maharashtra Chapter 2007 to 2009. She is a member of Undergraduate Committee of Medical Council of India since 2013, and she's been invited as guest faculty at various national and international conferences. I welcome Dr. Sharda Rane ma'am. Dr. Charushila Gore ma'am is a professor and head of Department of Pathology at D.Y. Patil Medical College, Hospital and Research Center at Pune. She is recognized as a postgraduate teacher and an undergraduate teacher. She has MMC recognized faculty and speaker for medical education technology. She is moderator for histopathology slide seminar of Maharashtra State at annual MACyCON conferences from the year 2016 to 2018. She has been examiner for MBBS, BDS, and MD of various universities in and out of Maharashtra. She is member of various boards at D.Y. Patil Medical University. She has more than 70 publications in various national and international journals, and her main areas of interest is histopathology and cytology. I welcome Dr. Charushila Gore ma'am to chair the session. We have a very accomplished speaker today, Dr. Vikas Kavishwar sir. He is a professor at pathology at TNMC Nair Hospital, Mumbai, and consultant surgical pathologist and cytologist at Metropolis, Mumbai. He is an accredited MMC speaker. His special interest is in nephropathology, cytopathology, and dermatopathology. He is on an executive committee of Association of Cytologists and of Maharashtra. He has been faculty at various conferences, CMEs, and workshops. He has numerous publications to his credit, and he's been teaching UG and PG students since last 30 years. I welcome Dr. Kavishwar sir and request him to start the session. Thank you.
For being here. Good afternoon, everyone. I'd like to thank organizers for involving me in this MACyCON, which is a fantastic cytology conference. And the topic given to me is cytology of urine. I think this is the best discussed. I think it doesn't matter how many resources you have. What really matters is how to use available resources and we have to plan the diagnosis. We are going to cover this part in three major aspects: urine cytology, scope limitations, system for reporting, which is the standard system these days, and liquid-based cytology, which is coming up. So let us talk a little bit about approach to urine cytology. Why to do urine? Detect pregnancy as early as possible. When the lesion is present, it is the primary diagnosis of the lesion in the bladder or in maybe the ureter or kidney. Sometimes in a known case of urothelial carcinomas, and rarely what for primary. Sometimes the lesion is not detectable So this as a screening process, however, it should be restricted only for high-risk patients and non-malignant indications are specifically limited to certain indications, like for example, PK virus. Method of obtaining cells can be truly exfoliated as in voided urine or force exfoliated, which can be a better sample as far as the yield is concerned, that is watched. That was not ideal for morphology or interpretation. Our early morning sample or long-study samples. Contrary to what we do is during thin microscopy, early morning first samples that are more concentrated tend to the cell morphology because of concentration. Three factors like blood inflammatory cells, substances like speech abnormalities or whatever, etc. What are the types of samples then available? So usually what is done in practice is 3 days second morning mainstream urine samples are collected to minimize the contamination at external cells. Instrumented urine, as I said, are the best ones. However, they are often with problems because they are invasive. The conduit urine only related to post-operative patients, which have undergone cystectomy. Though this appears a very limited indication, in fact, this is the most practical indication today. There is hardly any tissue available to do biopsy, so one has to come with urine cytology in these patients. Which can be preserved by addition. It's like can be or can be by refrigeration. Urine cytology. As I said, it is not for routine. It is only for high risk of lung cancer, like in older age, pain patients, smoking, occupational exposures to chemicals, irritating urinary symptoms which are unexplained and long-standing, sometimes. Hematuria, a common indication, but most non-specific indication because many times it turns out to be non-neoplastic. As I have been emphasizing, it is not an ideal sample for this kind of population. Let us understand a little bit about epidemiology of carcinoma of bladder. 3% of global cancers are related to urothelial world. 9 are 55 years of age or older. So you can see the age distinctly in males, especially. Smoking in about 50 to 65 for environmental toxin exposure is 20% of the cases. In a geographically limited African or Middle East areas, squamous cell carcinoma can be because of cystosomas. So almost 80% of the cases are attributable to both these factors of bladder cancer. So it is a good strategy, and that is why urine cytology is being tried to be utilized. So it is not yet giving success also. Of bladder and 50% of kidney cancers are urothelial carcinomas, and majority of them are low grade and they are non-muscular. Often they are capillary tumors. 30% of bladder urothelial carcinomas are muscle invasive and high grade. Low grade and high grade are considered to have different diseases. That means it's not that it's a common spectrum that low grade will enter into high grade or long grade. But they have different pathophysiology, molecular history. Low-grade urothelial carcinomas are diagnosed by RT and individual cell morphology. So it is difficult. In other words, our focus is in cytology is to diagnose urothelial carcinoma, which is invasive or which can be in situ. Urine cytology can have an age-ago biopsy in certain situations. To detect carcinoma in situ, when there is no focal lesion. So what to biopsy, we don't really know. Carcinoma hidden in diverticula, not seen on scopy easily, but seen in detecting residual tumor from urine cytology, like in any other cytology nowadays, we are in the era of standardization. So what we need to standardize? The sample processing techniques, the common techniques are conventional cytocentrifugation. Coming up is LBC. There are ancillary tests which have been suggested, especially in developed world where this cancer is cytology. And artificial intelligence is the most early kind of in experimental stage. more importantly, cytology reporting needs to be standardized. And like in any other area of cytology, basically there are always 4 diagnostic basic categories: inadequate sample, benign sample, indeterminate sample, or malignancy. So what is the purpose of this? Firstly, there has to be uniformity of language for understanding of clinician, cytologist, patient, and secondly, when cytologist is reporting, it should be possible for him or her to report easily in a clear language with a practical category. If we have complicated criteria, then it may not be a very useful. The other side, if the criteria are not very specific, then they will not be applicable in practice. Thirdly, the criteria should be clinically relevant to manage the patient. That means they should give guidelines. Okay, if patient is in this category, do this. If it is in this category, do this. That. So there have been attempts in urine cytology also to standardize reporting, and relatively, what I should say, popular or time-tested thing is the Paris system for reporting. This was the original article which was reviewed in Acta Cytology in 2016. So we are in 22. So more than 5 years are over, and people all over the world have applied this system with satisfactory. What does this indicate? Basically, this has tried to categorize this into 7 main categories: non-diagnostic or unsatisfactory. Mark the word negative for high-grade urothelial carcinoma. As I said, the cytology focuses only to diagnose reliably high-grade urothelial carcinoma at present. So, it is negative for high-grade urothelial carcinoma. 3, 4, and 5 I have put together because they are the ones where we really want to focus during cytology in primary diagnosis. Atypical urothelial cells, suspicious for high-grade and high-grade. I'll go into details of this. Then 6 categories low-grade urothelial. Which is, as I said, cytology is not a very good technique. These are usually low-grade papillary urothelial carcinomas which need cystoscopy and biopsy. And very rarely, just to complete the list, other type of primary sample. It's the basic thing just to know normal urothelial lining, low-grade urothelial carcinoma, and high-grade urothelial carcinoma. The histology on one side and this is the cytology on the other side. Few benign squamous cells, urothelial cells, as seen in normal sample. This is more or less normal urothelial lining, maybe a little bit reactive changes at places. Low-grade urothelial carcinoma will definitely have some increase in hyperchromasia or ratio, NC ratio as compared to normal, but it is not as high-grade as high-grade urothelial carcinoma, where there is distinct presence of muscular and irregular levels. So these are the usual basic criteria on which even Paris system is based. What does it says? The first criteria is NC ratio. Call the cell atypical when NC ratio is more than 0.5, and call the cell high grade when it is more than 0.7. Now they are very close. Don't ask me how they really whether they calculate 0.5 or 0.7 by morphometry. People have tried, but overall it might be useful as we proceed further. I think if there hyperchromasia, whether it is mild or it is dark to very dark, of clear membrane is irregular and chromatic quality, whether it is irregular or circular. These are the only 4 major cytological criteria on which we try to classify these basic lesions. Like in atypical, the criteria number 1 is must, that is nucleocytoplasmic ratio, plus there can be either of 2, 3 or 4. Whereas in high-grade urothelial carcinoma, 1 and 2 are must. Can have additionally either 3 or 4. So this is the simple thing. Now you will ask me what is in between category suspicious for high-grade. Now urine per se problem is the adequacy of similarity. So many times we get very few abnormal cells. So for diagnosis of high-grade urothelial carcinoma, we should have at least 5 to 10 adequately preserved high-grade carcinoma. If there are high-grade cells but they are short in quantity, then they fall in between the category of suspicious for high-grade urothelial carcinoma. This is basically the Paris system. Let us try to this whole jargon related to that only cytological that they are present, not related, mild, severe. If it is mild, is there any reason? Try to follow up, get it so on. As I said, the basic is related to what is the quantity of high-grade atypical cells. If they are rare, call it suspicious. If they are many, call it positive. If you don't want to call it normal or low grade, but
there are some atypical cells for it. This is the system. Just to add a few points in each category. For non-diagnostic or unsatisfactory, unfortunately, there is no good criteria. As I just said, the quantity of cells is relatively variable and few in urine samples. So there are no consensus criteria for adequacy. But generally, it is said about 30 ml of urine should be submitted for cytoscreen preparation and interpretation. People have tried, there are references, and somebody has come up with the standardization of 2600 cells in LBC preparation. However, in practice, this is obviously not a very good criteria. What is important to know that if we see obscuration, we have to clearly say it is obscured. So this is a real category of unsatisfactory where we cannot see morphology. It is obscured by inflammatory cells or lubricant. So we should not give a false diagnosis of negative. And if there are any atypical cells or high-grade cells, obviously it becomes satisfactory. We have to report even if we see this one. Second category of negative, most of our urine cytology samples fall in this category, negative for high-grade urothelial carcinoma. What are the cells? Often what we get are urothelial cells, benign superficial cells followed by high-grade. Sometimes we get, of course, we often get squamous cells also, the benign cells. Benign glandular cells, sometimes if there is metaplasia, and rarely seminal vesicle cells. Changes associated with urolithiasis or virus cytopathy, sometimes we may come across. Basically, all these will fall in the category of negative for high-grade urothelial carcinoma. This is actually a picture from a reference which is showing the category like compared to RBC, yes, the nucleus of tubular cells and urothelial cells. See the NC ratio, benign cells, how they are. Sometimes they may be reactive changes, but not as high as here. These are the PK virus related cases where the nucleus is almost like glass. So reactive cells sometimes can be a problem for differentiating. However, see the NC ratio, when there is a lot of cytoplasm, it is better to underscore the interpretation and quality of reactive cells. For negative, for high-grade urothelial carcinoma, we may rarely come across this cluster, this kind of cluster, which is often related to instrumentation effect. This is actually a case of low-grade tumor which has crowded together. This is a benign kind of, sorry, this is not a low-grade, this is, but urothelial cells which are showing reactivity, but crowded, so misinterpreted as sometimes low-grade. And this is a benign vessel type small umbrella cells, which you can see the difference between this reactive cells where chromatic is more open. Here, atypical, suspicious, and for high-grade and high-grade, these are the areas where we really have to concentrate, that we have to pull out. When we see a urine cytology smear, if there are any urinary chromatin, urinary cells showing abnormal chromatin or some macrochromatia, what we have to see NC ratio. If NC ratio is not high, usually they will fall into reactive category. However, NC ratio is usually first thing which gets affected in particular cells. So NC ratio more than 0.5 is the major criteria. And as I said, any one of the sufficient for. Now, what is important is what is the management for this category? Only routine follow is sufficient, just like negative. Only thing this will be more what I should say close follow, maybe with sometimes sonography. No need to do any invasive treatment, but sonography and cytology. When we talk about carcinoma, whether it is suspicious or high-grade carcinoma, this is the kind of what we get. Usually, urothelial carcinoma tends to have single cells with sharp cell borders. Cytoplasm is more solid and nuclear membranes are irregular. Because sometimes these cells can be misinterpreted with generating cells. Sometimes it becomes very difficult to differentiate. We just have to consider the correlation with all the findings there. Same thing is true about suspicious or high-grade, as I said, is the quantity what matters. NC ratio with severe nuclear hyperchromatia are the major criteria, and one of nuclear membrane minor criteria. With minimum of 5 to 10 severely abnormal urothelial cells to go for definitive diagnosis of high-grade urothelial carcinoma. So these are again some of the photographs from suspicious for high-grade. You can see only occasional cell showing these. These are the arrows. Actually, these are having a good amount of NP ratio. It becomes very difficult to decide are they degenerative or are they suspicious. But whatever it is, at places they look quite hyperchromatic, like in this case, and so better to call it suspicious. And whereas low grade, this is a sample obtained by brushing, by invasive technique with conventional preparation. Sometimes this is a very rare kind of thing on cytology to see such kind of cluster, but this is obviously urothelial neoplasm. So this is what is low grade urothelial neoplasm. This is cannot be made, as I said, on cytology. Presence of fibrovascular folds are rare. Instrumented UV can show this. So basically, what we have to remember, even if we say this papillae and pores, better not to call it directly as a low-grade carcinoma, because there are three regions histologically. Papillomas is urothelial neoplasm with low malignant potential, and low-grade urothelial carcinomas. All three of them can have more or less similar papillary morphology. So category says it is a low-grade urothelial neoplasm other than carcinoma. And this is the last thing, just to consider this. They are less than 5%, very difficult to diagnose on cytology, honestly. Squamous, adenose, small cell. It may be useful when there is a known case with some major surgery done and post-operatively we are trying to follow up the patient and all that. Secondary malignancies are still rare, can come from localized prostate cervix or basically, urine cytology has overall sensitivity. You can see the variability of sensitivity, 15.8% to 4. This is because what kind of cases we are studying. Lower the lesion, lower grade is a lesion, sensitivity will drop. However, specificity is usually high because we are focusing on high grade urothelial carcinoma. In fact, what they say, if we exclude the low grade and we include only suspicious for high grade or high grade, then it may reach to almost 100%. We include only those cases for cytology followed by histology for correlation. This is just a summary of all that. As I said, suspicious for high grade, other malignancies. There are the three areas where the risk of malignancy is quite high, especially when we say high grade urothelial carcinoma or other malignancies. You can see that the risk of malignancy more than 90%. Suspicious is the anyway borderline category, just like atypical urothelial cells. But atypical urothelial cells have risk of malignancy much low. So NC ratio plays a lot of role. What is important to see here, if there are any difference in the follow-up, for all these three categories, suspicious for high grade or high grade, it is always more aggressive follow-up followed by cystoscopic biopsy. Whereas for atypical, what is suggested either clinical follow-up as needed or there is nowadays potential use of ancillary tests. Now, what are these ancillary tests? Not routinely available and not cost-effective today, maybe in our routine practice. However, there are some tests which are available when there are atypical cells seen. And what is the purpose of these tests? How to interpret them? See, high-grade urothelial carcinoma does not diagnosis is quite reliable on cytology, so there is no additional benefit of doing these urine tests. Low-grade urothelial neoplasm needs cystoscopic biopsy only, so these tests are not indicated. Only in the scenario of atypical cells, which have negative ancillary tests also, means usually it is a satisfying for patient and probably it is not there is a very less risk of malignancy. So that was my second aspect of Paris system for reporting urine cytology. And let us talk now a little bit about liquid-based cytology and what is its comparison with conventional. There is ample material available in literature. I'll just quote some of the references which are considered as standard and good references. Here in 2005, when it has just started LBC, they had said LBC provides reproducible and well-preserved material for additional techniques. What we have been saying just now for ancillary techniques like immunocytochemistry or fish, and they have better cell recovery. Urine suffers from good amount of abnormal cells, adequacy of abnormal cells, so LBC can have that age above. Basically, LBC methods are liquid-based cytology methods that are based either on filtration process like thin layer with the deposition of cells, and others are based on sedimentation. LBC is already in for, we all know that for pap smears, and it is getting excellent results. Slowly, in other areas of histologic cytology, LBC is coming up. Now, why it is considered useful, more useful? because cytoscreen slide may show few cells and can be basically confounded. Cytoscreen will concentrate also RBCs, WBCs, other cells, whereas LBC, what LBC does, it reduces, first of all, it reduces time. Most of the LBC techniques are at least semi-automated or automated, and nowadays they are becoming cost effective. They are less confounded with other factors. They preserve cytomorphology better with less self-preservation, and they improve the slide quality by clearing the unnecessary background, which cells are dispersed uniformly. So it's easier for cytologists to screen the smear also. Now this is another reference which is saying that it can be used to diagnose or detect recurrence of bladder cancer. LBC is considered more efficient in detecting malignant cells in comparison with conventional urine cytology. So the major indication for which we are today using urine cytology, there LBC is found at least marginally more efficient. Of course, there are more studies needed whether we can replace LBC to classical cytology. So today, whichever centers are doing LBC, they are, I think, simultaneously doing LBC with conventional urine cytology. However, it is, as I said, it's a major role, important as we get more and more biomarkers and ancillary techniques as they come into practice. After all this LBC discussion, this was a center where they were saying, do we really need to adjust the parent system? Because after a long time, we have got some system which is standardized. Now, whether that system needs any changes when we apply LBC for reporting. Not really, because they need the cells with similar inspiration. One of the major criteria which besides artificial or malignant, infrared and cytoscreen slide methods with similar inspirations. The hyperchromasia may be little different. The chromatic quality may be little different for infrared and cytoscreen. However, in both the methods, high-grade urothelial cells can be separately, clearly diagnosed from non-high-grade urothelial cells because they are clearly hyperchromatic. So, in other words, one can apply morphological criteria for high-grade cells in marriage system to both these methods, whether it is infrared cytoscreen or whether it is conventional cytology. So I think that was the short cover of urine cytology. And today, if you ask me, when it comes to cytological evidence and presence of malignancy as far as urine cytology is concerned, what I can conclude is presence of evidence is not always evidence of presence, and absence of evidence is not always evidence of absence. Thank you, please.
Once again.
Thank you. One brief overview of this urine cytology. Is from Pune for giving the stage many times, and the baby question. I have ever seen
Cannot hear well.
Hello.
Yes.
You are not audible.
राणे मॅडम नीट ऐकू नाही येते.
Dr. Gore ma'am, can you comment please?
Yes, thank you, sir, for giving us in-depth analysis of urine cytology. Nowadays, actually, more and more samples are coming because in most of the institutions, super specialties are already there. So, thank you very much. And I don't think there are any questions. I cannot see any questions. Madam, can you see any?
Hello, Vikas.
No.
Can you hear? Anybody can hear? Can Vikas hear me?
Yes,
ma'am, we can hear you.
Can hear you.
Vikas,
We can hear you now. Earlier we were not able to
inclusion. Madam,
Little disturbance,
Vikas, did you see any cases of
Did you see cases of virus infusions?
BK virus, yes, madam. Sometimes in post-transplant patients, but otherwise,
Cytomegalovirus.
no, cytomegalo, no, I haven't yet come across. Post-transplant BK,
Because
I have
people
seen,
send
not-
the urine
not
for
yet.
that.
Correct,
Okay.
madam.
Okay.
Yes.
Because I have seen one case of CMV or in urinary cytology, and which later on we confirm it. So that is one advantage of.
Aparna, can you just, because we lost her, I think, again.
Hello. Hello. Now can you hear me?
Yes, ma'am, we can hear you.
Just I want to share that I had seen one case of cytomegalovirus in urinary cytology, and which later on we confirm it on the.
I think there is some range issue. Bhageshri madam, can you hear me?
Yes, Gore ma'am, we can hear you.
Okay. Was my earlier comments audible?
Yes, your comments were audible. I think Rani madam has some connectivity issue, so her voice is breaking. So Aparna, can we move ahead or?
Yes, we should go ahead with the next. There is some technical glitch here. I'm going to log out and log in again for a second.
I would like to thank Dr. Gore madam and Dr. Rani madam for chairing this session, and Dr. Kavishwar sir for giving us a lucid presentation about urine cytology.
Thank you, ma'am. Thank you.
Now we'll begin with our second session. By the time Aparna logs in, I will introduce the chairperson.
It's sorted.
Yeah. So now I will introduce Aparna, the chairpersons for the next session.
Yes, Dr. Kusum and Dr. Jashnani.
Dr. Kusum Jashnani is a professor and head pathology department at Nair Hospital and Topiwala National Medical College, Mumbai. She did her UG and PG from St. GS Medical College and KM Hospital, Mumbai. Her special interest is in gynecology and placental pathology, cytopathology, bone pathology, and maternal autopsies. She has many publications in various national and international journals, and she is actively involved in UG PG student teaching and is also a PG guide for MD pathology. She has participated as a faculty and speaker in various national and state level conferences and CMEs. I welcome Dr. Jashnani ma'am. Our second chairperson is Dr. Avinash Pradhan, Professor of Pathology and a Chief Histopathologist at KM Hospital, Pune. He is ex-president, Indian Association of Practising Pathologists, Pune. His main areas of interest is pediatric hepatology, GI pathology, dermatopathology, and uropathology. He was an active team member in elucidating role of copper in Indian childhood cirrhosis. He was invited as visiting adjunct professor to University of East Carolina, USA. He visited UK twice through British Council, worked as an observer in King's Hospital, London and Massachusetts General Hospital, USA, and he's published papers in various international and national journals. This is Dr. Manohar Gharpure, late Dr. Manohar Gharpure session. He was a founder president of IPP Pune and one of the oldest pathologists to start clinical pathology in Pune. He introduced inter-lab QC programs and believed in best quality assurance in clinical pathology. He introduced histopathology slide seminars in the small group of 7 pathologists in Pune. He was honorary consultant pathologist at KEM Hospital, Pune. He led the war against illegal pathology labs and helped drafting the Pathological Laboratories Control Act for Government of Maharashtra. He is an avid nature lover and was fond of horticulture. He passed away in 1992. For this session, we have today's speaker, Dr. Avani Pense. Aparna, can we have a slide, please?
Yes, sure.
Yes, Dr. Avani Pense is an associate professor of pathology medicine at University of North Carolina at Chapel Hill. She is an adjunct assistant professor, Department of Pathology and Laboratory Medicine, University of North Carolina at Chapel Hill, associate professor of proteomics, Duke's Biorepository and Precision Pathology Center. She has authored numerous publications, presented multiple posters and research and clinical based articles. She is a PhD from University of North Carolina, and she has completed her residency as well as fellowship in cytopathology and surgical pathology from the same university. I welcome Dr. Avani Pense and request her to begin the talk for the Gharpure Memorial Session.
Greetings to all of you in Pune and all the wonderful places that you are logging in from. I'm coming to you today from Duke University in Durham, North Carolina, and I'm honored to be invited to present the Dr. Gharpure Oration. And today I'll be talking about the cytology of liver disease. This is a vast topic, so I'll only hit the highlights in my allotted time. We'll start by discussing the scope and primary uses of fine needle aspiration of liver and look at some of the techniques employed for specimen acquisition. Next, we will discuss the cytologic findings in a normal liver and then spend majority of our time on mass lesions encountered in a liver specimen. Fine needle aspiration of the liver is mainly performed to evaluate a mass-forming lesion. And the biggest question at this point is this mass a benign lesion or a malignant lesion? And if it is malignant, is it primarily arising in the liver or is it a metastasis from a distant family? This question arises in the context of several possible clinical scenarios, and oftentimes it gives us a clue about what to expect on the cytology specimen. A relatively simple situation is multiple liver masses in a person with a known family. On the other end of the difficulty level is a solitary liver mass, which is not of a hepatocellular origin, but in the absence of a known family, we don't know where it is coming from. And here we are expected to provide clues about the origin of this tumor. Majority of the liver masses that we encounter in our practice tend to be a metastasis. However, in case of a patient with multiple liver masses, it is important to remember that liver abscesses and metastatic lesions may have an overlapping characteristic features on imaging. Alternatively, on cytology and small biopsies, necrotic tumors with a prominent inflammatory response may get a false negative diagnosis of abscess unless the exceedingly rare viable tumor cells are carefully hunted for. Fine needle aspiration of the liver performs fairly well as a diagnostic procedure for malignancy. The sensitivity ranges from 70 to 94%, although some studies quote a higher value of 90 to 96% for the diagnosis of malignancy. The accuracy rate is also rather impressive at 90 to 94%. False positive diagnoses are very rare, but focal nodular hyperplasia and dysplastic nodules in a cirrhotic patient may be overcalled as hepatocellular carcinoma. Another possibility of error is when bile duct hematomas, especially when multiple, are diagnosed as adenocarcinoma. But both these instances are unfortunately rather rare. For the purposes of diagnosing a mass lesion, performance statistics of a fine needle aspirate of the liver compare very well to large core needle biopsies. An ability to make a cell block further enhances the diagnostic accuracy by allowing for immune studies. Due to the minimally invasive approach, complications from liver FNAs are rare. There are very few contraindications to this procedure, such as an unpredictable bleeding response or a situation where there is lack of a safe needle path to the target lesion, for example, in a patient with morbid obesity or severe ascites. Of note, patient cooperation is critical for the success of the procedure since the patients need to hold their breath during sampling. For a number of years, percutaneous aspiration of the liver with some form of image guidance whenever available has been performed successfully on patients suspected to have mass lesions of the liver. It is a relatively safe procedure which has a low risk of needle tract seeding by the tumor. Image guidance is most often in the form of ultrasound. It's portable, it's easily accessible, and does not involve additional radiation exposure to the patient and the performing physician. And since the title and theme of the conference this weekend includes next-gen cytology, I want to discuss this relatively recent collection method, which is the endoscopic ultrasound-guided fine needle aspiration and core biopsy of the liver. This technique has been used in the pancreas, but is now being utilized to acquire samples of liver parenchyma in patients suspected to have a medical liver disease as well as to target liver masses. Compared to percutaneous biopsies, endoscopic ultrasounds are more invasive, they need more time, and they require deep sedation. However, if the patient is getting an upper endoscopy or endoscopic ultrasound of the pancreas anyways, then getting a liver biopsy at the same time is beneficial because multiple organs can be evaluated and sampled during the same procedure. The limitation, however, is that endoscopic ultrasound can only evaluate lesions which are in close proximity with the luminal gastrointestinal tract. So the transgastric route can access lesions in the left lobe, while the transduodenal approach is for the right lobe. The areas that are difficult for this access route are the right posterior segments of the liver. Endoscopic ultrasound is thought to detect smaller hepatic lesions which may be missed by the conventional techniques. And this is a relatively newer way of acquiring samples, being used only in a few centers worldwide. And here at Duke, I have seen one or two samples. So I'll share one example with all of you. We can see liver parenchyma in the top left and bottom center of the field, and a relatively large piece of gastric mucosa is present as the biopsy is obtained by a transgastric route. That brings us to the discussion on normal liver. The commonest cell type that one will encounter in the liver FNA is obviously a benign hepatocyte. These cells are large polygonal cells with a central round to oval nucleus. They can be arranged in tuberculae or thick cords and ribbons, or as larger tissue fragments. Single isolated cells are also commonly encountered. The hepatocytes can be binucleated and can also show nuclear pseudoinfusion. Hepatocytes have abundant granular cytoplasm. They may be pigmented due to the presence of lipofuscin, especially in an older population of patients. Lipofuscin appears greenish brown on Romanowski type stains and golden on the Pap stain, as shown in the figure in the middle of the top panel. Bile may be present in cases with cholestasis. It can be either intracellular or extracellular. And bile pigment tends to be dark green with both the liquid and alcohol-based Pap stains. Rarely, hemosiderin pigment may be encountered in patients with disorders of iron metabolism or in cirrhotic livers, which can accumulate significant quantities of iron. Hemosiderin is blue with Romanowski stain and dark brown with Pap. Additionally, hepatocytes may have fatty change, as shown in the middle of the bottom panel, which will be morphologically represented by cleared out fat vacuoles in the cytoplasm. Steatosis may be a component of liver lesions, including hepatocellular carcinoma, so careful evaluation is needed before the presence of clear cytoplasmic fat vacuoles is attributed to benign fatty liver disease. The second important cell type which is encountered in liver FNA is the biliary type epithelium. Benign bile duct epithelial cells tend to be smaller than the hepatocytes. They are cuboidal to columnar cells with a basally oriented nucleus and are arranged as flat cohesive sheets with honeycomb-like architecture of evenly spaced round nuclei. Depending on the orientation, the cells can be seen lined up, making a picket fence-like row. Small tubular and acinar structures can also be encountered. While benign cells are easy to identify, they can show a range of reactive changes depending on the patient, particularly in the setting of biliary stents or biliary stones. In addition to hepatocytes and bile ducts, other cell types may also be encountered. Kupffer cells are the specialized macrophages of the liver and resemble macrophages elsewhere. Similar to the hepatocytes, they may have pigment in their cytoplasm. Due to their anatomic location in the liver, some may be present as flattened cells with elongated nuclei embedded within the hepatocyte pools. Cytopathologists are very familiar with these epithelial cells with their abundant two-prone cytoplasm and windows between two adjacent cells. Small fragments of skin and skeletal muscle may be encountered in percutaneous transabdominal approach, and depending on the approach taken by the endoscopic needle, normal gastric and duodenal mucosa, like we saw in the previous slide, may also be present in the sample. Like I said before, when you have a biopsy of a liver mass, the biggest question is it benign or malignant? And if it is malignant, it is primarily arising in the liver, or is it a metastasis from a distant fragment? This slide has a somewhat comprehensive list of specific entities that can present as a mass lesion of the liver. The significantly larger font size for metastatic tumors is reflective of their frequency because a majority of liver masses are originating somewhere else. It is difficult to do justice to every single entity on this slide, so we will discuss a few of the important ones. In a discussion about the cytologic features of liver disease, hepatocellular carcinoma has to be presented in a place of prominence. Accordingly, we will look at HCC in more details over the next few slides. Hepatocellular carcinoma accounts for the majority of primary liver cancers, and in many patients, the first diagnostic modality is an FNAC. Majority of the cases of hepatocellular carcinoma are seen in patients with cirrhosis or at least advanced fibrosis as a result of chronic liver disease. The incidence is higher in Southeast Asia and Sub-Saharan Africa, and it is still very much relevant for cytopathologists here in the United States, where about 40,000 adults were diagnosed with a primary liver cancer in 2017, and the incidence has increased significantly compared to the 1980s. The average age of diagnosis is more than 50 years, but rarely HCCs are found in children as well as in young adults. Common presentation is a solitary liver nodule, often in a patient known to have chronic liver disease. However, some cases present as multiple liver nodules and mimic a metastatic process, or they can present as diffuse liver enlargement. Although architectural arrangement is not always the strength of the FNA sampling, larger cell groups with trabecular and pseudoglandular or acinar arrangements can be seen in an FNA smear, especially in larger fragments shown in these figures here. Scattered single cells can be found in the background, and the samples in HCC can be highly cellular. The trabeculae or thickened cell cords tend to be wrapped by epithelial cells, which is a feature highlighted in the diffuse stain smear on the top left. Additionally, prominent vessels can be seen transgressing through the lesional cells, another characteristic cytomorphologic feature of HCC, which is highlighted on the top right side. The bottom left panel shows the pseudoglandular or acinar architecture of the hepatocytes. Individual cells of well-differentiated or moderately differentiated HCC simulate their benign counterparts and are polygonal with significant amount of cytoplasm, although they have somewhat higher nuclear to cytoplasmic ratio. Scattered cells can show intranuclear pseudo-inclusions. The presence of bile, when noted, is an important diagnostic clue about the cell of origin. The last one on the bottom right represents a more poorly differentiated HCC, and the malignant cells here are arranged in loose shapes and may need some ancillary immunohistochemistry to come to an accurate diagnosis of HCC. The poorly differentiated carcinomas can be quite pleomorphic, have a high NC ratio, macronucleoli, and may even have multinucleate giant cells. Architectural features may be better appreciated on cell block specimens, which also create opportunities for immunostains, which may be necessary to confirm the diagnosis of HCC. Positive staining for HepR is shown in the picture on the top right and is helpful to establish hepatocellular differentiation. Other stains that are positive in HCC but are not shown here include cytoplasmic TGF1 staining, arginase, and a specific canalicular pattern of staining with polyclonal CEA. The specific staining pattern of polyclonal CEA is important because the distinctive linear staining along the bile canaliculi is characteristic of an HCC as opposed to the reduced cytoplasmic staining that is seen in adenomyosis. LIPCAM3 is also a useful marker that is positive HCC and helps to differentiate HCC from benign. My favorite though is special staining for reticumin, which is lost because of the thickened trabeculae in HCC compared to the thinner 1 to 6 white trabeculae seen in the normal benign liver. This feature can also help in the difficult differential diagnosis between well-differentiated HCC and a regional nodule in a cirrhotic patient, or even a rarely sampled hepatic adenoma, because both these entities tend to have thin cell ribbons more similar to that of benign leukemia. CD34 shown in the bottom right panel is also very useful because it can detect sinusoidal capillarization and highlight endothelial wrapping around the thickened hepatocyte walls. I promised you many cases of HCC. So here is a variant where the background is just as important. These can be difficult to distinguish from a benign hepatocyte with lipid accumulation. Clear cell variant of HCC has glycogen accumulation in the cytoplasm and not fat. These cells tend to be delicate because they're filled with glycogen and they tend to break easily. The smears therefore have abundant bare nuclei with disrupted cells spilling out their cytoplasmic glycogen, resulting in the characteristic mottled appearance of the background that is sometimes referred to as tigroid background in other glycogen-rich tumors such as seminoma. Fewer diagnostic cell groups are seen in this particular smear, but we can still appreciate some nuclear pleomorphism, higher NC ratio, and larger nuclear layers. Luckily, we had a cell block with pretty good sized tissue fragments that allowed us to perform a reticulin and a CD34 that confirmed the morphologic impressions made on the smear, that of an HCC. Morphologically similar to the clear cell variant is the steatohepatitic variant. I don't have a smear preparation for this particular variant because this case came to me as a poor biopsy of the liver. The steatohepatitic variant is quite common at a frequency about 20% and shows steatosis or steatohepatitis in the background liver, mainly from obesity or metabolic syndrome or alcohol-induced fatty liver disease. The tumor shows the typical features of HCC, including wide hepatic plates, trabecular growth pattern, but it is characterized by neoplastic cells that show features of steatohepatitis. So they have a large fat droplet in the cytoplasm or steatosis, inflammation as well as fibrosis. Balloon hepatocytes are commonly seen with the signature Mallory-Dent bodies shown in the bottom right panel. The prognosis of this tumor is similar to that of a conventional HCC. So mentioning the tumor subtype is not necessarily going to change the treatment paradigm or prognostic implications. But given the epidemic of fatty liver disease, we are likely to see this subtype more and more often, so it is important to recognize. I have mentioned reticulin stain a couple of times in the context of diagnosis of HCC now. And I have said it that the wide hepatocyte plates can help us with the diagnosis of HCC. But in benign background liver with significant steatosis, there can be patchy loss of reticulin fibers, and the hepatocyte plates may appear artificially wide because of that. So treat reticulin with caution in the context of fatty accumulation in the background liver. The next example of HCC stresses the point that context matters, and it's important to look at the background liver as well and comment on it whenever possible. Another difficult smear with larger nuclei thickened trabeculae. I'm worried about a hepatocellular lesion, but let's look at some of the benign hepatocytes that have come along from the right, which is on the right side of the slide. Throughout this smear, we kept noticing a lot of brownish pigment in the hepatocytes. The patient here is in the late 50s, presented with a solitary liver mass and had no prior history of liver-related symptoms, or for that matter, very limited clinical history in general. Since the pigment was mainly in the background of benign appearing hepatocytes, we ended up doing a special stain for iron, which was positive. So we raised the possibility of a genetic disorder in iron metabolism. The patient was worked up and eventually diagnosed with hemochromatosis. This has significant consequences for the family members, not so much for the treatment or prognosis of the HCC, but given how common it is to be a heterozygous carrier for this mutation in my patient population here, it was important to raise this diagnosis for the future health of relatives in general. Since we are talking about pigment, we'll continue on that path, but we will now leave the world of HCC behind us. This time, the pigment is within the tumor cells. Diagnosis-wise, most of the times it is not difficult to make a correct interpretation of metastatic melanoma in the liver, especially if you have relevant clinical history of it. But there are enough instances where the primary is occult, it is not yet diagnosed, and it pays to keep this differential diagnosis of HCC in mind. because both of these tumors can have polygonal cells with relatively lower NC ratio compared to other malignancies, can have pigment and nuclear pseudoinfusion. Classic feature of melanoma cells on cytology is that they are somewhat discohesive, and this feature is highlighted in smear preparations because of the nature of the melanoma cells. They spread out on the smear very nicely. The cells are large with large nuclear pseudoinfusions that you can see on the liquid stain here. The NC ratio can be very low. Many of the neoplastic cells have pigment here, and it's important to differentiate it from lipofuscin pigment that can be found in the fats. Cell blocks show the pigment and the cells that are not quite looking like the vaccine. And then, of course, we have our ancillary immunohistochemistry. There are several melanoma markers available, including SOX10, S100, MARK1, that can be utilized to further confirm the diagnosis. Now let's switch gears and talk a little bit about cholangiocarcinoma, which is an important differential diagnosis for the poorly differentiated hepatocellular carcinoma. Also, since it is an adenocarcinoma, possibility of a metastatic adenocarcinoma from a non-hepatic primary source also needs to be investigated. Cholangiocarcinoma is the second most common primary tumor known to arise from the liver and accounts for 5 to 15% of liver cancers. In the US, the most important risk factor is prior history of primary sclerosing cholangitis. Other risk factors such as hepatobiliary stones, chronic infections by parasites, and exposure to toxins are more common in other parts of the globe, including Asian countries. Cholangiocarcinoma can arise from intrahepatic or extrahepatic bile ducts, and when they arise from intrahepatic bile ducts, they can potentially make a mass lesion in the liver. Cytologically, they resemble adenocarcinomas of the pancreas and the upper gastrointestinal tract. The smears tend to be hypercellular with crowded sheets, cell clusters, and abundant single cells. Evidence of glandular differentiation in the form of acinar arrangements or cells with mucin macules may be present. Architectural features may be more easily appreciated on the cell block, and visible fibrotic stroma may be obtained on the cell block if we are lucky. Individual cells are cuboidal to columnar, but they may show marked pleomorphism, nuclear membrane irregularity, and prominent nucleoli. CA19-9 immunohistochemistry is shown in the bottom middle picture. Other useful immunostains include CK7 and CK17. MACyCON can also be helpful whenever there is mucinous differentiation. Overexpression of P53, and loss of SMAD4 expression is similar to that seen in the pancreas. So it is difficult to differentiate cholangiocarcinoma from pancreatic adenocarcinoma based on this. And in many cases, diagnosis of cholangiocarcinoma has to be made after clinically excluding other primary sites. Sometimes it may be important to differentiate between poorly differentiated HCC and cholangiocarcinoma. HepFAR1, arginase, and glypican stains will favor a diagnosis of HCC over cholangio, where CK7 and CK19 staining supports cholangiocarcinoma. Also, the possibility of a combined HCC and cholangiocarcinoma needs to be kept in mind. Which brings me to this age-old question of, is this a cholangiocarcinoma or is it a metastatic adenocarcinoma? In this slide, I've made a list of potential differential diagnoses to consider and some immunostains that may help with this distinction. In case of multiple liver masses, the commonest differential diagnosis by far is a metastasis. Depending on the patient history, specific primary sites need to be considered. For example, in a patient with a history of colon cancer, cytologic features such as tall hyperchromatic cells with necrosis, positive CDX2 and CK20 will help that diagnosis rather easily. Certain morphologic features deserve special mention. HCCs can show clear cell change like we saw in one of our previous slides. And in this situation, possibility of metastatic clear cell renal cell carcinoma or other tumors with clear cell morphology should be considered. Neuroendocrine tumors are not uncommon in the liver. So it is important to remember that neuroendocrine tumors that can stain with CD56 can create problems because some of the cholangiocarcinomas also show CD56 staining. So I always recommend a panel of immunostains rather than a single immunohistochemistry. Lymphomas and mesotheliomas may at times present in the differential diagnosis, and then melanoma is the great mimicker. We saw an example, and it is always appropriate to keep that in the differential diagnosis. With this, we are going to leave the neoplastic processes behind and take a quick look at few of the non-neoplastic entities in the differential diagnosis of hepatic masses. Hepatic abscesses can be bacterial, fungal, or amoebic. Bacterial abscesses can be due to ascending cholangitis or sepsis. Many of them are polymicrobial, with the main positive organisms being E. coli and Staphylococci. Candida species are the most common pathogen responsible for fungal abscesses, and they tend to occur in immunocompromised patients. And amoebic abscesses are rare in the US, but the primary positive organisms for those is Entamoeba histolytica. A double target sign is shown on the top panel. It consists of a hypodense central area surrounded by first a hyperdense ring and then a hypodense zone. Seems to be highly suspicious on the radiology for abscess. Smears tend to have variable inflammation and necrosis, and in case of amoebic abscesses, a careful search may be necessary for the positive organism. Obtaining material from the periphery of the abscess improves the chances of diagnosis because the center will yield predominantly necrotic material. A note about amoebic trophocytes because they can resemble histiocytes. They have a small eccentric nucleus as shown at the bottom picture, and the cytoplasmic vacuoles can have adjusted red blood cells if we carefully look for that. Solitary liver cysts can be infectious or non-infectious. The non-infectious benign cysts include simple unilocular cysts, which are lined by cuboidal to columnar cells, similar to the biliary epithelium, or can even be squamous line. The cyst fluid is typically hypocellular, and the specimen can actually be non-diagnostic. Ciliated Forgas cysts are lined by respiratory type epithelium and may have cilia. Mucinous cystadenomas can also present as unilocular cysts and are lined by mucinous epithelium. It is important to remember that metastases to the liver can have cystic degeneration, and a thorough evaluation of cyst fluid is essential to find the diagnostic malignant cell. Although not common in the US, hydatid cyst is the commonest parasitic cyst that can affect liver as well as other organs. This is caused by larval form of Echinococcus granulosus, which is a dog tapeworm. The solitary cyst has a fluid level upon imaging, and outer acellular laminated layer of some cysts may be calcified. The internal layer is the germinal layer, which gives rise to daughter cysts, which can contain scolices and multiple hooklets. The scolices tend to degenerate in long-standing cysts, but hooklets can be identified, and they actually stain positive with acid phosphate. Anaphylactic shock is discussed as a complication of FNA and hydatid cysts, but the accurate incidence is not very well established, and successful aspiration is performed in many cases without complications. Our talk on liver cytology will be incomplete without the mention of bile duct brushing. We see these often in patients with malignant strictures as well as those with biliary stones. Benign ductal cells make flat cohesive sheets and honeycomb patterns where the cells respect each other's boundaries. On the other hand, brushings from malignant stricture will show a dual population of benign cells as well as cytologically malignant cells. The malignant cells are larger, they have high NC ratio, and there is significant nuclear pleomorphism. It is important to note that in most brushing specimens, we cannot differentiate between a high-grade glandular dysplasia and invasive adenocarcinoma. With that, I will conclude with a summary slide. Image-guided fine needle aspiration of the liver is a safe and effective diagnostic tool for evaluation of the liver, particularly in the setting of a mass lesion. Having appropriate procedures to handle these specimens, including adequacy assessment at the time of the procedure and cell block preparation, can often improve the diagnostic ability and circumvent the need for surgical biopsies as well as resections for diagnostic purposes. With multiple non-surgical treatment options available to patients, such as microwave ablation of smaller hepatocellular carcinomas, liver cytology has the potential to play a crucial role in early accurate diagnosis as well as in therapeutic decision making. The next slide, I have some references and resources that I used to put this talk together. I want to thank you all again for your attention and to the organizers for giving me this opportunity. And if there are any questions, I am happy to answer.
Thank you, ma'am. Aparna, are you there?
Yes, I'm there. Avni, are there any questions, Bhageshri? Can you see?
No, I don't see any questions, but I guess we have Dr. Rajan Sancheti who just joined in as an MMC observer.
Yes. Should I just
Hello.
take over?
Hello.
Yes,
Yeah,
ma'am.
I can hear you.
Yeah, I'm Dr. Kusum Deshnani. I had, thank you, Dr. Avni. It was a very nice and lucid presentation. I would just like to add here, okay, whenever we face problems in the differential diagnosis between hepatocellular carcinoma and metastasis, we do take the help of serum tumor markers like alpha-fetoprotein, CA19-9, CEA. So I would like to ask Dr. Avni, what is her take on serum tumor markers for screening and diagnosis of liver cancers? If she's around.
Yeah, I'm here. I think
Yeah.
you raised a very excellent point, and next time I do this talk, I'll include that information because I do rely on alpha-fetoprotein as well as CEA and CA19-9 to get the first clues of what I'm dealing with, whether it's a hepatocellular lesion or a metastatic lesion. So yes, I definitely agree.
Yeah, so we depend on that. Yeah.
And I actually see another question in the Q&A here. So should I just read it and answer it?
Yes.
Yeah, so the question is from Dr. Prachi, and she is asking, how often do you render diagnosis of hepatic mass lesions on cytology alone? And this is another great question because in terms of cytology alone, we do make diagnoses when there is a good cell block available. But now increasingly in my practice, the interventional endoscopists are getting core biopsies more and more. And the role of cytology has changed a little bit. So they will still submit it as a cytology specimen, and they ask us to come and do rapid on-site adequacy on that. So we do touch preps on these biopsies. So we still have material on the smears to teach our trainees, but the reliance on pure cytology smears for diagnosis of HCC is less and less increasingly. And similar thing is happening in the pancreas, even with the EUS sampling. They are using the new sharp core needles, so they actually get tissue fragments rather than just a cell block.
Hello. Hello. I'm Dr. Avinash Pradhan. Would like to ask you, Avni, this was a wonderful presentation, very lucid presentation. I'm sure due to time constraint, you are not able to cover certain aspects. But could you share your experience on fibrolaminar hepatocellular carcinoma?
Yeah, so I actually have not seen a case of fibrolaminar hepatocellular carcinoma as a pure cytology case, but we do see them rarely because they're not as common on the surgical pathology side, and they tend to be in a younger population. And until now, it was thought that they behave better, they have a better prognosis compared to a classical hepatocellular carcinoma. But I think that is shifting a little bit, and that initial impression came from the fact that these fibrolamellar carcinomas happen in relatively younger patients without the background of cirrhotic liver. So that may be one of the reasons why they fare better and their prognosis is slightly better. But I don't have experience on them on pure cytology.
The other question we have in KM Hospital Pune, specialized pediatric oncology. And what is your experience on hepatoblastomas?
Yeah, so again, not so much on cytology because when they have a pediatric case, they tend to just get a surgical biopsy. And we always do a consultative diagnosis given how rare it is. And again, it's a pediatric case. And we also often send these cases out to for confirmation of diagnosis to other experts that are pretty much in like a pediatric children's hospital based practice. Because at Duke, we the main focus of liver pathology at Duke is very much related to transplant, and because of that, medical liver biopsies. So we just don't see as many pediatric cases to feel like we are the world's experts on that. And we are happy to do consultative diagnoses and even send them out for confirmation.
Okay, thank you, Amni. It was a very lucid presentation. Thanks again.
Thank you.
Dr. Pense, and thank you, chairpersons, for chairing this session. And Aparna, Dr. Sancheti is here, I think.
Yes. Dr. Sancheti, we would like to thank you. Dr. Rajan Sancheti. He is the moderator from Maharashtra Medical Council side. He has been very cooperative, and I would like to mention that he is a very active part of IMA, and he also happens to be an important part of DigiShield, which is the IT partner helping us. And so it is incidental that we got to have a moderator who is so much in support of our conference. I have been speaking to Dr. Rajan Sancheti, and he has promised me that through Pune IMA, he is going to have a greater chunk of attention and giving back to the practice of pathology through IMA. So after this conference, we are going to get after him to gear up for more activities in Pune. Dr. Sancheti, thank you very much for being there. And in spite of your busy schedule, he actually is associated with the lovely part of Bharti Hospital. He's the RMO there. And today he's traveling to Aurangabad, but in spite of that, he's joined the conference and is blessing us with his presence. Thank you, Dr. Sancheti.
Thank you, madam. Very, I would say, excellent academic session with all brilliant presentation. Thanks a lot. I won't take much of time because already we are less of time.
Yeah.
Thanks a lot. Thanks, ma'am.
Thank you, sir. Aparna, should we go to the next session?
So we are heading to our next session. Avni, thank you very much. We have kept her awake at 4 a.m. and and she must have gotten up earlier because she has answered everything very promptly and very alertly. So thank you.
I did make a cup of coffee that is here with me.
Yeah. Okay. So we head towards the next talk.
Yes.
This was Gharpure Memorial. And now I request Dr. Bageshri to introduce Dr. Nalini Gupta and Dr. Kolte for the talk of Dr. Leena Naik. Dr. Leena Naik is the president of Association of Cytologists of Maharashtra. So can you introduce the chairpersons?
Yes, thank you, Aparna. Today's chairpersons for this session are Dr. Neelam Kolte. She's working as HOD Cytopathology at KEM Hospital, Pune since 1987. She's practicing as cytopathology at Kolte Laboratories since 1987. She's recently trained at Motic, China for DNA ploidy and an AI-based study. She visited British Columbia Research Institute, Vancouver, Canada for the same. She's working on machine learning with OptiScan, and she's been trained at Memorial Sloan Kettering Hospital, Mayo Clinic in USA for cytology and histopathology. She has worked on various projects with WHO, ICMR, and NAVI. Do we have Dr. Nalini Gupta? Has she joined?
Yes, she has joined.
Yes, Dr. Nalini Gupta is working as a professor Department of Cytology and Gynecological Pathology at the prestigious Postgraduate Institute of Medical Education and Research, Chandigarh. She did her senior residency in pathology from the same institute. She has more than 350 publications in various peer-reviewed index journals of international and national repute. Her special interests are exfoliative cytology and pulmonary oncopathology, liquid-based cytology, and cancer research. She is a member of the editorial board of cytopathology and diagnostic cytopathology, member of International Academy of Cytology, International Academy of Study of Lung Cancer, and International Society of Gynecological Pathology. She is the chairperson of External Quality Control Program of ISC. She is also a life member of IAPM, IAPID, NAMS, ISLLC, ISC, and a treasurer of ISSLC. She was awarded an ICMR International Fellowship for the Young Biomedical Scientists and has worked with Dr. Meena Desai in Manchester Cytology Centre, UK, and with Dr. John Smith in Royal Hampshire Hospital, Sheffield, UK, and has learned LPC and its various applications. She has conducted more than 30 workshops on LPC. I welcome Dr. Gupta, ma'am. Today's speaker is Dr. Leena Nayak. She is ex-professor and head of Department of Pathology at LTMMC and GH Sai in Mumbai. She is ex-professor of pathology at GS Medical College and KEM Hospital. She is president of Association of Cytologists of Maharashtra and a mentor for fellowship in cytopathology MUHS. She has more than 50 publications in the field of cytopathology. I welcome Dr. Leena Nayak, ma'am, and request her to please start with her presentation.
A very good afternoon to all the delegates, invited speakers, ACM committee members, and organizing committee. I'm talking on serous effusion cytology. Now, serous effusions, when it comes for cytology, it is usually a most neglected part of cytology. But then, serous effusions give you a lot of information. It plays a key role in distinguishing reactive effusions from malignant effusions. And it also helps to define the exact type and size and stage of the lesion. Effusions are excessive amount of fluid accumulated in major serous cavities, which are pleural cavities, cardiac cavities, and perils. It is result of an underlying pathologic process, and most of the effusions are associated with reactive. Now, Indian Association of Cytologists has published guidelines for collection, preparation, interpretation, and reporting of serous effusions in Journal of Cytology in procedure. Now, these guidelines give a standardized format for how to process serous fluids from collection to sign out of. And these guidelines are applicable to different types of resource settings. You may have a low resource setting with only a small centrifuge, or you may have a medium resource setting where you will have a cytoscreen machine available to you, or you will have a high resource setting. In India, we have many laboratories which have low to medium resources. So these guidelines are applicable to both these resources. In this format, the categories of essential, optimal, and optional are listed. The essential categories are such where if you don't have these essential instruments available, you cannot process serous fluids in your laboratory. You will have to refer it outside to other labs. Optimal settings are where you have good instruments, a better instrument like cytoscreen available along with immunocytochemistry, and you can process serous effusions in a better way. Now, for accurate cytological diagnosis, proper collection techniques for serous fluids along with transportation, preparation of specimens are important because an adequate cellular, well-prepared and well-spent smear helps in ultimate goal of accurate cytopathological diagnosis. For serous fluids, it is always better to process freshly tapped sample without any delays, because if any bacterial growth occurs, it alters the cell morphology. The transportation time, which is permitted, is 2 hours. If you are going to overshoot the transportation time, or if your serous fluid is not going to transport it on time, then it needs to be refrigerated. And this refrigeration is at 4 degrees Celsius. The serous fluid should never be frozen because it will alter the cell morphology. You can use anticoagulants if your serous fluids are mixed with blood. And these anticoagulants are citrate, oxalate, etc. But then you should never put fixatives in serous fluid. Fixatives like formalin and alcohol are not advised because they alter the morphology and they prevent cells from sticking to the slide surface. Coming to gross examination of fluid, and before that, how much fluid do you need for processing? Usually 20 to 30 ml is the optimal quantity required for serous fluid processing. If you are going to prepare cell blocks, about 30 to 50 ml of fluid will be required. The gross evaluation of serous fluids is done by technicians. In that, you look for color of the fluid, which may be watery colorless, yellow, black tinged, bloody. It could be milky white, like chylous fluid. It could be purulent, etc. Consistency also is checked. It could be serous, liquid, gelatinous fluid. Temperature of the fluid also needs to be checked, whether it was at room temperature or it was refrigerated, needs to be known, and you should look for blood clots. Bloody effusions, where hematocrit is more than 10%, are known as hemothorax, hemoperitoneum, or hemopericardium. These fluids, when seen under microscopy, will show a lot of cytophages, and they are more likely to be associated with malignant conditions than non-malignant conditions. Sometimes traumatic effusions also are blood. Sometimes you get blood-tinged effusions. It is because of the procedure or recovery from trauma-related incidents. Chylous fluid is milky white, and it is usually traumatic. It could be surgical or non-surgical trauma associated with malignancies also. Many a times lymphomas are associated with chylous effusions. In adults, conjunctive pericarditis, cirrhosis, and lymphangiomyomatosis also may be associated with chylous effusions. You need to find out whether it is a fluid you have received is conjugate or exudate, and this is usually done in routine examination. Conjugates have low protein content, where exudates have high protein. Conjugates occur when there is intact vasculature. It is usually seen in conditions like congestive cardiac failure, cirrhosis, nephrotic syndrome, hypoproteinemia, superior vena cava obstruction. Exudates have high protein content, and here you usually have disruption of capillaries and capillary permeability culture. Malignancies and infectious conditions usually show exudate effusion. Along with cytological examination and routine examination, you can also do biochemical tests on effusions, like for detection of glucose, amylase, adenosine deaminase levels, microbiologic examination, smear culture for bacteria, fungi, parasites can be looked for, special stains like PATH, CMS, and Seal-Nelson stain can be done, and immunologic tests like flow cytometry and monocytochemistry can be done on these fluids. What are the essential components of a report when you give a report on serous fluids? First is you have to say how much is the volume of serous fluid received and appearance of the serous fluid. The specimen cellularity, whether it is low, moderate, or high, needs to be checked. You can give description of the cells seen, which is optional. You need to mention background and interpretation of the smear. That is, after evaluation of the smear is prepared, the case may be placed in any of the 5 recommended diagnostic categories, which is given by IMS. Now, what are these categories? These are the diagnostic categories for reporting serous effusions, given by Indian Association of Cytologists. The The first category is unsatisfactory for evaluation, where no cells are seen and it is obscured by blood, artifacts, or extensive lesions. Second category is no malignant cells, which is category A, where you don't detect any further changes, and this category has to be correlated with and with imaging studies and microbiology studies. The category B is where when you don't see malignant cells, you see some benign changes like reactive mesothelial cells, inflammatory cells, plenty of lymphocytes, and sometimes you may get evidence of specific infections like tuberculosis, microfilaria, fungal infection, headache, etc. The next category, that is category 3, is atypical cells, anodes, not otherwise specified. In these cases also, you have to correlate this space clinically with imaging studies and repeat cytology is advised. Ancillary techniques are optional in this case. The fourth category is atypical cells or suspicious for malignancy. In this case, ancillary techniques are advised, and atypical cells suspicious of malignancy category comes when the changes seen in serous fluids in the cells are qualitative or quantitative, insufficient to call it clear malignancy. The fifth category is malignant cells. These malignant cells may be of mesothelial or non-mesothelial origin. Subtype of this malignancy, wherever possible on cytomorphology or on ancillary techniques, may be found out. Now coming to cells which are seen in serous fluids, mesothelial cells, macrophages, inflammatory cells, RBCs, and others. Coming to mesothelial cells. Mesothelial cells are one of the most versatile cells of the body, and it has a very wide morphologic spectrum. The morphologic spectrum of reactive mesothelial cells overlaps with that of malignant cells, and it creates a diagnostic difference. This is the morphology of malignant mesothelial cells. They are usually solitary or small cohesive clusters, round to oval, varying size. Here you can see a mesothelial cell, which is binucleate and one uninucleate, and you can compare the size with RBC. They are 15 to 30 microns in diameter, and they show two zones of tape, ectoplasm and endoplasm. And in this cell, which is packed stain, you can see little variation in the cytoplasm. Nuclei are central or off-center. Binucleated cells, multinucleated cells are common. Nucleoli are prominent, and mesothelial window is usually seen. Now, this is a cluster of mesothelial cells, two cells with a mesothelial window. Similarly, these cells have centrally placed nuclei, these cells have off-center nuclei. This is again a mesothelial window. Mesothelial window is not a specific finding for mesothelial cells. It is also seen in adenocarcinoma. Next cell category is macrophages. Macrophages are described two types, mesothelial and histiocytic. Histiocytic macrophages are the usual macrophages you see in any fluid, and mesothelial macrophages are macrophages which show mesothelial cell presence. Like this cell seen here, the skirted border of the cytoplasm indicates that these are mesothelial macrophages. It also shows blood cells. Various blood cells are seen depending on type of inflammation, neutrophils, lymphocytes, and eosinophils. Neutrophilic effusion. When you have neutrophils which are more than 50% of the cell population, it is called neutrophilic effusion or neutrophil-rich effusion, and it is seen in bacterial pneumonias, infarctions of lung, pancreatitis, subclinic abscess, and even in early tuberculosis. You may get neutrophilic effusion, which is neoplasm. That's why looking at the morphology is very important. Myeloid sarcomas, chronic myeloid leukemias are the conditions in which you can get neoplastic neutrophilic. Lymphocyte-rich effusions, where you have lymphocyte count more than 50% of the cells. 10% of the malignant effusions also show cause as non-Hodgkin's lymphoma, and they will show immature lymphoid cells in the effusion. 20% cases of Hodgkin's lymphoma, the effusions are benign. It is due to obstruction of lymphatic drainage, so they are chylous effusions. NHL, that is non-Hodgkin's lymphoma, is a common cause of chylothorax, and over 50% of malignant effusions with chylothorax, the malignant tumor is NHL. That is non-Hodgkin's lymphoma. Now, where do you get these lymphocytic effusions? The lymphocytic effusions, non-malignant are common. Tuberculosis, viral infections, lymphomas, primary and secondary are neoplastic effusions. True chylothorax, rheumatoid pleuritis, SLE, uremic effusions, and congestive heart disease. Coming again to neoplastic lymphocyte effusions. If these effusions are because of condition like CLL, SLL, this is a small cell lymphoma. Cytomorphology does not help in diagnosis of lymphoma, and you have to submit the sample for flow, or you have to carry out cell block with markers, ICC markers for the diagnosis. Burkitt's lymphoma. Burkitt's lymphoma, when it presents as effusion, it is easy to diagnose. It can be subjected to flow cytometry, but then diagnosis in these cases is always an emergency, because these lymphomas have 100% proliferation rate with 24-hour doubling time, and effusion sample is the ideal specimen for rapid diagnosis. You usually see intermediate size cells with cytoplasmic vacuoles, as they are seen here on Ginsa stain smear, and they can be easily suspected, and diagnosis can be confirmed on immunocytochemistry and flow cytometry. Coming to eosinophilic effusions, if you have more than 10% of the cells, nucleated cells, eosinophils, it is called eosinophilic effusion or eosinophilic effusion because they are parasitic. Fungal infections, hypersensitivity syndrome, drug reactions, and also pulmonary infarction. Coming to tuberculosis, in our country, tuberculosis is endemic. The early effusions in tuberculosis are neutrophilic, and later stage effusions in tuberculosis are always lymphocytic. So, neutrophilic effusion does not rule out tuberculosis. This fluid can also be subjected to other tests like adenosine deaminase levels, which are increased more than 45 international units, and gamma interferon. In rheumatoid arthritis, you can get pleural effusion as a complication, and concurrent or prior to joint involvement, and it is always exhibited. You see degenerated cells, necrotic debris, and atypical single cells, but necrosis in effusion is almost diagnosed for rheumatoid effusion. Systemic lupus erythematosus. Here, pleural involvement is more common than pericardial involvement. This is also exudative. Inflammatory cells are there, and sometimes you get cells are seen and identified as heavy cells. But heavy cells seen are not pathognomonic of systemic lupus erythematosus, and in this you can suspect this SLE, and patient has to undergo other confirmatory tests. Now we come to cases. This was ascitic fluid in a 65-year-old patient. He had abdominal distension and he was chronic. It was a cellular smear, and the cells seen were green cells. They were multinucleate cells and cells arranged in rings. Multinucleate cells trinuclear cells, uninuclear, but then with high NC ratio, hyperchromatic nuclei, ruffled borders, binucleate cells. Again, a cluster of cells with knobby margins, and again a binucleate cell with ruffled border and two-tone cytoplasm, where you can see cytoplasm in the center and thin cytoplasm, a bit of reticulated cytoplasm. So here in this case, there was only one cell. The background cells were blood cells and macrophages. So we had single population of reticular cells, but with mesothelial cells. There was no evidence of mitosis, apoptosis, or necrosis. There was no evidence of anaplasm. So this was reactive mesothelial cells. Now these cells can be mistaken easily for malignant cells. We called it ILC diagnostic category 2. It says no malignant cells, benign failure stain of reactive mesothelial cells. Now in this case, no other population of cells was seen apart from mesothelial cells. But then if the doubt for malignancy is very high, then in these cases you can prepare a cell block and it can be subjected to immunocytochemistry to find type of cell. Now, where do you see these reactive mesothelial cells? Liver cirrhosis and uremia are very common conditions where you get reactive mesothelial cells. These cells are thinly placed groups, pseudopapillae, small glands, multinucleate is common, large nuclear high NC ratio is common with nuclear membrane irregularities, nuclear hyperchromasia, chromatinins, and prominent nucleoli. The cells in large groups usually show a knobby or scalloped borders, characteristic mesothelial cells. Now the case which we saw, we had biopsy from that case and it showed reactive mesothelial hypoplasia of the peritoneal biopsy. The conditions associated with reactive mesothelial cells along with cirrhosis is the most common condition associated with reactive mesothelial cells. Also neoplasia. In malignancies, you can see reactive mesothelial cells along with malignant cells. Reaction to foreign substances like talc, asbestos. Traumatic irritation of the peritoneum or serous surfaces because of hemodialysis, operative procedures, chemoradiation therapy, pancreatitis, infarctions, uremia, and collagen vascular disorders. Now, this is the image which shows range of mesothelial cell appearance. Now, this is from Dr. Sidam's book on serous fluid cytology. It shows almost normal looking mesothelial cells with endoplasm and ectoplasm, small nuclei, and at other extreme you have large mesothelial cells with very high ratio, eccentrically placed nuclei, which look almost like malignant. So what are the diagnostic difficulties? First thing I want to state is that if you find malignant cells in effusion, it is very ominous prognosis. It almost suggests advanced stage of the disease. So, because of this, you should always avoid false positive diagnosis in serous effusions because it has negative impact on the clinical management. The second thing which occurs in serous effusion is cells round up in fluid medium due to surface tension. So, native shape of malignant cells doesn't remain a guiding feature for deciding primary origin of the malignant. Effusion fluids are nutrient rich, so malignant cells always proliferate and they form cell balls. But when they form cell balls, sometimes the morphology is difficult to assess. And third, reactive mesothelial cells is a consistent component with morphologic overlap with malignant cells. So diagnostic difficulty with reactive esophageal cells always remains in serous state. Now this is image again I have picked up from Dr. Cytology. Very good image that shows you the diagnostic difficulty with cells when you have reactive esophageal cells. Now this is a dictionary reactive esophageal cells. So very high incidence of and if you can look at this adenocarcinoma cell, it is almost comparable. In fact, I would say that this adenocarcinoma cell is less malignant than the reactive esophageal cell. So such cells lead to false positive interpretation. And this would be avoided. Again, one more image which shows you esophageal cells and adenocarcinoma cells. Esophageal cells also show similar nuclear features and high incidence. Differentiation is almost difficult. So what is the way out in such cases? You need to resort to immunocytochemistry and do markers for mesophageal cells and adenocarcinoma. The mesophageal cell markers which are usually suggested are calculating CK56, desmin, and D240. And adenocarcinoma markers are BAR84, OCT1 and 2. These markers can be done on cytology slides which are wet kits, or can also be done on cell blocks. Now we come to next case, that is pleural effusion in 64-year-old female, and she was a known case of ovarian cancer. And this was a appearance on smears. This is Gibson stain smear, and it shows many cell balls and these clusters of cells which look like papillae. If this is a high power view, it shows its cells, and you can easily make out now by presence of ectoplasm and ectoplasm and ruffled borders that these two are esophageal cells, and if they are enlarged hepatomatic, so these are reactive esophageal cells. Next page is a cluster of cells where you can see the cells are small, very epachromatic nuclei. You are seeing here also. Here the cell shape is preserved. It is not rounded up, fortunately, and you can see columnar cells. Here you can see cells with cytoplasmic vacuoles, but then nuclei are small. It looks like mesophageal cells. Now this is image from same case where you can see this cluster of malignant cells and large cells, some multinucleate ruffled borders, and these are reactive esophageal cells. Now in this here, the reactive esophageal cells are more eye-catching and malignant looking than the smaller real malignant cells. Okay, here is the high power view of the same. These are the reactive esophageal cells and the malignant cells. Again similar, these are the malignant cells which should border to columnar here and reactive esophageal cells. Some of these malignant cells show eccentrically placed nuclei which are almost touching the outside, and this is supposed to be the indication that these are malignant cells. Whereas in esophageal cell clusters, you will get nuclei which are placed centrally, and even if they are eccentric, you will see a ring of cytoplasm. So if you see a ring of cytoplasm outside nucleus, they are likely to be esophageal cells. But in malignant cells, the nucleus almost touches outside. You don't see a ring of cytoplasm. So this our case was very highly cellular effusion. It had two cell populations. It had cohesive clusters with papillary arrangement, large cytoplasmic vacuoles also, and it had presence of reactive esophageal cells. So as per the IST diagnostic category, this goes in category 5, malignant cells. We call it papillary adenocarcinoma consistent with metastasis of ovarian carcinoma. And we can advise cell block with immunocytochemistry confirmation. So what is the processing approach for serous fluids? In serous fluids, to diagnose malignancy, see how to identify the second foreign cell population, and it is easily done on field suspension. Then you have to evaluate nuclear features of this second population. It has to be done on pap stain. So in serous fluids, you have to do both the stains, IMSA stain and pap stain for evaluating morphology and for accurate diagnosis. You semi-quantitatively evaluate mesothelial cells. Objective confirmation of the second population and differential diagnosis of the primary can be done by preparation of cell block and immunocytochemistry. And this has to be correlated with clinical and radiological findings. The cell block needs to be prepared in many cases of serous effusions for accurate diagnosis. The advantages of cell block is that multiple sections can be taken similar to tissue block. H&E slides can be obtained and immunostaining can be carried out with ease. The methods for cell block preparation have three main methods. First is filter paper and formalin method. Second is 4% agar method, and third is plasma thromboplastin. Now, we in our institute prefer plasma thromboplastin method for preparation of cell block. The details of all these methods is given in the reference in Journal of Cytology, IAC, Indian Association of Cytologists, and they have given all the procedures for cell block preparation. Now, this immunocytochemistry, when it is done on cell block, this is advised by Dr. Siddham in his book on serous fluid cytology. He calls it subtractive coordinate immunoreactivity pattern and advises that in cell block you should do vimentin, PAN-CK, LCA, calverinine as first immunomarkers. Cell block is a preferred sample for immunocytochemistry. The results of cell block are comparative to surgical samples. Multiple sections are possible here, and cell block can be archived and can be used later for any further studies. Now, one thing you have to remember that some cases of malignant effusions, you may not see mesothelial cells. It also happens in inflammatory effusions. Mesothelial cells are not seen. So, if you have absence of mesothelial cells, it doesn't affect the report. It doesn't affect the adequacy of the sample. Adequacy of serous fluid samples for cytology does not depend on presence or absence of mesothelial cells. Coming to third case, this was a 54-year-old female. It was a known case of carcinoma. MRM was done 2 years back, and histopath diagnosis that time was metaplastic carcinoma of the breast. She presented with abdominal distension and pain. She had ascites. Ascitic tap was done for diagnosis. The ascitic tap showed this type of cells which were larger if you compare with RBC and mesothelial cells. They had high MC ratio. We prepared cell block out of it, and it showed good cellularity with cell balls and glandular arrangement, and at times at places papillary arrangement. Now, CT scan in this case showed large solid cystic right adnexal mass. Right ovary was not seen separately from this mass, and she had omental, peritoneal, mud colon, and serosal deposits. So it was suggested that it's the case of CS sigmoid colon, or there were large serosal deposits involved in sigmoid colon. So possible primaries in this case were primary from breast presenting as ascites, so primary colon, presenting as ascites, and as ovary also had a mass, maybe ovarian primary. The cytology diagnosis was category 5 positive for malignancy. We called it papillary adenocarcinoma, and we prepared a cell block and carried out immunocytochemistry. On immunocytochemistry of cell block, we found that CK7 was positive, CK20 was negative, Data2 negative, is negative, Cal-retinine was negative, but W1 was positive. So with CK7 W1 positive, CK20 Cal-retinine data suggested this as ascitic fluid of ovarian primary. So ISC diagnostic category here becomes category 5 malignant cell. Cell block on immunocytochemistry suggested ovarian primary. Case 4, 67-year-old female. He had pleural effusion. He presented as non-exertion, dysphagia, odynophagia, loss of weight and appetite. Now this was the effusion smear, pap stain, and you can see that these are very obviously large malignant cells. But then some of these malignant cells show surface plaques. Here also you can see inflammatory cells and large malignant cells. On gypsum cell smear, there were some cells with quaternion, and these cells had two-tone cytoplasm. We had endoplasm and ectoplasm, resembling esophageal cells. These also were large cells, and some of the cells showed cytoplasmic granularity. So cytology diagnosis was high-grade carcinoma. But then here we saw two-tone cytoplasm along with cytoplasmic cells. So both point to esophageal cells. So the differential diagnosis of malignant mesothelioma. Now, mesothelioma to diagnose on cytology is very difficult. It has to be really correlated with clinical presentation and radiology. The malignant mesothelial population includes multiple lesions, intercellular windows, cell arrangement, peripheral plaques, clusters, knobby outline. And I think immunocytochemistry is important. It should be positive for one mesothelial cell marker and negative for all adenocarcinoma. Now coming to surface plaques. Our case showed surface plaques, and these are long complex microvilli on the surface of malignant cells. Usually it is malignant mesothelioma, and sometimes it is of diagnostic. But such surface plaques or microvilli are also seen in metastatic ovarian carcinoma. So here we have a mesothelial cell showing ruffled border or surface plaques, and this is our case showing surface plaques. Now two-tone cytoplasm is said to be feature of mesothelial cell, and in this case we also saw two-tone cytoplasm in some cells. So we prepared cell block and carried out Cal-retinine, which was negative in the malignant cells, occasional cell positive made of esophageal, but then P63 was very strong positive in viable malignant cells. So here, because of immunocytochemistry, we come to diagnosis of squamous carcinoma, and we gave diagnosis ISC diagnostic category 5 malignant cell C and cell block immunocytochemistry, it is squamous cell carcinoma. On CT scan, which was further carried out in this patient, they saw a enhancing circumferential wall thickening with endoluminal mass in distal thorax in esophagus, which suggested esophageal carcinoma. They carried out a biopsy, and it was squamous carcinoma esophagus. Coming to next case, pleural fluid in 54-year-old female. She was a known case of carcinoma breast. With MRM done 2 years back, she had taken 4 cycles of chemotherapy. She presented to hospital with breathlessness grade 1. On X-ray case, there was bilateral pleural. And these were the cells seen on in suction. If you compare the size of the cells, you can see that these are intermediate size cells. They are not very large. Most of the cells have eccentrically placed cytoplasm. There seem to be some cytoplasm, vacuoles in the cytoplasm. They still show some ruffled borders. This is another image showing cells, intermediate size we saw. Then here we have one binucleate endothelial cell, and this is one of the cells is laid out here where nucleus is being touched. Some macrophages are seen in the background and endothelial cells. This is Pactin smear of the same case now, and without the intermediate size cells, it was seen with eccentrically placed nuclei, cytoplasmic vacuoles. Here you have one endothelial cell which is fine. Now here you can see that endothelial cell has almost that of the atypical cells. Apart from these two cells, you can also see cells with necrotic nuclei, and these are necrotic cells with necrotic. Again, those intermediate size cells, here you can see their features very well. More ruffled borders, nuclei with different nuclear membrane, coarse chromatic, cells with necrotic nuclei. I have identified as necrotic cells. Again, it's a here you can see a triangular endothelial cell, and these are the intermediate size cells. So what was the cytology diagnosis? We gave it as positive format. Why? Because of nuclear morphology of those intermediate size cells and presence of necrotic cells. What was the diagnostic difficulty? The cells which were intermediate size had a fuzzy border, and because of this fuzzy border, they resembled mesothelial cells. And the mesothelial cells, though I could identify some mesothelial cells, they were almost similar in shape. All these cells were medium-sized cells. Some showed intracytoplasmic mucin, which is seen as pink blobs in the cytoplasm. Again, intermediate size cells we saw is the mesothelial cell, and the other intermediate size cell. But here we carried out cell block and gave immunocytokine. We did calculating, and it was hopefully positive. Most of the cells were negative for calculating. ECDSP 15, which was done on the cell block, was very strong positive in most of the cells, suggesting malignancy of the breast primer, malignant effusion of breast primer. So calculating was seen in occasional cells, suggesting mesothelial cells in the background. ECDSP 15 was strong positive in most of the cells, suggesting breast carcinoma cells in the egg. The previous diagnosis in this case at the time of MRI, histopath diagnosis, was globular carcinoma of breast, and this explains the intracytoplasmic mucin seen on Gill cells. So, what was the diagnostic difficulty? The malignant cells were medium size. The size was similar to mesothelial cells. Now, this type of cells, medium size cells or intermediate size cells, are mammary, gastric, pancreatic, lung, and prostatic malignancies. This small size makes these tumors a more difficult group of tumors to identify on fluorescence. So, medium size tumor cells is the most important source of error leading to false negative diagnosis, and this has been. Coming to next case, case 6, 40-year-old female had a cytology. We examined the cytology fluid. This is Pactin smear. It shows a cluster of cells with abundant foamy cytoplasm and nuclei showed prominent effusion, NC ratio is not high. Similar cells on Ginsburg test homey cytoplasm. Again, this is another image from the same case. You can see small clusters and dissociated cells. Now, what are these cells? Are these macrophages? Cells had abundant granular and finely naturated cytoplasm like macrophages. They had spherical bland nuclei with prominent proteases, but they were sealing sheets. Macrophages are not sealing sheets. So we prepared cell block and we carried out immunocytometry. And it was 10 positive. Unfortunately, I don't have the image of this case. This patient was a known case of renal cell carcinoma. We gave diagnostic category 5 malignant cell C and cell block ICC suggesting or favoring renal cell carcinoma. This patient had multiple organ metastases and ascites, but malignant ascites in renal cell carcinoma is extremely rare. So this case I have put because of the cell morphology, which looks like macrophages and can be easily mistaken, and it can go as false negative diagnosis. Metastatic carcinomas in effusions are seen very often. Effusion cytology provides a higher field of cells than biopsy of the serous. So it is preferred. Clinical history helps in proper trials along with appropriate processing. After detection of malignant cells, primary site can be located with help of clinical tests, radiological images, and immunocytometry. Diagnostic pitfalls are false positive diagnosis can be up to 0.5% and false negative diagnosis is very high, up to 30%. So you have to prevent this false negative and false positive diagnosis. The diagnostic pitfalls are because of surface tension related cell alteration. So spindle and polyhedral cells also will become rounded. You have to prevent improper specimen processing. You have to be aware of many phases of reactive mesothelial cells and proliferation related features like cell bodies. Degenerative changes have to be avoided and if present have to be detected. Unexpected patterns and unusual entities like polymorphic lymphocytes, three-dimensional benign cell groups, megakaryocytes also have to be identified and false positive diagnosis. The concept of effusions in malignancy along with increased capillary permeability, sometimes lymphatic blockage, where you can get chylous effusions. Low-grade sarcomas and spindle cell mesotheliomas do not exfoliate in the serous fluids and cannot be detected. Non-exfoliation is sometimes a due to layer of debris which is present on the serous surface. Neoplastic cells initially are more in number, but they decrease over time and are not seen later in the long-standing effusions. In cases of negative results in suspected malignancy, you need to repeat fluid cytology for accurate diagnosis. Serous effusions is an appropriate sample for surface marker flow cytometry. So whenever lymphomas are suspected, the serous effusion can be subjected to flow cytometry and it helps in diagnosis of and sometimes based on microscopy has a role in differential diagnosis of malignant mesothelioma from metastatic adenoma along with immunocytometry. So in effusion, samples to be processed without delay. Smears have to be made from cell button, which is obtained after centrifugation, or you cytospin the fluid to make cytospin smears which are of better or superior quality. Both PAM and Ginsburg stain things how to be used. Cell block, how to be prepared wherever necessary if you suspect malignancy. Immunocytochemistry can be carried out on cell blocks and also on cytosine spheres. And flow cytometry can be carried out on effusions wherever you suspect hematopoietic neoplasms. Thank you.
The lucid presentation, Dr. Naik. Comments from Dr. Gupta and Dr. Kolte ma'am. Dr. Nalini Gupta ma'am.
Yes, am I heard?
Yes, ma'am.
So first of all, I would say thanks to the organizers for giving me this opportunity to be part of this session. And thanks to Dr. Leena for exhaustively covering the morphological aspects of effusion cytology, which are actually very important for at the postgraduate level. I have actually given some of the panels which we routinely use in our effusion cytology, and we use for all our fluids we use SurePath LBC. So for us it is 1 mgg and 1 LBC slide, and we've seen that with after introduction of LBC, our false negative rates have reduced because it leads to a lot of cellular concentration and hemorrhagic smears are taken care of by LBC. All effusions which are lymphocyte-rich effusions, we subject them to flow cytometry, one to differentiate lymphomas versus tuberculosis, and then to subtype the lymphomas. And we've seen that especially these DLBCLs and buckets and then T-cell lymphoblastic lymphomas, they're very easy to diagnose, and you can actually give a proper diagnosis, proper subtyping on effusion sample, which is helpful for the patient also. And the treatment can be started because these TLBLs they are actually sometimes emergency kind of thing because they have superior vena cava obstruction kind of thing going on. So with that, maybe I think Dr. Neelam can take over.
Thank you, Doctor. But you have also covered details about your experience. We in AEM hospital also get a lot of effusions and along with PAL and all this, and we routinely perform cell blocks, not after we detect some abnormal cells, but routinely. And we are slowly shifting to liquid-based cytology as well. So thank you, Dr. Naik, for your lucid presentation. Thank you. If there are any questions, you can answer. Dr. Joshi?
Yeah. So I guess there are no questions from people, so we can move ahead. We have a small film from the sponsor, which we'll display now, and then we will, because we have few minutes to gear up. Till then.
Aparna, can we begin with the next session?
I am sorting that out. We are going to do this 15 minutes ahead of time. That's why I was.
Utilizing cell enrichment, but designed for the low throughput laboratory. 3D SurePath direct to slide is a very simple procedure.
Bhagyashree, I will now like to request you to call upon the next event, for which we will like to invite Dr. Pinto and Dr. Girish Krishnan.
Aparna, we'll begin with the next session.
Yeah, we are inviting Dr. Pinto and Dr. Girish Krishnan to chair the session, and I request you to introduce them. This is a KB Nafadkar Memorial Oration going to be delivered by Dr. Meherbano Kamal from Nagpur.
Dr. Girish Krishnan is an alumnus of BJ Medical College and has also completed his MD in pathology from the same institute. After a short stint in the Department of Pathology at BJ Medical College, he started his own laboratory, Prerna Laboratories, and is currently consultant pathologist here as well as at Shashwat Hospital, Aund. His areas of special interest are gastrointestinal pathology and genitourinary pathology, and he is trained at CMC Vellore for the same. He has been the secretary of the Indian Association of Practising Pathologists, Pune, for 3 years, and he has been the organizing secretary for a national CME in surgical pathology hosted by IFPP. Welcome, Dr. Girish. Our next chairperson is a renowned academician, researcher, administrator, UG/PG teacher, and consultant pathologist from Goa, Dr. R.G.W. Pinto. He is Dean, Faculty of Medicine at Goa University and Professor and Head of Department of Pathology, Goa Medical College, Goa. He has been Chairman, Moderator, and Faculty of International Conferences of IAC, that is International Academy of Cytology, European Federation of Cytology Societies, and Asian Society of Cytopathology, and Indian Academy of Cytologists, held at almost many countries in all the continents like USA, UK, Canada, Australia, China, Belgium, Croatia, Turkey, Greece, and the list is endless. He has organized many international and national CMEs and conferences in India and abroad. He has many publications in national and international journals. He is a well-known UG/PG teacher and loved by all his UG and PG students. I welcome Dr. Pinto as a chairperson for this KB Nafadkar Memorial Session. Dr. KB Nafadkar was an ex-president of Indian Association of Practising Pathologists for 20 years. He is one of the founder members of the IPP. He was departmental head of microbiology at KEM Hospital, Pune for 30 years. He presided of IRB of the collaborative project of John Hopkins University and Sassoon General Hospital on HIV and tuberculosis. He is a prolific researcher, authored more than 50 research publications in national and international journal, and he is a co-founder of Art Circle of BJMC. So can I have a speaker slide, Aparna?
Yes, it's coming.
Today's speaker for Dr. KB Nafadkar Memorial Oration is Dr. Meherbano Kamal. She is Professor and HOD of Department of Pathology, Government Medical College, Nagpur. She is trained in cytopathology from AIIMS New Delhi. She has more than 36 years of teaching experience. She is past president of Indian Academy of Cytologists in 2016. She is a national editor of Acta Cytologica from 2020 to 2022. She has over 50 publications in national and international journals. She is editor of Monograph and Atlas of Uterine Cervix Cancer and TBS She has contributed chapter in the book of colposcopy and cervical cytology in gynecologic practice by Dr. Usha Saraiya. She has research grant for cervical cancers from ICMR, Chitanvis Trust, INCLAIN Philadelphia, and ICMR again. She was convener for national and state level conferences, symposiums, and workshops in cervical cytology for over the last 20 years. And she is a faculty for government recognized course in cervical cytology and colposcopy at Kama Hospital, Mumbai. I now request Dr. Kamal Madam to begin her talk. Thank you.
Aparna, you're going to project it?
Yes, ma'am. We are going to have, Madam is going to present interesting cases and her journey over the last more than 50 years and her experience. So we will have case by case videos. There are 5 videos and it's going to be very interesting. And we begin now.
How can I be on the screen on the side? I've put on my video. Should I share? Can you see me on the screen?
Not
in the
yet.
corner?
Not yet. I will ask Vipin. Okay, we'll try to display her there.
Okay, you can start that.
And we can see you now.
Okay.
Okay.
Thank you for the kind introduction. Respected chairpersons and office captains, I'm deeply honored and grateful to the organizing team of Association of Cytologists of Maharashtra, and especially Dr. Aparna for giving me the opportunity to share a few interesting cases as a part of this Dr. Nafadkar Oration. These stalwarts in the field of pathology have left back a legacy to be remembered and followed by us. Friends, it was a great dilemma for me as to which cases I should be sharing. Should they be rare ones or should they be the ones that really taught me a lesson? Something which is difficult for me, maybe a cakewalk for pathologists working in a high turnover laboratory or higher institutes. That which perplexed me 30 years back is relatively easy for me today. So what I have done to come out of this dilemma is that after every case, I will be giving a reason as to why I selected this particular case and what were the pearls of wisdom that I've collected during 40 years of my career in cytopathology. Now coming to the first case, this is a 58-year-old presentation bleeding TB. She had a past history of CA breast with axillary nuclear and in the liver. USG guided FNAC from liver nodule show cytologic features of metastasis of ductal malignancy. As to diffuse radical mastectomy, with actual pathologies. The excisional biopsy had this immunoprofile, ER negative and HER2 hotspot. After 2 months of chemotherapy, she had the complaints of bleeding, PV, and birth speculum one by one spiral growth, and it was present in the cervicovaginal region. That is what they told us, and a pap smear was taken. The smear showed abundant inflammatory in a dirty background, along with around hyperchromatic cells that were seen in syncytial clusters. There were discrete cells also, and they were small to medium in size, with high NC ratio, and cytoplasm was very scanty. Nuclei were hyperchromatic, and the chromatin appeared very slippery, and the nucleus was indistinct. We thought we saw some tubules or tubular arrangements of these cells as cases because we had in the mind that she was a known case of CA breast. Some dysplastic cells were also seen there and there in the smear along with these malignant cells. The cervix is a less favorable site for metastatic disease from an extragenital malignancy because of its small size, composition of mainly well cytomuscular components, restricted blood supply, and an active lymphatic drainage channel. Consider a metastatic cancer, and still be considered a metastatic cancer in the differential diagnosis. HSI, yes, in a country like ours, where there is a lack of awareness regarding regular screening, it would not be surprising if the patient was harboring HSI or squamous cell carcinoma of the small cell type. And of course, a poorly differentiated malignancy was also entertained. Although not indicated, HPV DNA test for high-risk viruses was done, considering that this could be carcinoma of the cervix, and to our surprise, the HPV DNA test was negative, and this was alarming. However, the oncologist continues with the cycles of chemotherapy. After 4 extra cycles of chemotherapy, the activity in small hepatic nodules significantly decreased in size, but the cervicovaginal growth continued to increase in size, so much so that the patient now complains not only of bleeding but also a mass protruding from the introit. This is how the mass looked like, and it seemed that the mass was not responding to chemotherapy, and a wide local excision of this mass was done by the surgeon. The histopathology of the growth comprised of solid sheets of monotonous looking round cells separated by fibrocollagenous tissue that divided the tumor tissue into irregular masses. Light and dark small round cells and that was uniform were seen with indistinct cell borders. The cells had a high AC ratio and rosette-like arrangement. Rosette-like arrangement was seen at bases, and peripheliomatous hypercellular areas were also seen. The chromatin was fine and stippled, and nuclei were inconspicuous. There were no malignant squamous cells. Due to the primitive character of the malignant cells, we kept it basically as a malignant round cell tumor. It could be a small cell neuroendocrine carcinoma of the cervix or a small squamous cell carcinoma of the cervix, a small cell type, and we advised immunohistochemistry. Epithelial markers like the pancytokeratin and EMA were negative, ruling out squamous cell carcinoma, and other tumors were also ruled out. And to our surprise, WIT2, that is CD99, was positive, and Wyman2 was positive. And with this, we labeled this as extraosseous living sarcoma, PNET, of the cervicovaginal lesion. And it is seen to be a synchronous double primary malignancy. The incidence of synchronous double primary malignancy is pretty low, and it is rare, and it is to the tune of 0.3 to 4.3%. The second primary lesion is identified either when it is identified either simultaneously with the primary lesion, then it is known as the synchronous malignancy, or after a period of time, it is known as the metachronous malignancy. Living sarcoma, PNET of the genital tract of women and that too of the cervix is extremely rare. Only 14 cases have been described between the period between 1987 and 2015. There is still its occurrence in the cervix as the second malignancy in the complex of multiple primary malignancy. CA breast with synchronous or metachronous malignancy of the endometrium is the most common combination, and followed by CA breast with cancer of the ovary, stomach, rectum, and oral cavity have been reported. CA breast and squamous cell carcinoma of the cervix are known to occur as synchronous malignancies. Association of CA breast and PNET of the cervix as synchronous double primary malignancy has not been reported in the literature until we published this case. In the treatment strategies, the victim is treating the malignancy that is more advanced first, or sometimes both malignancies could be treated simultaneously if the chemotherapeutic agent is sustained. In the follow-up of this patient, after 2 months of removal of the vaginal growth, the patient developed liver failure and pulmonary complications, and she succumbed to her cancer. This, as to why I presented this case, this was the first time when in a pap smear I saw cells that did not have origin from the female genital tract. I have reported a variety of ovarian tumors and the uterine tumors in the pap smear, but never seen cells out of origin from this SGD. This gave me a knee-jerk reaction. Nonetheless, in a country like ours, where there is lack of awareness regarding regular screening, it would not be surprising if the second family in this case would have been a carcinoma cervix. But surprisingly, it was a female. At times, when the cells do not fit in a particular pattern, one may see a slide with closed eyes and an open mouth, and forget the local entities and concentrate on the morphology. A high index of suspicion and combined with good morphology is all that is required.
Yeah. We are going to the next case, ma'am.
Yes. We can take the questions in the end, I think.
Yeah.
A 43-year-old lady came with the complaints of menorrhagia of 8 months duration and pain in abdomen. Pap smear and DNC was done. The pap smear showed such dense clusters and bundles of small dark cells in a clean background. There were a lot of cells that were also dissociated, and the dissociated cells were round to oval and showed scanty or no cytoplasm, and they were hypochromatic. Anisonucleosis and anisocytosis was minimal. All nuclei had fine chromatin in distinct nuclei, and most of the nuclei showed pointed ends, as you can see here. These are the nuclei which are showing pointed ends, and many were pendulum shaped. The first thing that came to my mind was exodus, that is normally shed endometrial and stromal cells. So I rushed for the LMP of the patient, and I found that it was 1.5 months back. Somehow the cellularity was also much greater than what one usually sees in an exodus. So we also entertained the possibility of cells shedding from a submucosal leiomyoma or a leiomyosarcoma. Hyperchromatic crowded groups or HSIL of this small cell type was also one of the possibilities. Small cell or neuroendocrine tumor of the uterine cervix was also considered, and a possibility of stromal sarcoma shedding cells onto the cervix was also considered. USG was of the pelvis was reported as large submucosal fibroids. For the sake of completion and also to know what is going on in the cervix, colposcopy of this patient was done. Colposcopy was adequate and showed a huge circumoral erosion, and an atypical transformation zone was seen, and the glandular mucosa seemed to be very hypertrophic. Her DNC specimen showed similar oval to spindle cells. We reported them as bundles of smooth muscle cells with foci of degeneration. Endometrial glands were not seen. As soon as I received the gross specimen of this patient, the specimen comprised of a well-circumscribed tangy yellow large rotary tumor mass invading the uterine muscle. Extrauterine tumor extension was not seen, and submucosal fibroids were also seen. So here you can see this yellow tan colored tumor mass, and these are the fibroids that were present. Histopath section showed thinned out and ulcerated endometrial lining and few endometrial glands. Beneath was a highly cellular tumor tissue consisting of spiral arteriole-like vessels with tumor cells whirling around these vessels. Nuclear ATP or pleomorphism was not seen. Mitotic figures were 10 high power field. This tumor tissue was invading both the endometrium and was also seen permeating the smooth muscle bundles. At times, it is very difficult to differentiate low-grade endometrial stromal sarcoma from a cellular leiomyoma, but we labeled this case as low-grade ESS. And our diagnosis was confirmed with CD10 positivity. As of here, the preoperative cytologic features of these tumors as seen in the pap smear have not been reported. However, there was a case series wherein 11 vaginal preparations in this series of 14 patients were from recurrent tumors, and cytology samples were compared to the patient's previous biopsy or resection specimens, which appeared similar, and therefore they were signed out as consistent with low-grade endometrial stromal sarcoma. In this series, the single preoperative case could not be clinched or diagnosed and was signed out as atypical cells with abundant necrosis and endometrial cells present in the smear, which was the reason for the single preoperative diagnosis of one of the cases. When I discussed this case with Dr. Ravi, who's doing a lot of cytology in the private practice, he wanted me to see the slides of one of his recent interesting cases. It was FNAC from a patient 68 years old who presented with a paracolic mass, and she had been treated for ESS 7 years back. And now the FNAC of this patient showed numerous capillaries spaces. You can see these are all capillaries, and these small tiny stromal cells which are round to oval, and they seem to be swirling and whirling around the capillaries. So the presence of capillaries was a very prominent feature in this FNAC smear, and the cells showed hardly any pleomorphism. So a diagnosis so difficult with a pap smear may be relatively easy on FNAC, because the FNAC findings of these tumors have distinctive architectural features that recapitulate the histologic features. Other cytologic features that were seen in this FNAC smear were the dissociated comet cells with tails of cytoplasm and red granules inside the cytoplasm. You can see a lot of basement membrane material in the NTG stained smears, and this basement membrane material is of the capillaries. Nevertheless, we are not sure how predictive any of these features would be for the preoperative diagnosis of low-grade ESS in a pap smear. In a cytology smear, the differential diagnosis would have to include a slew of monomorphous spindle cells, neoplasms. Dr. Ravi had done a CD10 marker on the FNAC smear, and this was positive in that FNAC smear of the paracolic mass. My point is that a diagnosis so difficult with a pap smear may be relatively easy by FNAC smear with the help of relevant clinico-radiologic findings or previous histopath reports. In the absence of hyaline stromal matrix that we saw, capillaries and comet cells with red granules in the cytoplasm as seen in FNAC specimen of these tumors, it is not easy to diagnose this entity in a pap smear. A heightened awareness of the fact that all histopathologic entities are a potential source for cytologic material may allow one to correctly diagnose or at least suggest the diagnosis of these lesions. These conditions give rise to important diagnostic pitfalls to be aware of in the pap test. The pap smear can be a continuous challenge. Once in a blue moon lesion can eclipse your diagnostic skills. Actually, cytology started with exfoliating cytology, that is the pap smear, but our familiarity, expertise, and diagnostic skills are more easily acquired when it comes to FNAC. No matter how strong is our inclination for an expertise with FNAC, this case demonstrates that there can be striking dissimilarities in the exfoliated features and FNAC findings from same entity, and this emphasizes the need for continuous training in the field of exfoliated cytology. Coming to the next case. Coming to the next. Coming to the next case. 5.5-year-old girl presented with redness of right eye, pain, and inability to close the same eyelid. Her parents gave history of trauma 1.5 to 2 years back, following which she developed corneal ulcer. In a span of 6 to 8 months after the trauma, the patient developed anterior ciliary staphylomas. The left of the ciliary body tissue on the surface of the eyeball is known as anterior ciliary staphylomas. A past X-ray of the skull showed enlargement of the right orbit, increasing soft tissue density, no evidence of destruction of bony or white membrane, no leukoporia or white pupillary defect, which is a diagnostic of retinoblastoma. Evisceration of the eyeball was done for this anterior ciliary staphylomas, and an implant or eye shell was put in to maintain the integrity of the eyeball. Histopathology of the eviscerated tissue showed a hemorrhage, inflammatory cells, and ciliary tissue. These sections were reported as consistent with the clinical diagnosis of ciliary staphylomas. The patient was almost asymptomatic for 9 months to 1 year. But again, she developed the same complaints, and this time CT scan was done, which showed an intra and extracorneal heterogeneous mass with calcified nodular lesion. Because retinoblastoma can spread anteriorly and involve the aqueous venous channels, conjunctiva and lymphatics, or invade the sclera anteriorly, this time the clinical radiologist impression was suspicious of retinoblastoma. Therefore, a transocular fine field aspiration cytology was performed, and smears were reported by a private pathologist. The smears and cell block material showed a hemorrhagic and necrotic background with small round cells with scanty cytoplasm. No obvious rosettes or pigment was seen. And overall, an inconclusive report was issued both on cytology and on the cell block, the reason being poor preservation of cells. Because of uncertain clinical and cytological features of retinoblastoma and the possibility of a foreign body granuloma due to the implant or retention of foreign body due to trauma at the beginning of the clinical history, a decision to remove the implant was taken by our ophthalmologist when the patient was referred in our hospital. And at that point of time, I was working in a rural medical college, and I volunteered to do intraoperative breast cytology. Intraoperatively, tribal tissue was seen, which appeared to be free from the sclera or vital walls and its muscles. The implant, that is the scleral support, was removed, and I prepared fresh smears from the tissue that was provided to me. A rapid accurate staining was done, and the rest of the tissue was subjected to histopathology. The smears showed abundant cellularity consisting of dissociated columnar and round cells. Plenty of acute inflammatory cells were also seen. Tubules and cords were seen lined by tall columnar medullary epithelium, and these cells were seen surrounding vitreous-like material. This is the vitreous-like material surrounded by the tall columnar cells. Such branching papillae were also seen. Multi-layering or a pseudo-stratified pattern of columnar cells was seen. No other heterologous element was identified in the smears. Sections from the same tissue showed large cystically dilated tubules lined by medullary epithelium. Presence and formation of ribbons, cords, and tubules recapitulated the primitive neural tube. These structures were lined by a single or a pseudo-stratified columnar epithelium. And these cyst-like structures contained vitreous-like material that we saw even in the cytology smear. Rosette-like structures of primitive retinal appendages were seen. The diagnosis of a ciliary body medulloepithelioma is usually promptly made in the presence of a ciliary body mass. However, when the tumor masquerades as other intraocular conditions, the diagnosis is often delayed. I got the opportunity to review the smears from intraocular FNAC. It represented only the clumps of such primitive neuroectodermal cells, and very few of these columnar or spindly cells were seen. I thought, could we have given a differential diagnosis of small round blue-cell fever? Broughton and Riverman reviewed 56 cases, and they found that up to 20% of cases were misdiagnosed and surgically treated for other conditions, and the diagnosis was delayed for up to 1 year. A small medulloepithelioma in the ciliary body region of the eye may occasionally be asymptomatic and may go unnoticed on clinical examination. Familiarity with the clinical appearance is the most reliable feature in its diagnosis. In case of unusual presentation, like in our case, and in the absence of sophisticated ancillary studies, a transocular fine aspiration cytology or intraoperative square smears are helpful in the diagnosis of difficult cases. Diagnosis of the tumor in the early stages allows proper management and avoid remediation. I could retrieve very few references on intraoperative cytologic diagnosis of ocular lesions. This was one by Effusion et al. Reporting rapid diagnosis in 45 quantitative cases wherein intraocular FNACs were performed. One of the indications for which the surgeon requested intraoperative diagnosis included unusual clinical presentations with an uncertain diagnosis, like in our case. The chapter of the eye by Marigold Burley in the textbook of Winfried's Gray summarizes that the role of FNAC in the diagnosis of intraocular tumors is reliable in terms of technique and adequacy of sampling, but the limitations lie predominantly in the interpretation of the material. A greater likelihood of misdiagnosis or false negative diagnosis occurs when material from children is being reviewed, especially by those who are unfamiliar with ocular work. This was my first experience with intraoperative crust cytology, a courageous step taken with a genuine desire to help save the vision of a beautiful girl named Hina. And this taught me that instead of missing a diagnosis or landing up in misdiagnosis, a pathologist may gather courage to choose to refuse interpretation of cytologic material from arenas that he or she has never handled before. Better not to be a jack of all and master of none. Thank you. Coming to the next case. Perhaps Coming to the next case, a pap smear from a 21 years nulli gravida patient was sent for second opinion to me. She presented with complaints of blood stain by discharge of 50 days duration, history of removal of cervical polyps on 2 occasions. The second polypectomy was done 4 weeks before when she came to me. Her speculum examination findings were there in her file, and it showed a polypoidal growth coming up to the introitus with a fleshy stalk attached to the cervix, vulva and vagina and the parametria were free. And USG pelvis was normal, showed no abnormality. And histopathology reports of the infected infected endocervical polyp when it was last excised. This conventional pap smear was collected 4 weeks after the second excision of the polyp, with the hope of some diagnostic clue as to the nature of these recurrent polyps. Smear showed inflammation and such large hyperchromatic round nuclei with or without cytoplasm. Such histiocytic giant cells were also seen, and they were in close proximity to these large malignant looking cells. Such clusters of cells with bipolar tails of dense granular cytoplasm were seen. Initially, we thought that these are metaplastic cells. But the nuclei of these cells were malignant looking. They were large, hyperchromatic, and the cytoplasm was dense, and you can see these tails of cytoplasm and a bent straw appearance. So we reported this, we knew that we were dealing with a malignant condition, but it neither appeared squamous nor granular that are common in the cervix, and it was very mesenchymal malignancy that we were dealing with. The gynecologist referred the patient to me for liquid-based cytology and HPV DNA test and colposcopy. With great difficulty, I was able to expose her cervix. Colposcopic assessment did not reveal anything abnormal except for a small polyp or a vesicle type of tissue and metaplastic epithelium, which we labeled finally as atypical transformation zone. Fortunately, we could trace and contact the pathologist to whom the last excised polyps were sent. These were in the form of 3 to 4 long finger-like tissue pieces with thick fleshy cores, and areas of hemorrhage and necrosis were seen. Let me tell you that these polyps were excised without any preoperative suspicion of malignancy. We could review the histopath slides of this patient with the pathologist had, and it showed a histopathological pattern of the sarcoma botryoides variant of internal rhabdomyosarcoma with a very cellular cambium layer beneath the endocervical epithelium. There was condensation of spindle-shaped myoblastic cells and differentiated rhabdomyoblasts beneath the surface epithelium and around the endocervical glands. Botryoid RNA is a classical triad of small undifferentiated 2 cells, and the differentiated rhabdomyoblast of different shapes like the spindle tadpole or the strap cells in a midroid stroma. And you can see the intermediate type of rhabdomyoblasts that are having a plasmacytoid appearance and or spindle configuration. These were the source of the cells that were seen in the pap smear. And a classical bent straw appearance of the rhabdomyoblast has been described in the literature in cytology books. We also did the PTA stain on the histopath section, and it showed distinct broad striations in the cytoplasm. So this was a case of sarcoma botryoides of the uterine cervix. Desmin and myogenin positivity was seen in some of the tumor cells. One of the least common sites for aderomyosarcoma in the genitourinary tract is the uterine cervix, and most of our information is based on individual histopathology case reports. And the largest series is of these original 14 cases. And a rarer still is finding the cytologic features of this tumor in the literature. I could find this single case reports. Crepe smears in this patient were taken from the recurrent polypoid mass arising from the same location of the cervix as the primary lesion. The authors reported this as non-epithelial malignant tumor. Friends, in my practice of last so many years, I've seen that many a time gynecologists use the pap smear as a diagnostic test in their difficult cases instead of a screening test. And as a result of which we will continue getting cervical cytology from rare conditions. Preoperative cytology sample or a pap smear will not be an appropriate diagnostic test in this condition. Scraping intact polyps may be a problem and may not collect cells of interest. And one can expect to get abnormal cells from ulcerated areas only. And this is simply a hypothetical situation. Unmarried girls may be sexually active in India but do not undergo a pap smear. For me, this was an unusual and difficult situation. In spite of my experience for last 25 years in screening for cancers of both in the fields and in hospital setting, I had not come across any single occasion when I was required to collect a pap smear in an unmarried girl. Friends, I believe that we do not learn from books, we learn from our patients. We go back to our books to see whether a similar patient has been included in the literature or not. So continue to publish all your good work and rare experiences. It is bound to benefit others in the future. Thank you. This is another case. A 14-year-old male came with multiple subcutaneous nodules all over the body, and he had these since last 2 years. He was HIV negative and FNAC was done. The FNAC smear showed abundant material, or you may call it abundant cellularity. And wherever the material was nicely spread, it was seen in the form of these small, round, dark looking nuclei with hardly any cytoplasm. And these nuclei seem to be arranged in a acinar or a rosetoid pattern. The smear showed such abundant material. Again, you can see plenty of these bodies or round dark nuclei spread all over the smear. We were dealing with the metastasis of blue round cell tumor or metastasis of some epithelial malignancy. So we started digging for some more history and investigations that the patient had. After interrogating him a lot, he gave past history of operation for a polypoidal nasal growth. So does this history clinch any diagnosis? Can you think of anything? And now with this history of operation for a polypoidal nasal growth, we could immediately clinch the diagnosis of rhinosporidiosis. Right, these are the spores that you are seeing. They are multiple and in thousands they were seen in the smear. Now we all know that rhinosporidiosis is a rare infectious chronic granulomatous disease caused by Rhinosporidium cepheri and Endosporidating microorganisms. And now it is thought to be caused by Cyanobacterium microcystis aeruginosa. Previously, the concept was that this, the organism is Rhinosporidium cepheri. This is a pap stain smear. Here you can see the capsule of the spores, which takes a negative staining. And in the center of each of these spores, you are seeing some globular material. We did a bar stain, and these spores were nicely highlighted. And you can also see that they are arranged in a acinar or rosetoid manner at places which, because of which we mistook it as a round cell tumor. So this was a case of disseminated subcutaneous rhinosporidiosis, and this case was an eye-opener for us also, just like this pharyngium, which is opening up to release thousands of spores. 90% cases of rhinosporidiosis have been recorded in India and Ceylon. In India, majority of the cases belong to the southern and central region. The city of Nagpur is precisely at the geographical center point of India. So much so that the monument of the 0 mile site is located in Nagpur. The Britishers used to use this point to measure the distances of various major cities, and these distances have been carved on this pillar. Being at the center point of the country, the Britishers also had a plan to make Nagpur the second capital city of India. If not a capital of India or Maharashtra, we are definitely a #1 center for cytology. And I invite you all to come to Nagpur and visit my department and our cytology section. Although the geographic distribution of this condition may be defined, but there are unsolved problems related to its life cycle. It has not been cultured till date, and it does not fulfill any of the 4 criteria laid down by Koch regarding the infectivity. Its taxonomic classification is uncertain. It has recently been classified in the taxonomic group MACyCON, which is a group of microorganisms at the boundary between the fish and the fungi. Water is an essential medium for its transmission, but its spores have not been isolated from ponds even on this effort. Microcystis aeruginosa has been isolated from water of ponds and from the round body spores by Ahluwalia et al., but this has not been accepted by the scientific community at large. The first cytologic description of Rhinosporidium was published by 49 users in 1974. That is almost 40 years back. There was a lacuna of reports, publications. Still we reported our series of 10 cases, which included this case, which was clinically suspected as basal cell carcinoma. And you can see a nodule here with rolled up edges present at the inner canthus of the eye. When we published this case series in 1995 in Acta Cytologica, this seemed to be a very seminal article in the sense that I brought forth 3 important observations and original observations that were never published before. First was, we highlighted the classical rosetting of the polymorphs around the spores. And this we repeatedly saw in many smears coming from the nasal polyps. This makes identification or recognition of the detection of the spores relatively easy in scrape or FNAC smear, somewhat resembling the splendor hypoid phenomena. Other thing was that 49 users had described some ray-like structures inside the spores, but I searched for literature, I read a lot, and I could describe the contents as 7 to 10 globular past positive material, which later on I found in the literature was glycoprotein, which gives nourishment to these spores while they are developing. Second, we describe the morphology of the developing pharyngium and its content in cytology smears. This is a trophic. These are the contents of a trophic cyst or a juvenile pharyngia, and here you can see this in the histopathology section. That this is called as a trophic cyst or a site. And these are at the 4th or 5th division. And they contain tiny multiple nuclei with condensation of cytoplasm around each of them. Trophocytes then mature into intermediate sporangia, which are larger and thicker with bilamellar walls. And these intermediate sporangia grow into mature sporangia and are filled with a large number of endospores, which are so tiny in the beginning. Thirdly, we emphasize that scrape cytology is more rewarding as mature sporangia rupture on the surface by the phenomena of being short of the egg. Now, what is this phenomena? Pressure of the growing sporangium on the epithelium leads to thinning and ultimately ulceration of the epithelium and leads to the release of spores or intact sporangia onto the surface of the polyp. Scraping with an iron spatula is more convenient, faster, less traumatic, and more rewarding rather than aspirating the polyp, which may bring out only inflammatory cells from the core of the polyp. So scrape may do the job that aspiration may fail to do. The reason for presenting this case is that it was my first international publication and it gave me a lot of professional satisfaction of contributing information that was not previously documented in the cytopathology literature. Besides diagnosis of microbes, fungi, parasites has made cytopathology very interesting and exciting, provided the cytologist knows when to aspirate, brush, or take imprint or scrape from it. The wise cytologist knows the best use of each of them. Thank you. Coming to another case, a 29-year female came with a history of shortness of breath of 3 weeks duration, cough and right-sided pleuritic chest pain, and pleural fluid was sent for cytology. Chest X-ray revealed multiple non-calcified nodules in both the lungs and also in the...
Aparna, the case is not being projected. Please load the case.
Ma'am, we are doing that.
Okay.
Coming to another case.
Can you see that? Yeah, I don't know. Ma'am, can you see that 29-year-old female?
Yeah.
Okay. With a history of shortness of breath of 3 weeks duration, cough and right-sided pleuritic chest pain, and pleural fluid was sent for cytology. Chest X-ray revealed multiple non-calcified nodules in both the lungs and also in the pleura along with pleural effusion. The impression of plain and contrast CT thorax was possibility of lung metastasis over infected etiology. The pleural fluid analysis was in favor of an exudate with high lymphocyte count. Sediment layers from the fluid showed abundant cellularity comprising both of cell clusters and balls and plenty single cells. Cannonballs or proliferation spheres and modules were seen as large cell balls with smooth community borders, and they had a very uniform, compact appearance. Where the cells were less compact, individual cells appeared oval spindle, and with a pattern recognition approach, this seemed to be a spindle cell tumor with whirling of cells. And we thought, could this be metastasis from a sarcoma? Sarcomas account for only 3 to 6% of malignant effusions, and their diagnosis frequently is made in the setting of a known primary tumor. Or could this be a mesothelioma with a spindle cell pattern that also looks like a fibrosarcoma? Literature says that effusions occur in only about 20% of sarcomatous variant of mesothelioma, and they rarely shed diagnostic cells. The clinicians did centesis twice to relieve her of her symptoms of breathlessness, and fresh specimens, cytology of fresh specimens showed additional cells with vacuolated cytoplasm, and an epithelioid appearance was seen. You can appreciate this. Here you can see the lower pictures showed vacuolated cytoplasm and the epithelioid appearance. Leaky lymphocytes were also seen in aggregates and clumps, and these look like epithelioid cell clusters surrounded by lymphocytes. All cells round up in fluids due to surface tension effects, and identifying epithelioid cell granulomas in fresh cytology is really a difficult task, and therefore the differential diagnosis becomes very wide. Surprisingly, mesothelial cells were not many, and rarity of mesothelial cells is highly characteristic of tuberculosis effusion. An exception is HIV-infected patients with tuberculosis effusion. Broadly, this seems to be a spindle cell tumor. It could be mesothelioma monophasic, or it could be a fibrosarcoma, or a well-differentiated leiomyosarcoma, or a smooth muscle tumor of the pleura. And of course, tuberculosis could not be ruled out. In difficult cases, a pattern recognition approach has also been suggested for the diagnosis of malignancy in effusion cytology. So finally, we issued our cytologic report saying that it is a spindle and epithelioid cell tumor with mild to moderate nuclear atypia, very primary, very metastatic. And we asked the patient's relative, we asked the clinicians for more clinical details. The patient's relative came to us with a bag full of reports and papers. There was a discharge card mentioning the details of history of hysterectomy 1 year ago, and grossly the uterus showed huge intramural fibroids, and histopath diagnosis of this was given as leiomyoma. We revised our cytology report and of the pleural fluid and reported this time as query benign metastasizing leiomyoma or query leiomyosarcoma coming from the uterus, or still maybe from the lung or the pleura. And we advised the review of slides and more sections on the uterine leiomyoma and biopsy from the pleural. Come what may, the patient was unable to get histopathology slides and blocks on one hand, and on the other hand, the oncologist wanted a tissue diagnosis before starting any treatment. Meanwhile, the clinicians did a biopsy from a pleural node. Unfortunately, the biopsy was very tiny and it showed very few spindle cells, and the material was not enough for immunohistochemistry. I have a very strong team of IEC certified cytotechnologists. We restained the H&E slides of the fluid and did a Masson trichome stain on the fluid smears and got beautiful and convincing cytoplasmic positivity. Red staining of the cytoplasm, this just told me that the cells were of muscle origin, but the dilemma regarding its benign or malignant nature could not be solved. And very reluctantly, we told a clinician that this seems to be a case of benign metastasizing leiomyoma. After a month and a half, from the blue, the patient came to me with some blocks and slides, out of which one block, there was only one block which was from the uterine leiomyoma, and she also told me that the gynecologist and the oncologist have not yet started treatment for want of a final diagnosis based on IHC. The single section taken from the leiomyoma showed bundles of spindle tumor cells traversing and infiltrating the benign uterine smooth muscle bundles. The tumor areas were highly cellular. As you can see here, the cells showed mild atypia, if any, and there were 3 to 5 mitotic figures per 10 high power genes. There were such areas with clear cells, clear cytoplasm and eccentric nuclei, and there were also some myxoid areas. So with these findings, we kept the diagnosis of uterine smooth muscle tumor of uncertain malignant potential. Stump are uncommon tumors. They are classifiable by current criteria as unequivocally benign or malignant. And conventionally, a diagnosis of leiomyosarcoma is made when two of these three criteria are met, namely CTCN, that is the coagulated tumor cell necrosis, diffuse cytologic indication, and mitotic index of more than 10 mitotic figures per 10 high-powered fields. The seminal work of Bell et al. Included 213 problematic uterine smooth muscle neoplasm, and he says that out of these three univariate predictors, the CTCN comes out as the best separating feature between benign and malignant tumors. CTCN was also seen, here you can see it, and was characterized by geographic margins and a sharp interface between viable and necrotic cells and irregular angulated or geographic border and presence of epitotic nuclear debris at the interspace as against the granulation tissue in an extensive necrotic area. In this review article regarding the prevalence and occult rates of uterine leiomyosarcoma, the authors claim that the incidence of overall uterine leiomyosarcoma is as such low, but the proportion of unexpected uterine leiomyosarcoma is as high as 46% of all the uterine leiomyosarcoma cases. IHC was done in our patient, and the tumor cells showed patchy immunoreactivity for all these smooth muscle markers. Quantitation of IHC positivity is important. If the tumor is benign, there is uniform and strong positivity in all cases. Use of Ki67 and P53 can help stratify the diagnosis. When this patient came to receive the final report with IHC, she had one more CT of the abdomen, and that was advised by her oncologist as a part of complete workup before chemotherapy. It showed multiple nodules all over the peritoneum, and that it seemed that the disease had spread all over the peritoneum. Our final impression on the histopathology, single cell block was smooth, very smooth muscle tumor of low malignant potential, leiomyosarcoma, well differentiated. When I last called this patient, it was her brother who received the call and informed that she was on respirator. He sounded very bitter at the misdiagnosis, delaying diagnosis, and frustration about the cost of treatment. In the pursuit of professional excellence, generally IQ overshadows our EQ. But with this patient of mine, I had developed a special emotional bond. Empathy and sympathy brought me close to her family and filled me with disappointment and helplessness. This case represents an undersampled leiomyosarcoma. Hysterectomy specimens may be the bread and butter of practitioners claiming to be histopathologists, but following standard operating protocols is crucial. Knowing a little but knowing it well, the very definition of a specialist, is the key to success and diagnosis. Thank you.
Thank you, madam. That was very interesting. They really were pearls. The session is open for discussion for the chairpersons and for any question answers.
Hello, Dr. Meherbani. I'm Dr. Krishnan.
Yeah, hi.
Thank you for this wonderful talk. You have truly brought out all your years of experience to the fore and have presented some really unusual cases. And I must say the picture quality of the photomicrographs were fantastic.
Thank you.
At the outset also, I would like to thank the organizers for giving us the opportunity to chair the session. Are there any questions? And Dr. Pinto, your comments, please.
Good afternoon.
Hello, Dr. Pinto.
I must say that Dr. Kamal had a very elegant and elaborate and very spectacular cases of a very wide gamut of lesions and very wide gamut of sites. and she did it very nicely, taking all things into account, the clinical, the histories, the special stains, the lot of literature, and sharing her experience, like with double primary malignancies, as well as inflammatory lesions, as well as the cervical lesions. And I'm sure that these pearls of wisdom
We can't hear your voice.
Can you hear? Could you hear?
Yeah,
now we
it's
can.
breaking. It's breaking a little.
Thank Dr. Aparna Joshi for giving and to chair this very prestigious Dr. K.B. Nafadkar Oration. So once again, it was an excellent presentation of cases, Dr. Kamal.
Thank you, Dr. Pinto.
Yeah, and Dr. Joshi, also a very nice organization of this MACyCON.
Thank you, sir. Thank you very much. It's end of the day, but we are very, very inspired. And Madam, if you have any comments to make from your side.
Yeah, I think everybody can hear me.
Yes, Dr. Kamal. Yes.
The only thing, I can't see myself. That's it. I'm unable to do that.
No, we can see you. Yeah.
No, I'm very thankful to Aparna and the whole executive committee of MACyCON, and of course all the participants who have been kept hanging till the end of the session. And it was a pleasure discussing and sharing my cases with you. So I would request on behalf of the executive body of MACyCON that all of you please try to become life members of Association of Cytologists of Maharashtra, so that we can enrich it more and more in the coming years. Thank you. Thank you so much.
Thank you.
Thank you.
Thank you. Thank you, madam.
Thank you, ma'am.
Yeah. Thank you. Bye.
We convene tomorrow again at 10 o'clock. And I would like to open put an open question if there is any arrangement for GPM or ACM, and if a decision is made. Dr. Sanklecha was saying that he is going to have one arranged in person in coming sometime. So if it is there already decided, I will like to declare on this forum. Otherwise, I'll declare tomorrow.
Okay, we'll try to talk out the matter on telephone and let you know by tomorrow.
Yes, ma'am. Okay.
Later.
Have a good evening, all of you.
Yeah, bye.
Thank you.
Next time we will have a nice banquet.
Thank you.
Yeah.
Thank you, Bhageshri.
Yeah, bye, Aparna. Thanks a lot.
We should do more.
Yeah, see you tomorrow.
Yeah. Thank you. Thank you, Dr. Pinto.
Thank you. Most welcome.